Good morning, one and all. ಶುಭೋದಯ. ಇಲ್ಲಿ ಉಪಸ್ಥಿತರಿರುವ ಎಲ್ಲರಿಗೂ ಹೃತ್ಪೂರ್ವಕ ಸ್ವಾಗತ. ಯತ್ರ ನಾರ್ಯಸ್ತು ಪೂಜ್ಯಂತೆ ರಮಂತೆ ತತ್ರ ದೇವತಾ ಯತ್ರೈತಸ್ತು ನ ಪೂಜ್ಯಂತೆ ಸರ್ವಸ್ತತ್ರ ಫಲಕ್ರಿಯ, which means where women are honored, divinity resides. Where they are not honored, every action becomes fruitless, which emphasizes the theme of this conference, Swasth Shakti Samriddha Samaja, which means healthy women leads to a prosperous society. It gives us immense pleasure to welcome you all to this day 2 of this prestigious 35th KSOGA annual conference. Let us come together with enthusiasm, curiosity and the spirit of learning. Let's begin the first session today. The first session is Samuha Charche, that is panel discussion. Welcome to the ultimate brainstorm session, and the topic is obstetric emergencies. I welcome Dr. Moderator of this panel first, Dr. Kasturi V. Dhonimat Madam, Director Tattvadarsha Hospital Hubli and past President KSOGA and HOD of KIMS Hubli. We welcome you, Madam. Please someone guide, no? Guide madam. I welcome our next moderator for the session, Dr. Udayashree Urkara Madam, Associate Professor, Department of OBG, Secretary, Hubli Dharwad Obstetrics and Gynec Society. We welcome you, Madam. Now I welcome our panelist for the session, Dr. Prakash Biranoor sir, Consultant and Director Vedika Fertility and Maternity Center Hubballi, Dr. Purnima Patil, Assistant Professor and Consultant at Sujani Hospital, Dr. Pooja R, Consultant Obstetrics and Gynecology, CEO at CGS Hospital Chalkere, Dr. Madhushri, Assistant Professor, Sridevi Institute of Medical Sciences, Tumkur. And I may now invite our expert for the session, Dr. Munikrishna M. Sir, Head of the Department, DIMS, Kolar. I also invite our panelist, Dr. Basavaraj Kolli sir, to the dais. Welcome you, sir.
I think some confusion. I'd like to invite Shirley George ma'am. She is ex-HOD of St. John's Medical College and at present consultant at Chinmaya Mission Hospital. She is an expert in this panel. Welcome ma'am.
Over to the moderators.
Tondrila ma'am, we have started on time. Very nice. Come on.
I thought I'm the panelist.
You are the expert ma'am.
Expert, not panelist.
Expert panelist.
Expert panelist.
So, pleasant morning to one and all. So, first of all, I thank the organizers of Tumkur OBGYN Society, Dr. Durgadas and his team, Dr. Rekha, for giving us this opportunity to conduct this panel discussion. So, with me, I have Dr. Udayashree, Secretary of OBGYN Society, to conduct this panel. And we have panelists, Dr. Basavaraj Kolli, Dr. Prakash Biranoor, Dr. Pooja, Dr. Purnima, Dr. Madhushri. So we have very expert panelists to discuss the cases, and we have very renowned people, experts Dr. Munni Krishna and Dr. Shirley Josh, madam, for this, as an expert for this panel. So today we'll be discussing on obstetric emergencies. So this is a very, very important topic. I know these are all very critical cases. We'll discuss in detail, we'll see how we can save their lives. But I wish that no woman should face these emergencies, and also no obstetrician should face these complications. So with that, we'll start with the panel. So we'll be discussing 4 cases. And so since we have 45 minutes, we'll keep 10 minutes for each case. We'll keep it as short as possible. So we have even made the cases very short presentation. Yeah. So the first case, so I'll ask Udesh to read about the first case.
Yes, ma'am. Good morning, everyone. Case 1, a 30-year-old primigravida, low risk with normal vitals, undergoing induction of labor at 40 weeks. And after an artificial rupture of membranes in active labor, the patient complains of sudden breathlessness and anxiety. A minute later, she experiences a tonic-clonic seizure and collapses. The fetal cardiotachograph shows terminal bradycardia. She is hypoxic. So what is your diagnosis?
Dr. Basaraj can. It's working. Mic on somewhere?
As you see, the case is going on. It is a case of amniotic fluid embolism. It is a rare case, but catastrophic condition which occurs during labor or immediately after labor due to the exposure of antigens, mainly the fetal components or the amniotic fluid enters into the maternal circulation, causing catastrophic effect, and there is a cytokine storm resulting immediately after delivery of the patient.
Yes, sir. Exactly. It is more suspicion of amniotic fluid embolism. So amniotic fluid embolism is not actually the embolism in the veins or the arteries. It is the reaction, immunological reaction to the cytokine storm which occurs to the amniotic fluid debris or the fetal debris which enters the circulation. So that's a reaction more than the embolism. And any differential diagnosis, Prakash?
Any obstetric emergencies like pulmonary embolism, even the severe eclampsia and uterine rupture, all these are differential diagnosis for the amniotic fluid embolism. But we have to differentiate in pre-eclampsia and all pre-eclampsia and eclampsia we have a hypertension. Yes. And in postpartum hemorrhage also the differential diagnosis. In postpartum hemorrhage we have bleeding and all those things. And here in amniotic fluid embolism there is a coagulopathy is the main differentiating factor for the amniotic fluid embolism and other than the pulmonary embolisms and other conditions. Yeah. Here the cardiac arrest will be there, then the sudden collapse, cardiorespiratory arrest and conjunctive coagulopathies, and it occurs after the procedures after the labor, like intrapartum procedures like artificial rupture of membranes like this in this case, and after the delivery and even during the cesarean sections, all these triads, and these are the differential diagnoses.
Yes. So anything that causes sudden maternal collapse can be a differential diagnosis for that. So amniotic fluid embolism is a more of a diagnosis after exclusion. So after we have excluded all these cardiac causes, cardiomyopathy, eclampsia, whatever, sepsis, so pulmonary embolism, so it's more of exclusion. The diagnosis we come to a conclusion after excluding those causes. So the diagnostic criteria here are patient will be in sudden hypotension, some sudden cardiac arrest. We are not able to explain sudden cardiac arrest, sudden hypotension, sudden hypoxia, and then if you resuscitate, if they survive, they end up in coagulopathy. So this is a basic diagnosis. And usually, as he told, it is surrounding those procedures, whether it is suction evacuation or cesarean or labor or within 30 minutes. In that period, if it is there, this event, sudden collapse, then we should suspect amniotic fluid embolism, or if we are not able to explain the other causes. So any experts from the, comment from the experts?
Okay. So in the differential diagnosis, anaphylactic shock also should be considered. As Madam said, any maternal collapse in that, whatever the reason. And also it is noticed that 70% is during vaginal delivery, only 19% after cesarean, and immediate postpartum 11%. That's the incidence.
And also amniotic fluid embolism can present with straightway with coagulopathy. Need not be with cardiorespiratory arrest or something, collapse. We have seen in the practice actually, they, while doing cesarean section, they go for DIC and PPH. Only retrospectively we have to think of amniotic fluid embolism. Can present as a coagulopathy itself as a presentation.
So though we know what are the diagnostic criteria, to make it more objective, the SMFM and AFI Foundation have given diagnostic criteria to help in making diagnosis more objective. So here they are considering the sudden onset of cardiopulmonary arrest or hypotension, which may present as systolic pressure less than 90 mm, or with evidence of respiratory compromise. It can be dyspnea, cyanosis, or desaturation, all occurring within 30 minutes of the incident event. And then documentation of overt DIC, they have given a scoring system for this, where they have considered the platelet count and PT and INR, and depending on the platelet count, they have given points of 0, 1 and 2, and like how bad the thrombocytopenia is, and also for deranged coagulation profile, that is prothrombin time and INR, so less than 25%, 0.25 to 50, 1 and more than 50 as 2, and then they have considered fibrinogen levels also. So to make it more objective, they have given it a scoring system. And coagulopathy should be detected before hemorrhage itself can account, because we know PPH also is a differential diagnosis for amniotic fluid embolism. And patients, because they will be delivering, they will be having bleeding there. So that time it will be confusing picture. So coagulopathy, if occur before a hemorrhage itself, can account for the DIC. More likely it is amniotic fluid embolism and not PPH as the cause for DIC. And yes, clinical onset within 30 minutes of the incident event, and absence of fever, because in presence of fever also they can have such problems. Thank you.
Risk factors for amniotic fluid embolism, Pooja.
Risk factors are placenta previa, abruptio, anything which causes obstetric hemorrhage is itself a risk factor, and patient is in prolonged labor, or cesarean, if you do a artificial rupture of membrane and decide for immediate cesarean section, during cesarean she collapses. So that also is one of the factor. Then when we apply instruments like vacuum delivery or forceps delivery, other risk factors are if she is having severe hypertension or eclampsia. So these are the risk factors.
So the risk factor should be considered, like if the venous pressure in the uterine vasculature is more than the systemic venous pressure. So when that pressure is more, there is more likely that the amniotic debris and the fetal debris enter the main circulation. One is weather. So those where there is increase in the intrauterine venous pressure are when you induce labor, especially when there is hyperstimulation or when there is precipitate labor, eclampsia, in these cases where it's increased. So this is where. Or one more thing is where there is breach in the continuity of the venous. So where in placenta previa, abruptio placenta, any lacerations during delivery, C-section also we can have the breach in the vascularity and instrumental delivery. So these are the main. So these two things you should come in when it.
And many times, if amniotic fluid embolism occurs in the setting of a cesarean section, usually we miss the diagnosis because anesthetist is there. He will start resuscitating. Differential diagnosis can be anaphylaxis because many drugs have been used for induction and anesthesia. And also it can be an anesthetic complication also. Like whatever it is, resuscitation is the same. So measures are taken and prompt resuscitation occurs, because the team is alert and ready for it. So many times AFE occurring in the setting of cesarean section usually will miss the diagnosis also. That is one thing we should always remember.
Yes.
Madam, excuse me, madam. Does mucosal stent like is a high risk for amniotic fluid embolism, madam? meconium strain like
Meconium strain like, yes, yes.
and prolonged labor also,
Yes,
madam.
yes. Yes.
Madam, how many cases you have come across in your practice, madam, actually? Because I have not come across any case in my practice.
We have seen lots of cases, amniotic fluid. Even after delivery, suddenly patient just collapsing. Baby has come out and patient no pulseless, breathless. We have seen cases like that. We have just delivered the baby, but if you see there, mother is totally hypoxic, cyanosed and hypotension, pulseless, breathless. Many cases. Even after delivery also, suddenly we see patient is bleeding and she has gone into shock. We are thinking whether it is PPH, but it turns but at the same time she is having severe hypoxia and cyanosis that lands more towards amniotic fluid embolism than PPH as the cause. So that way we differentiate, but very difficult to, I'll come to that, how to diagnose.
And one more thing I wanted to say. The patient is so restless. She has air hunger sort of thing, no? That is very, very typical. She will just say that something is happening to me, I'm very restless, and then she just collapses.
Yes, that is the first symptom. Very restless, she doesn't know what she's doing, even the people around, and suddenly, and not much difference, next second only she's collapsed.
She will collapse.
She complains and next second she collapses. We have seen like that. Quite a number of cases. Signs and symptoms?
As I already told, patient will be having severe hair hunger, breathlessness will be there, and she will be restless and chest tightness. And while sign-wise, you can see there will be the hypoxia, SpO2, that is saturation is going to be less, and anxiety, and she will develop seizures, and then suddenly she will collapse. Altered sensoriums.
So the symptoms are, as madam told, restless. She'll have paresthesia, restless, vomiting sensation, very vague, which are for and convulsions. Many patients suddenly they are not PH, nothing, no history of epilepsy in the past, but suddenly they throw convulsion and coma. And with these few symptoms only, paresthesia, numbness, restlessness, vomiting sensation, they are just telling, by the time you see, they're collapsed, and the signs will be
Cold extremities and hypotension, crepitations and bronchi, and bleeding from the venipuncture sites because of the onset of DIC, that is coagulopathy, and severe bleeding, atonicity and all will be there.
See, this patient has not yet delivered. Suddenly you start seeing this bleeding from where you have pricked everything. So you think, why after bleeding, PPH, DIC, that's okay. But and her all the parameters were normal. Suddenly if they land up in DIC without any reason, even when they are in labor, you should always think of this.
And so whenever there is a convulsions, we think of eclampsia. Maybe she started eclampsia, we think more often than not amniotic fluid embolism. Maybe probably if DAC sets in, then we can think of.
So auscultating the lungs will give a more diagnostic criteria.
And all this sudden onset of restlessness, the feeling of an impending doom, all those things can be coined under the term aura also. What we tell for before a seizure, the same terminology nowadays, the latest textbooks are using the term aura for that. So sudden onset of aura, all these symptoms can be a warning sign for us that maybe it is AFE.
Okay, any diagnostic tools? Anything to diagnose, tell 100% that it is amniotic fluid embolism?
Ma'am, there is no specific diagnostic test or any tool, ma'am. It is mainly clinical and it is made after excluding all other causes, ma'am.
Yes, I agree totally. It's only clinical and excluding the other, then we come to a conclusion of amniotic fluid embolism. No confirmatory test. Only in case if there is a pulmonary artery catheterization if you have done, and if you are able to get a amniotic fluid debris in that, then you can tell, okay, 100%. And most of the time it is when we do postmortem. Postmortem, they will, after dissecting, they may get amniotic. So it's a postmortem diagnosis rather than the patient is alive. And some experimental like fetal antigen in maternal lung, the fetal antigens, finding that is TKH2 is a fetal antigen. If they find that fetal antigen in the maternal lungs, then that is, but it's still in the very research stage, not into the practice. Again, IGF-B1 is also this, again in the research stage. And other is a chest X-ray. On chest X-ray, you will have pulmonary edema signs. And for diagnosis, DIC, whatever you have, then those diagnostics. But nothing, no test to diagnose amniotic fluid embolism. All those which I am telling you are more of into research. Okay. How do you manage this case?
Ma'am, it's an emergency. First, you have to call for help, ma'am. We have to, because in obstetrics, we should have more hands. So call for help and put 2-bore IV cannulas and fluid and see the condition, whether patient is survived or not. Sometimes collapse. If she died, we can go for perimortem cesarean section and we can deliver the baby within 4 to 5 minutes of the collapse. Or if she is survivable, that time we have to do all the other things like fluid, giving airway, securing of airway, breathing, circulation, and after that immediately delivering of the baby.
Okay. Any comments from the experts?
She's covered everything, so basically airway, secure intubation, then look after the cardio this thing arrest, if there is, so you have to follow the
Inotropes
guidelines.
and all should be
And,
given.
if after 2 cycles of compression also cardiac output has not come, then we have to think of doing the cesarean section immediately to help. That will help in the maternal resuscitation, and also it will help the fetal survival. Chances of fetal survival is more there. And management of the coagulation.
Yes,
So massive obstetric
blood transfusion should be
hemorrhage
done.
protocol should be activated. If you have cryoprecipitate, whatever, if you have
Plasma
and if your center is advanced, even recombinant factor 7A, I mean, otherwise blood and blood products.
So 5 things we have to remember this. Team approach, multidisciplinary team, airway, circulation, and because she is in a DIC, massive transfusion protocol, and deliver her. Deliver her helps in resuscitation as well as saving the baby. It will be more of perimortem cesarean section.
So
So
5 minutes is the time actually.
So this just as a summary, we'll not again go, we'll go to the next case. This is just stepwise what we have to do. We have to announce code blue in the hospital, code blue, code blue. So whole team comes. And all this which you have told, just it's summarizing how to do the DIC management, obstetric management, all, okay. So key points, ABC, all the, okay, will not go. These are all we need to manage that and how they act. We'll go to the next case. And one last question, what is the outcome of these cases? What is the, and anything to prevent? What is the mortality in these cases?
20 to 80%.
Mortality is very high, ma'am. It's around about 50 to 60%. So into a preventive matlab, the thing is we have to unnecessary overstimulation and all those things should be avoided. Heroism is avoided during the labor cases.
Though I totally agree that this case unpredictable and neither we can predict it nor we can prevent it. This is one condition in our obstetrics, neither we can prevent or not predict. So patients will be asking 100% guarantee. We can't give them 100% guarantee because neither, can we predict amniotic fluid insulin in any case? No factors to predict. Can we prevent? Except for those overstimulation and all, but so many cases we can't even prevent.
And our emergency team should be ready. It's in the wherever, whichever the city or whichever the hospital, you make a team of anesthetist, neonatologist, and even the blood bank. You should be very good with the blood bank, all those things. Otherwise, it's very difficult to get all those products. So our team should be ready. Even though it's a simple delivery or the whatever the risk, high risk delivery, whatever the deliveries. So it should be a team effort.
Yes, similar to like eclampsia drills and shoulder dystocia drills, what we keep conducting to reinforce the team. This is also one more condition. Sudden maternal collapse should be a drill, should be performed now and then in the hospital so that the team gets sensitized and they know what to do when actually such a situation occurs. Second case. So second case, so 30-year-old gravida 4, para 2, living to abortion 1 at 39 weeks of gestation, comes in spontaneous labor, and after being in active labor for 6 hours, she delivers a 3 kg baby, and but there was a difficulty in removing the placenta, and the resident notices heavy bleeding. On examination, she's tachycardic, pulse of 120, and then hypotension, and per abdominal examination, there was tenderness, and uterine fundus was not palpable. And vaginal examination, a bulging mass was felt in the vagina with heavy bleeding.
Diagnosis, sir?
As this case has progressed as the case of not delivering of placenta at the time, and there is a hemorrhage and shock along with the mass in the vagina. This is a triad sign of diagnosis as uterine inversion. So this is a case of acute uterine inversion, as the fundus of the uterus is inside the vaginal canal, and it is within the 24 hours of postpartum. So it is second degree acute uterine inversion, madam.
Yes, exactly. Acute inversion and second degree. So the classification, depending upon that, we will not go into the classification because of lack of time.
Same like prolapse,
We'll go into
4 degrees.
4 degrees. So in the cavity, outside the os, outside the introitus,
The classification
and
is-
both vagina and uterus full outside, that is 4 degree.
The classification is depending upon the acute and
Yeah.
depending upon the time also, and even the peripheral, non-peripheral, and acute, subacute and chronic. So the presentation will be the different one. In the acute, the shock and bleeding will be there. In the subacute is in 24 hours and 1 month. They will be having the bleeding, will be there. And in the chronic, they are having the peripheral sepsis and discharge, and they will come with the pain abdomen, all those things.
More than 1 month. Even we have seen chronic also. Chronic cases, we have seen few cases. So initially we were thinking it was a fibroid polyp or something. When the patient comes after 1 month with something protruding, then when we see detail, we this thing, it was chronic inversion cases.
And when acute collapse occurs, it is usually first and second degree. So you will not be actually seeing the mass outside. But in chronic cases, usually they'll present with third and fourth degree because it's been there for a long time.
So what are the main 2 causes of death in these cases?
One is postpartum hemorrhage causing hypovolemic shock, ma'am. The other one is neurogenic shock. If the symptoms prolong, then she might go for septic shock also,
Yes, yes.
which leads to death of the patient.
So most of them go into neurogenic shock and this thing. So you should never handle them in the labor room. You should always shift them to the labor OT, and there you should handle. Otherwise you are going to increase their neurogenic shock.
Always a
So that's
team
a rule.
effort.
Yeah.
Anesthetists always have to be involved along
Yes.
with the gynecologist.
Any experts from the
Many times, because of it, we usually we know neurogenic shock, they say, main cause, main thing for, for hypotension and all. But many times, it is a lot of bleeding. We don't recognize. That's what study says, more than neurogenic shock, we should think of unrecognized PPH. The amount of blood loss, we are not recognizing that could be the cause for collapse.
What are the predisposing factors for uterine inversion?
Mainly, delivering of the placenta should be proper, ma'am. That is the main cause. Undue, before the contraction of the uterus after delivery, if we try to remove the uterus, and if we, during the manual removal of the placenta also, if we are using a faulty techniques or Credes manure, like squeezing or putting fundal pressure on the uterus for the removal of the placenta, and sometimes fundal attached placenta and short cord, toughened cord, all will leads to the, and even atonic PPH also
Yes, yes.
leads to the risk factors for the uterine
Experts.
I think, this is, I think, as I told, fundal pressure and squeezing the
yes.
fundus and to express the placenta, that is still prevalent in rural or maybe, those who are not trained, or
The eyes.
it is the most prevalent, and that is the most cause and referral cases, what we see, actually, mismanagement of third stage. And still placenta is attached and they squeeze it and to deliver the placenta, that could be the cause of what we see.
Sometimes it can be spontaneous also. They have seen spontaneous,
Yes,
so without
spontaneous.
any of these causes, it has happened. And maybe you have used uterine relaxant and uterine atony happens, that also can be.
So sometimes it can be spontaneous, as madam told, especially in case of uterine anomalies, or as madam told, the uterus is not contracting properly and the placenta is adherent. In those cases also we can't prevent. Sometimes when you try to do, it just comes out. It can be any degree, but it can land up in that. And sometimes over distended uterus. So in those cases we should be little alert in those cases. And if we teach everybody the periphery, active management of third stage properly, technique, we can prevent most of the cases of uterine inversion.
Actually, nowadays we don't see it all.
Yes, yes.
When
It's
we
quite
were,
rare. In
when
those
we were
days,
students, it was a very common occurrence.
Even in medical colleges, this mishap is more common in the initial days when the new batch of postgraduates come. So it should be very careful, they should be monitored, they should learn prevention rather than learn by doing a mishap.
Madam, as the prevention of concern ma'am, of uterine inversion, madam, actually, so for all cases of high-risk cases, can we do a scan before delivery? So to diagnose adherent placenta, adherent morbid placenta,
Yes.
so that we can take precautions during delivery,
Yeah,
madam,
now
actually.
with the technology, we are able to do or diagnose everything prior, and so the inversion rate has quite come down. But when in those days, earlier days, quite a good number of inversion cases, you know, because they were not diagnosed, adherent placenta and all. But with this thing, those days when we used to, even ultrasound was not there. So those days we had nothing to diagnose adherent placenta. So trying to pull, and also those cases, there's lots of uterine inversion cases we have seen. But now it's come down a lot.
You know, whenever there is after, delivery, still, even placenta delivered, any patient complaining of pain abdomen, persistent, bleeding, I think we should suspect, uterine inversion, maybe incomplete or first degree, and we should do vaginal examination, see the fundus is palpable through vagina, something. That we have to, that's why, missed cases going for chronic inversion. We should.
Unexplained collapse, just put
yeah,
your
right.
hand on the abdomen, see if you are able to palpate the contour. If you are not able to palpate the contour, then you will be able to diagnose the first and second degree. Otherwise, you will miss those cases, first and
Persistent,
second degree.
bleeding,
So
bleeding.
palpating the contour of the uterus is very, very important.
And always you have to wait till the placental separation after delivery of the baby. One usually hurries for placental delivery. So if you wait for placental separation, uterine contraction, most of the cases are avoided, madam,
Avoid it,
actually.
yes. Management,
Ma'am, again it is an obstetric emergency. We have to call for help, and it should be immediate resuscitation along with repositioning of the uterus has to be done simultaneously, ma'am. So in immediate resuscitation, again airway, breathing, circulation has to be established, and reposition can be tried once in the labor room if it's possible, or else we can give a uterine relaxant and try it, or else it should be done under general anesthesia. Or if it's not possible vaginally, we have to go for abdominal methods also, ma'am.
So should we do it in the labor room or shift her to OT?
Ma'am, if there is, if the OT is near the labor room, then it can be immediately shifted to the OT and it can be done in OT, ma'am. Or
okay.
else,
So the results of your reduction depends on how early you start. Earlier you start, you can reduce it faster. The more time you take, it constricts, and it will be difficult in reducing. So the earlier you initiate, it is the best results you will get, and you can save the patient. So that is, don't wait for that, this and all. You start immediately reduction, because you will get good results. Once that constriction occurs, no, then you have to struggle a
And
lot.
same time, ask for blood and ask for help, senior person, and we should not delay it actually. Let me resuscitate, give some blood, and increase the BP. No, simultaneously, I think first priority to do correction, then simultaneously we have to do. We need not wait for correction of hypotension and all.
And one more thing to remember is that when you have successfully replaced it, keep your hand in the
contraction should be established
uterine
when
cavity till and start oxytocin, so that, and once the uterus is started contracting only, then remove your hand.
Yes, that is very, very important. After reduction,
You can put.
And keep it for 24 hours. Yeah. No, we can use balloon tamponade, and that we can insert it and prevent reinversion actually.
so
That will help
unless
it.
it is well contracted and retracted, you should not remove your hand. Otherwise, again, it can repeat. So these are the stepwise management. I'll not go into details because of the lack of time. We'll just put it. So this is the manual method. And the last thing, the portion which comes last has to be replaced first. And the fundus has to be replaced later. That one rule you should know. If this fails, then next. If manual reposition fails, then what you will do next?
hydrostatic.
Hydrostatic,
can be
yes.
tried, ma'am.
you should keep at a level higher, then with the pressure if you put, and you should, either you can close the vagina with a hand or the cup, you can close it and then with hydrostatic. If that also fails,
Then abdominal methods have to be tried, ma'am.
any surgical procedures?
Huntington's method and Altane's technique has to be tried, ma'am.
So there are two types, no? Abdominal and vaginal. So when one Huntington's, you will be trying to lift the round ligament up and then. Otherwise, one more?
Incision.
Huntington's. Vaginal is spinal and Kushner, but nobody is practicing because it's very difficult. If in the spinal is an anterior approach and Kushner is a posterior approach, that is in case of chronic and these inversions. So in the spinal, we have to dissect the bladder up and then start the process, bisecting the anterior vaginal wall, then we have to reposition the uterus. But in the posterior approach, and the advantage is, the thing is, if the bladder is adherent and if that is not dissectable, then you have to go for a posterior approach. But nowadays nobody is practicing that.
The
only
vaginal
abdominal
approach,
process.
the problem is difficulty in visualization. You know, it has gone so high up. The constrictive cervix is quite so high up. You are not able to visualize it and cut it. So, but for the hydrostatic method, I request everybody can use this, you know, vacuum cups. So one, it is blocks and pushes the fluid at a pressure. So you get good results when you use vacuum cup for the hydrostatic method. And then abdominal approach, as just cutting the posterior ring also can bring it up. And the very last option is hysterectomy.
When you do alternate operation, you know, we have to be careful about rectum, you know, when you just, you know, we have to be careful of incising. Injury to rectum, we have to be careful posteriorly.
So this is the summary, we'll not go into the details. Case 3.
Our third case today is 28-year-old pregnant woman at 34 weeks of gestation with mild intermittent asthma, was previously well controlled with inhaled steroids and short-acting beta agonists. She presents to emergency department with severe exacerbation of asthma, experiencing increasing shortness of breath, wheezing and difficulty in speaking. She has tachycardia and her saturation is 95%, and there are neck retractions on inspection.
So diagnosis?
Acute severe asthma exaggerated by the physical change of the pregnancy, ma'am. So as there is her wheezing and coughing, shortness of the breath, and her saturation was 95%, it should be minimally more than 97% would be the accepted. So it's the acute exacerbation of asthma, as is a known case of asthma.
Any rule of 3, you know?
So
Sorry, 1/3 rule, not 3, 1/3 rule.
Rule of
One third.
one-third, ma'am,
Oh, yeah.
that is 33%. In pregnancy, 33% will not be affected from acute asthma, and 33% of them will worsen in pregnancy, and 33% surprisingly it will improve.
Yes. It remains unchanged, maybe due to physiological changes, but improvement also is seen in one, that's because of the physiological changes, and some cases respond. And maybe we have lots of triggers. The why worsening in some cases in pregnancies, lots and lots of triggers during pregnancy. Can anybody tell about the triggers? Okay, I'll go through. Okay, anyway, that slide got okay. Triggers?
Some cold air and drugs like aspirin, some viral infections,
So-
exercises, all will leads to the
Yes, yes, okay.
triggers.
What are the life-threatening complications?
You know, any respiratory infection, you know, that will precipitate, you know, respiratory infection.
Ma'am, maternal complications will be, the patient will have acute respiratory. Maternal complication, there will be acute respiratory
Is it
distress
working?
sorry, ma'am?
Is it working?
Ma'am, it's working. Acute respiratory distress syndrome, patient will have pneumonia, cardiac, right heart failure, pulmonary hypertension, and even maternal mortality can happen, ma'am, if it's not treated immediately. And fetal complication, there will be preterm delivery and fetal hypoxia, intrauterine fetal death, and later patient, baby will have low birth weight, and this fetal hypoxic ischemic encephalopathy, neonatal hypoxic ischemic encephalopathy can also occur, ma'am.
Yes, so timely recognition and management is very important to prevent the complications in the baby, and especially the long-term, it can end up in long-term complications in the baby if you don't timely recognize and manage it. How do you manage acute exacerbation?
Again, it's an emergency, ma'am. You should call for help. maintain airway. The rule is to maintain saturation for about 95% and PO2 60 mmHg. Start oxygen, put her in left lateral position. If there is any trigger, stop the trigger. Like in this case, it was antibiotic which was given. So you have to stop the antibiotic, give corticosteroids, give salbutamol inhalation, and beta adrenergic drugs along with corticosteroids will help, ma'am.
Yes. So, preferred medications are inhaled corticosteroids, but then you have to go for parenteral corticosteroids. And these are all the guidelines for this. I'll just skip this. There are stepwise management for this. So step 1, we'll start with short-acting beta agonist. Then step 2, steroids, inhaled steroids or systemic steroids.
Intravenous steroids.
But long term, if you are using in pregnancy, it can cause problems. Because sometimes if this attack occurs in the early period of the pregnancy, then you may have to continue throughout pregnancy not to repeat. But you should explain the patient of the problems. Step 3,
Long acting if
beta
it is
agonist.
occurs in.
Because of lack of time, I am not going into the details. Then alternatives. Yeah.
We can give.
Okay, this patient comes in labor. How do you manage?
In labor, first thing, see her vitals, make sure the fetal heart rate is monitored, and call for help, start oxygen, give her IV fluids so that whatever secretion is there, it will come out, and maintain saturation. If she is collapsing, then plan for intubation. Plan delivery as soon as possible. If she is in early labor, plan for cesarean section. Stabilize the patient and plan for cesarean section. If she is in late stage of delivery, you have to monitor her continuously and plan normal delivery.
Yes. So very, very emergency things, what you have to do is immediately give her hydrocortisone. Because she's in labor, you don't have time for anything. And you continue 8th hourly during labor. One is that. And you should monitor her with a forced expiratory volume and peak expiratory flow volume.
Yes.
So that is the one which you can monitor the patient with that. And avoid methergine and PGF2 alpha. And in case if you are taking her for C-section, then regional anesthesia, no general anesthesia. These main 4 things if you remember during labor. That's it. So this is all just a summary of that, so we'll not go into the details. So our goals of treatment in asthma should be, hypoxia is more dangerous than the drugs. So that to the drugs, so that you should explain, and then you can use all these medications. I told you what to avoid. So stepwise approach in chronic asthma, this is just for the information. Intermittent short-acting beta agonist, SABA, mild persistent SABA with low-dose inhaled steroids. Means you go one by one, you know. Short-acting, then inhaled steroids, then long-acting, then from there high-dose inhaled oral or parenteral steroids. So stepwise management this is. Case 4.
Coming to the last scenario, 34-year-old multigravida was hospitalized for a cesarean section at 37 weeks. Her obstetric history included no term births or abortions previously, but one preterm birth and one living child. Her surgical history included she has undergone encerclage because previously she had a preterm birth and a cesarean section. She had undergone a cesarean section that time. And during her prenatal visits, she was treated with vaginal cerclage attributed to previous preterm birth history. The patient had no history of medical or drug allergy. Injection cefotaxime was administered several times previously with no adverse reaction. And upon admission, the patient vitals were normal. Then for pre-induction antibiotic, she was given cefotaxime 1 hour prior to section, and patient that is test dose. The patient complained of diffuse itching and burning, and within seconds she experienced shortness of breath, cough and chest tightness. Several minutes later she experienced dyspnea and diffuse urticarial rash was observed over her face and trunk, followed by emesis. Her blood pressure was 90/60 mm of mercury and her heart rate was 133 beats per minute. Her saturation was 93% with oxygen supplementation, and further the FHR revealed bradycardia. So what is the diagnosis?
Anaphylactic shock, ma'am.
Yes, typical with all the rash, everything,
Rash.
so the diagnosis is.
So how do we manage this case?
Management again call for help, and first of all, as we already identified, first stop here, the trigger factor is antibiotic. So if it is going IV and all, stop the antibiotic and immediately oxygen should be given, and avil hydrocort, histaminics and steroid should be given, and
So,
adrenaline should be, IM adrenaline, 0.5 mg of 1 is to 1000 dilution.
any anything from experts? Okay.
Same
So,
thing.
But putting the patient in the left lateral position is very, very important. That help you in resuscitation. Otherwise, again, and monitoring the baby is also very, very important in these cases. So in these patients, we'll have more than 40 symptoms. If you want to diagnose anaphylaxis, more than 40 symptoms, means the symptoms are from head to toe. But since he is a pregnant patient, any symptoms related to the uterus and the fetus? Just I'll focus one sentence. There are 40 symptoms. If I put the slide, you'll have, means how you can, otherwise you'll miss the anaphylaxis. Otherwise, so many times you have given the drug, if you don't know all these 40 signs, then you would have, previously she must have had some of this, but you would miss. So you should know what all can occur. She may just present with nausea, vomiting after the drug. That can be mild, but now when we repeat, it has got severe anaphylaxis. So this, all the organs, some people may just complain of itching around the eyes, in the first dose. But when you repeat the next dose, they'll end up in. So all these 40, this thing you should know. But what is related to the uterus, just will concentrate that. When they have anaphylaxis during pregnancy, what symptoms in the uterus? Uterus and the baby.
Patient can complain of abdominal pain. She might go for preterm labor, and sometimes it is unexplained abdominal pain. It is not like contractions also. So if she is complaining repeatedly abdominal pain, after injecting antibiotic, we have to be careful.
I should be careful. This is such a simple thing, So they just may complain vulvar itching or vaginal itching, one thing, or they'll just complain of low backache and uterine cramps. That's a vague symptom. Many people can complain, but you should be careful. After you give an antibiotic, if they start with that, you should be more alert. And suddenly fetal distress.
Fetal distress.
Sudden fetal distress because of the
Always in these cases there will be fetal distress.
and they end up in preterm labor. So what are the triggers? Triggers also so many things in this thing. What can be some simple triggers? Drugs we know, but in particularly pregnancy?
Latex gloves, or when we insert a catheter, sometimes they'll have shock for that. And blood and blood products whenever we give. She would have received blood before also, but especially during pregnancy, the immune sensitivity increases. So while giving blood and blood products.
Even
And
oxytocin, even
oxytocin,
misoprostol.
oxytocin.
The drugs which we use routinely for all patients, but some patients can be sensitive and they can end up. So you should be always careful. Simple drugs. And as you told, even the latex, the rubber, so many people are sensitive to that, they can develop reaction to that also.
And sometimes anti-D also when we give,
Yes,
they have
anti-D, yes,
sensitivity for
perfect.
that.
Yes.
And
Also intravenous,
And
yeah,
intravenous
nowadays we don't use sucrose more often. We go for FCM and all that.
Yes, sir.
Less sensitivity.
And combination of using latex gloves and oxytocin, that has seen a higher incidence of anaphylactic reactions. And misoprostol, especially the buccal misoprostol, is known to cause anaphylactic reactions.
So the fetal complications, I think we have dealt, because of lack of time, we'll just. So fetal complication, whenever there is, yes.
Fetal distress, ma'am.
Yeah.
Fetal bradycardia will be there, ma'am, due to maternal hypoxia and metabolic acidosis, HIE, and later they can go into long-term complications also, ma'am.
That is what we are worried. Hypotension, reduced circulation, uteroplacental, and then the baby hypoxic and hypoxic ischemic encephalopathy, which the baby can land. So very quick in managing the cases so that they don't land up in that.
And neurological complications in
Yes.
later life for the baby.
And if the patient is not improving, and if there is this thing, better to take them, shift them to the OT and do cesarean section. And one is, it will help the baby, like good baby. and also other is it will help in resuscitation. So if you see the patient is not improving after a severe anaphylactic reaction, better deliver them, shift them to the OT, better deliver them by C-section. You are able to save both mother and the baby by that. In our case, epinephrine, only one this thing, epinephrine was not used. Any difference of opinion?
No, it can be used, ma'am.
Yes.
It is a drug of choice for anaphylactic shock. It has to be used.
Yes, this I wanted to convey here, because some people don't use it thinking that it will cause vasospasm, it will affect the fetal circulation. Here we want to save the patient first, patient and the baby both. So don't hesitate to use the epinephrine. There are lots of studies which will tell that it is safe.
It's the first drug to be used, and just because you're afraid of uterine blood flow reduction, you should not.
So don't think of those theoretical things, you should use it. Okay. So this is how, if you put this chart in your labor room, what to do when there is anaphylaxis. First thing that it is shown in the chart, injection epinephrine, then high flow oxygen, mother on left lateral side, elevator lower extremities, all these are shown in this thing. Maintain minimum systolic blood pressure of 90 with the fluid replacement, continuous monitoring, and then oxygenation, etc., and perform cardiopulmonary CPR, and when indicated performs this. So if you put this is how you manage. It means everybody is sensitized for that. So this is just summary of what we can do. You can put this thing also, what has to be done. Thank you for your patient hearing. I think we have finished on time. Yeah.
That was indeed an insightful discussion highlighting the importance of preparedness and teamwork in managing emergencies. Thank you, panel, for this enriching session. Now I request the panel to please collect the token of gratitude at the gratitude desk. I request the volunteers to please guide them to the desk, please. Now let's proceed further with our next session, keynotes. I would like to invite the respected chairpersons to the session, Dr. Gangambika Nishti ma'am, Professor and Head of the Department, ESIC Medical College, Indore. Madam has been past Head of the Department, MRMC Gulbarga, and Secretary of the Gulbarga OBGYN Society. I welcome you to the dais, ma'am. Now I welcome Dr. Kasturi V. Dhonimat ma'am, Director at Tattvadarshi Hospital, Hubli, past President KSOGA and Head of the Department, KIMS Hubli. Madam has been NMC Assessor across all the medical college over India and has been ex-President of Hubli Dharwad Obstetrics and Gynec Society. I welcome you, Madam. I call upon stage Dr. M.B. Bellat, sir. Dean of KSOGA, past President KSOGA and Secretary General KSOGA, Head of the Department in the past of JNMC Medical College. Sir has many awards in his bags, and the recent one is the Torch Bearer Award. I welcome you to this session, sir. Okay. Now I call upon stage our first speaker, our first resource person of the session, Dr. Bharti Rajshekar ma'am, for the talk. The topic is Decision Dilemmas in Periviable Gestation. I heartily welcome you to the dais, ma'am. I request Dr. Kasturi V. Dhonimat ma'am to introduce Bharti Rajshekar ma'am, please.
Everybody knows Bharti, so she doesn't need introduction. She is the past president of KSOGA, very active member, and she is very active in lots of social activities. You know, she has done lots to the society. So with these two sentences, I'll introduce Bharti. Yes.
Thank you, Dr. Kasturi, and a very good morning. So it's on. The mic is. Yeah. Very good morning to all my dear KSOGians, and I thank my chair, Dr. Kasturi, for introducing and making it so short and sweet. And today we speak about a very interesting topic, which earlier we were talking about preterm babies, but today we are going to talk about pre-viable babies and what are the dilemmas we have and how could we make good decisions to optimize the outcome. This is working fine. So what is the definition of a pre-viable? So first of all, I think hope is something, nothing should be out of the reach of hope. So let us hope for the best whenever we have this pre-viable fetus in our hands. So what is considered the peri-viable period? 22 weeks of gestation is the lowest threshold of human viability till date. It is limited by the physiological development of the fetal lungs. So it is generally defined as delivery occurring from 20 or 7 weeks, that is starting of 20th week to the 7th to 25th week and 6th, 7th. That's almost the end of the 26th week. And this is a very gray zone for clinical and ethical decision making, especially in resource poor settings and in the rural backup where facilities are a constraint to us. So these very early deliveries result in the majority of neonatal deaths and more than 40% of infant deaths according to data. The youngest surviving premature baby in the world is Nash Keane, who was born in 21 weeks gestation and has been recognized by the Guinness World Record in July 2025. So what are the dilemmas we have in decision making? Well, there are many, depends on where you are, what you have in your hands. So there are some predictive outcomes for this. One is most important, the gestational age of that fetus, the birth weight, has it been exposed to antenatal corticosteroids for lung maturity, the sex of the baby, I'll come to it later, the plurality, is it a singleton, a triple or a double, and what is the team and facility we have on hands. So a simple algorithm would be the PABCD, especially in cases where we have PPRA, and the first thing P is the patient's view of the risk and whether they can cope up with the situation, and the healthcare practitioner's view should be taken into consideration. Then you think of the ability of the healthcare system, the baby, whether it has any comorbidities, the patient's context should be taken into consideration, and desire, especially in PPRM, does she want to continue the pregnancy or terminate the pregnancy, and what do we have as expertise locally. So we have to individualize each one of these infant babies, and we have to weigh the maternal and fetal risk benefits and provide them either active care, that is abortion care when they are 22 weeks to 24 weeks, or we could give them an expectant management and further on. So always counsel your patient and the family one-to-one, provide infographic evidence to them and tell them what could be the morbidities, what could be the economic constraints. We have to discuss threadbare, otherwise usually we see that they will be with us for a week, then after 1 week they give up hope. So this is very important. We need to use data while we are counseling them. Otherwise it becomes difficult. We can't be very cursory in our counseling, because there are going to be a high incidence of neonatal morbidity, mortality, and also associated maternal morbidity in about 60% of these mothers. So we have various factors. So do we have any tools to decide and help the parents decide whether we should go around with expectant or active management? Well, the Child and Health Development Consensus has developed certain tools, and these are available on the net on the following website. So what does this tool have? It has the gestational age. You have to just fill it in like the gestosis score, the weeks, the estimated birth weight, the sex of the baby, because female children have a better survival rate than the male fetus. Is it a singleton? It carries a better outcome than a multiple pregnancy. And has the baby been exposed to antenatal steroids? You submit this and you do get an outcome as a high risk, extremely high risk, and a moderate risk. And this high risk, as I told you, follows all these parameters along with the setting for birth. And then you could do a proper counseling, not only to the parents, but also our own team. Our nursing team, healthcare team, and our perinatal health and a neonatologist team, it is easy for us to categorize these babies into extremely high risk and say, do we need to continue with life-sustaining measures, or we just carry with palliative care? If they are high risk or moderate risk, we should definitely give them hope and go ahead with a confirmed management plan. Have an active survival focused management should be there, provide active obstetric management and active management for the newborn. So these are the factors. Of course, it's a medical challenge in many of our situations, but it is possible. ethical dilemmas are there, because what could be the consequences, and are we doing the right thing? Because if God had a reason for that baby to be born peri-viable, was it for some reason that we do not know? And of course, it has to be a multidisciplinary approach. And whenever we obstetricians are handling such cases, to optimize the outcomes, counseling is of utmost importance. Prediction of impending preterm delivery and trying to prevent that delivery, or at least protect that pregnancy with antenatal steroids and the other management protocols. Transfer the woman with a baby in utero to the appropriate unit. Promote fetal maturation with antenatal corticosteroids. Prevent cerebral palsy with magnesium sulfate administration. Optimize the time and mode of delivery. Minimize the risk of infections and neurological injury. So these are the main protocols we will have to follow. So yes, antenatal corticosteroids definitely have a place in managing periviable fetuses, and a second dose can be repeated if the delivery does not occur 7 days after the first dose, and this has been found to reduce the neurodevelopmental delays are reduced in these neonates. Of course, maternal antibiotic administration should be considered according to the protocol of the institute, because it can prevent the morbidity due to that. Maternal magnesium sulfate administration also is of utmost importance. Once 24 weeks is, or they are 20 weeks and they are at a risk of a periviable delivery, and it will delay the onset of neurodevelopmental delays and reduce the incidence of cerebral palsy. When to give it? Within 24 hours of the expected or planned birth. If delivery is planned, it should start as close, or even 4 hours before birth, it does provide benefit according to data. The dosage, all of you are familiar, 4 grams loading dose, continue with 1 gram per hour, maintenance until birth or 24 hours, whichever is later. What's the place of tocolytic therapy? Well, this is a controversy. Data is limited. However, tocolytics may delay birth for a few days or a week so that we can improve the outcome. It is associated with potential maternal and fetal side effects, so you have to be very, very cautious when you are starting your tocolytic protocol, especially when there is chorioamnionitis. And the drugs used, all of you are familiar: nifedipine, atosibrone, magnesium sulfate, indomethacin, and beta agonists. Cervical circlage can be considered as an emergency placement, especially when there is cervical dilatation and membranes bulging. However, there should be absence of infection or absence of infection. So what obstetric and pediatric resources should be available in institutions? Well, it is ideal that it should be a level 3 or a level 4 NICU with complete respiratory technology backup, and this can optimize the outcome for the neonate as well as the woman. When do we transfer? This is very, very important. Efforts should be made to transfer the woman before the delivery, because antenatal transfer has been associated with a better outcome. And always be in dialogue with the institute or the personnel to whom you are going to transfer the woman to, so that they are prepared. So protocols should be in place to facilitate proper transfers. Method of transport should be individualized. There should be a backup in the ambulance, a ventilator, the warmth, everything has to be protected. It should be a specialized, not a regular ambulance. You cannot shift them in that. Final decisions should be made with the hospital where you are shifting the mother to, along with in discussion with the acceptive physician. Don't just wave them off and say, oh, my burden is over, let me just hand it over to somebody. It will not optimize the outcome. Induction of labor becomes necessary to ensure maternal benefit, as well as if there is severe chorioamnionitis, the fetus is also benefited by that. The best method will be decided depending on the situation, though it is not a single method. Interventions for delivery: cesarean section may intuitively be, we may feel, yes, it is the best for this infant, but however, the method of delivery should be based on obstetric and maternal indications. Cesarean delivery cannot be recommended routinely for these periviable fetus. Fetal intrapartum monitoring, continuous monitoring is definitely needed till the birth of the baby is achieved. Delayed clamping has its benefits in these periviable fetus. All of you know that. It reduces the incidence of necrotizing enterocolitis. So evidence has shown that these transport mechanism, antenatal corticosteroids, the method of delivery, the place of delivery definitely have an impact on the outcome. Intrapartum, what do we do? The birth should be at a level 3 unit, antenatal corticosteroids, magnesium, cesarean may be decided depending, and tocolysis is a question mark. Neonatal interventions, there has to be a good NICU setup, neonatologist has to be available, surfactant is definitely necessary, and respiratory support will definitely be needed. So what is the spectrum of outcome in these periviable fetuses, because that decides the decisions we're going to make and the dilemmas we're going to have. We know they are prone for periventricular leukomalacia, severe IVH, bronchopulmonary dysplasia, necrotizing enterocolitis, severe retinopathy of prematurity, high risk for permanent sequelae in adult life, and neurodevelopmental impairment. So these have to be counseled to the family. I would not say the patient, I would say the family, and the incidence of bronchopulmonary dysplasia is the highest because of the immature lung of the periviable fetus. And evidence has shown that there is an increase in neonatal survival and a reduction in the morbidities with optimum protocol-based management. I'm not going to go to the details. There's a lot of evidence to support that there is an increased survival of these periviable fetus from the age of 22 weeks to 25 weeks if we give them the optimum protocol-based management, and it has shown that through the years this morbidity is considerably being reduced. So should newborns at 22 or 23 weeks gestation be aggressively resuscitated? Well, if you are in the setup with all these things, I would say it is a definite yes. Let us not say that we cannot afford to do it. So we have to decide on that. So this decision will be made in association with the family as well as with your team. So once this 2019 guidelines have been introduced by the British Association of Perinatal Medicine that says consider every infant as an individual with its own set of protective attributes and risk factors. Many a time we say this fetus will not survive, but today we see them as successful adults in our own scenarios, in our own setups. We have seen these. So God has a reason for everyone to live. So do not give up hope. So always depend whether it's going to be active care, survival focused care, or is going to be just comfort care to the baby and the parents. So we can follow, because everybody is different and every baby is a great person tomorrow. So this is the guidelines which has been released by the BBMP, and it has the complete concise management protocol that we should follow rather than a single adherence just to the gestational age. And there's various reports and evidence from Sweden, from Japan, which shows there's an increasing body of evidence that interventions, if done in the periviable gestation, is associated with increased survival rates. So what are the considerations for maternal health? What are the implications and the dilemmas we need to solve before we take a decision on periviable pregnancies? Women have a higher incidence of interventions like cervical cerclage and a cesarean delivery or a hysterotomy. The incision may have to be a little higher with its own morbidities. There's increased risk of sepsis and increased duration of hospital stay, more perioperative morbidity, and in future she may have an incidence of viable pregnant hysterotomy scars rupturing. So you decide on unbiased information to the parents, choice of non-intervention or active care should be given to them, enumerate the short-term, long-term effects, individualize management, and discuss finances and hospital stay with them. So what are the managing modalities we have? Comfort care, routine active treatment, individualized care, and active treatment based on parental wishes. So every life matters, and let us give them hope and manage according to the protocols, so that the best thing we could give to somebody is always a chance to come into this beautiful world of ours. Thank you very much, and namaste.
Thank you, Dr. Bharati. Very excellent talk. Very informative, and this is a dilemma which everybody faces, a day-to-day practice, and we should leave the choice to the parents. And with I think with the setup of good NICU now, with very good NICUs are there, we should be able to save these babies. And nowadays we have those transport incubators. Even 1 minute also that from shifting from labor room to NICU also, that time also they don't lose the chance of resuscitation and all. So all this will make a difference in saving these babies. Thank you, Bharti. Excellent talk.
Thank you, ma'am, for the insights. That says every decision will have the power to impact lives. And now we call upon our next speaker of the day. Any question? No.
Questions at the end.
Now we call upon stage our next speaker, Dr. Vidya Tobbi, madam. And madam will be talking about micronutrients in pregnancy. I request Kasturi Donimat madam to introduce madam, please.
So it's my pleasure to introduce Dr. Vidya. She is a former professor and HOD of at Alaman Medical College, Jaipur. And she is the past president of KSOGA, vice president of FOXY, and many more things. If I have to talk, I'll take all the time. So with these few words, I present to you, Dr. Vidya.
Yeah, thank you very much. Thank you, Kasturi, and all the dignitaries of the dais on the dais. This is very favorite topic for me, and always the nutrients are very much less discussed. So always, yeah. What happened? I welcome the other chairperson. She wants to welcome. There in the audience, it seems.
We welcome other two chairpersons for the session, Dr. Anupama Sundar ma'am and Dr. Pranita Ajay. We welcome you, ma'ams. Thank you.
Which one is to?
Not this one.
Yeah. This one. Okay. So I immensely thank the organizing team here. They have put a greatest show here. I thank Dr. Durgadas and his team here. So nutrition, we all know that it is a foundation of life throughout the pregnancy and beyond. And this foundation is for the maternal as well as fetal health. Also, we all know about the intergenerational effects, stunting, chronic diseases, and first 1,000 days always a critical window. So nutrition now matters forever. So we talk always on balanced diet, pre-conception, first, second and third trimester, and as well as the fourth trimester, and the critical period for development of embryos and fetal organs and tissues. So we always talk of, there are other issues also which the nutrition matters, like age at conception, energy balance, the obesity is on rise, and most important is the chronic diseases and infectious disease risk management. So if you see this slide, which is a busy slide, but it does addresses to the pre-pregnancy, periconceptional, second and third trimester and lactation. So what are the important nutrients we should have in each trimester? Now key factors whenever we discuss about the maternal outcome, the nutrition plays very important role, and there are impacts of suboptimal maternal nutrition on mother as well as baby. So role of micronutrients at each stages of pregnancy, that is folic acid, B12, B6, not only the iron and calcium, there are other micronutrients which are very, very important. Now these micronutrients, there is a significant difference which was observed in the various levels across the 3 trimester. Not only the folic acid and iron during pregnancy, but it is well researched. Now the researchers are coming up on vitamin B12A, even zinc, copper, selenium are very important micronutrients for the fetal development and maternal health. If you see the Indian context, over 50%, we know these statistics, very alarming. Anemia is not, means with the oral and all, it is not prevented. So we all know this is a very statistics, and there is a triple burden of malnutrition. One is undernutrition, stunting and wasting, there is low protein and low energy intake, hidden hunger, micronutrient deficiencies, low vitamins and low minerals, and there is a overnutrition which is on increase, like overweight and obesity, low nutrients but high energy. So there is a triple burden of this malnutrition during pregnancy. So globally, when you see that around 2 billion are affected by micronutrient deficiencies with even higher rates during pregnancy. So if you see the zinc deficiency, it can lead to preeclampsia, preterm birth, fetal growth restriction, spontaneous birth and gestational diabetes, not only zinc but also magnesium. Magnesium also plays a very important role as a micronutrient. Iodine deficiency, we all know the implications caused by the iodine deficiency in each gestational trimester. Iodine deficiency lead to this thyroid. We know that iodine is very important for the production of thyroid hormones, and it does cause deficiency, leads to fetal growth restriction. Even the stillbirths are reported in severe iron deficiency. So zinc, magnesium and iodine supplementation for improving pregnancy and infant outcome is very, very important. if you do the zinc supplementation, there is a 14% reduction in the premature delivery among zinc supplemented women. And magnesium is again widely studied nowadays, and it has been shown that there is a reduced risk of premature birth by 27%, low birth weight babies by 33%, mothers hospitalization by 34%, risk of spontaneous abortions by 62%. So it also reduces the incidence of hypertensive disorders in pregnancy and hyperglycemias in pregnancy, and also, as I mentioned about the iodine supplementation, has got its own implication. Another micronutrient is a vitamin D. We all know its importance in the pregnancy, infant and the child. Especially vitamin D deficiency has been shown in the children. There is, if it causes wheezing, asthma, even type 1 diabetes, food allergies, autism, and excess body fat. So the vitamin D is again very important, and there are many studies which are published on vitamin D deficiency, like vitamin D deficiency has got high risk of pregnancy complications. Then also it has been suggested to improve if you supplement in adequate amount, the pregnancy and infant outcomes, and even the prenatal postpartum vitamin D3 supplementation is an effective intervention to increase mother's vitamin D status and promote optimal vitamin D status in newborns. So other vitamins are also very, very important, especially vitamin B6 and B12 and folate deficiency. They result in alteration in gametogenesis, fertilization, and development of embryo before implantation. So which is associated with systemic and follicular homocysteine levels. So it causes, if you supplement, it reduces oxidative stress, prevents neural tube defects, and other inherited abnormalities. So these are very important things one should know, that these are not only iron. So we all know that the iron deficiency is very, very common. 58% of the women, they are anemic, and also we know the antenatal, intranatal, postnatal, and the fetal effect of iron deficiency. Folic acid, we all know that it causes neural tube defects, and it should be in adequate amount in periconceptional period before conception. So hyperhomocysteinemia is again an important thing. It corrects the hyperhomocysteinemia and the pathways, various pathways, and it plays a role in the reduction in incidence of gestational hypertension or preeclampsia. So folic acid has got a deficiency, again is very, very common, and it has to be supplemented. So another thing is, we all know, we have studied about the folate trap, and here vitamin B6 and B12 is also important along with the folic acid. So we have to see that these are the coenzymes which are very important. Now the omega-3 fatty acid also has also been studied in length, and it also increases in the gestational length. So this is in the nutshell. I'll not repeat all, but this is very important slide for postgraduate, that how these micronutrients and its benefit. Already I have gone through this, so I will not go through it again. So these are the various vitamins and various micronutrients, how it helps in various aspects. Now earlier, since 75 years, we have done this iron folic acid protocol. So despite various decades, anemia remains rampant by all means. So we have studied, and we know that it is alone not sufficient. Also it causes gastrointestinal side effects, nausea and other things. We have tried with the parental also, but it has not corrected the hidden hunger. So WHO and ICMR has moved forward, and they have brought in this United Nations International Multiple Micronutrient Antenatal Preparation. That is a short form of that, and this also has been endorsed by ICMR and WHO. So in the last year, only in June 24, a 15-member expert committee of ICMR has released a special report suggesting the use of India-specific multiple micronutrients, including iron, folate, and calcium. Of course, we don't give iron and calcium together, but definitely this formulation is there. And these are the WHO recommendation, and this is the formulation. Now, ICMR and this is WHO, both have recommended this. Okay. So FIGO, our FIGO ambassador is there, Dr. Hima Divakar, and it is a publication and checklist is there, and even FIGO has endorsed this multi-micronutrient model of the formulation by various, including iron and folic acid. So preconceptional nutrition, which always we call it as a zero trimester, it sets the stage for fertility, implantation and healthy pregnancy, and this status influences epigenetic programming of gametes, and supplementation, the right micronutrients improves the birth outcome, and many women start the pregnancy either underweight or anemic. That's why preconceptional formulation should be also used. Zero trimester, that is what they say, folic acid, iron, vitamin D, calcium, iodine, zinc, and omega-3 and vitamin A. Of course, vitamin A should not be used much in, there is a formulation which doesn't have vitamin A. So it has got a clinical implication. You have to conceal, screen, and start. So periconceptional interventions and preconceptional interventions are very important. This is a fetus development by trimester-wise organogenesis, rapid growth, brain maturation and fat gain in third trimester, and post-lactation and recovery. So these are the micronutrients in focus, like iron, vitamin C, vitamin D, calcium, DHA for DNA synthesis and energy B12, folic acid and iodine. So these are the trimester-wise nutrient priorities one should ask the patient to take in preconception, first trimester, second trimester, third trimester, and postpartum. And our clinical focus is fertility, implantation, and epigenetic in preconception, organogenesis, neural tube closure in first trimester, second trimester, the blood expansion and skeletal ossification, and in third trimester, we focus on brain myelination, skeletal mineralization, and in postpartum, lactation and maternal recovery. For that, various key nutrients, trimester specific, we can give these patients. There are various innumerable studies which are published in the Lancet, and there they also recommend that multiple micronutrient supplementation should be given. So this is the multi-nutrient tablet with 17 vitamins and minerals, and there are innumerable maternal and fetal benefits. So what are the barriers and realities? The one is pill burden, compliance issues, food taboos, and cultural barriers, and need for clinician leadership and counseling. We hardly take any diet recall or anything, so we have to find out all those barriers. The way forward for India is one is integrate nutritional counseling, screening into ANC, adopt India-specific multiple micronutrient formulation, that is ICMR, which is included in 2024, with dietary counseling, leverage ICMR India-specific formulation, promote trimester-tailored implementation, clinician to lead adoption and empower women, collaborate with dietitian, nurses, and there are again digital tools for this, and there are various nutrition apps also. So it should be a complete nutrition care. We are committed for the positive pregnancy experience, which ensures the healthy mother and fetus. So iron, folic acid, copper, vitamin, only few I have shown. There are many others which cannot be shown here, but there are many others. So in summary, micronutrient deficiencies have been linked with compromised conception, length of gestation and fetal development and growth, which can lead to pregnancy loss, preterm delivery, small birth size, birth defect, long-term metabolic disturbances, antenatal, postnatal supplementation with multiple micronutrients can improve the birth outcomes and health of the baby and mother. So not only KSOGA, UNICEF, WHO, Lancet Global Health recommends pregnant women who initiated these multiple micronutrients, which contains 13 to 15 micronutrients, has a low risk of preterm birth, low birth weight and cesarean birth, and improved maternal and fetal outcome. So it is a call for action for us. Every antenatal visit is an opportunity for empowerment, ensure the right nutrients at right time in the right way towards healthier mothers and healthier next generation. So that is what I want to conclude. These are the FIGO recommendation and various guidelines. There are ICMR also, you can go to the website and download that. These are the FIGO, and this is my last slide, that is thank you, eat well, eat. Thank you very much. Thank you.
Vidya, it was a very informative presentation. I think micronutrients are the need of the hours, especially in the preconceptional and periconceptional areas. And women are now not exposed to the sun and even exercise, so vitamin D is a very important. So very good points. And iodine, in your slide, there was one slight problem was that iodine supplementation reduces the fetal hypothyroidism. It has by mistake come as a hyperthyroidism.
It has come type.
So just to correction for that, because audience must have gone through that. Okay.
Thank you.
So thank you very much. You please wait here for the questions at the end.
Thank you, ma'am, for that wonderful session. Now I call upon stage our next speaker, Dr. Shobana Patel, madam, on the topic social egg freezing. I request Dr. M.D. Bellat, sir, to kindly introduce madam.
Dr. Shobana Patel, she is my own friend, colleague, and whatever you say, we have worked together. And I just want to ask all the audience to give the big hand that we developed the memorandum of this KSOGA with my presidency and Shobana's presidency, along with the seniors here. All the members of this senior KSOGians are here. Shobana, I think this got registered under her presidency. And Ballari, we had a general body meeting. So see, all today you see the protocol of this KSOGA is after Pushpa Srinivas made it. It is Dr. Shobana. Very meticulous person, very systematic. She won't say that you can't go like this and this. Even in her presentation, you will see that it will be. She is she was a professor with us, and she is now also adjunct professor with us. And she runs her fertility center, Patte's Fertility Center. And she is positions held where, like Vice President of Fertility Preservation Society, Executive Committee member of PCOS Society of India, and she is chairperson of the Public Awareness of PCOS Society of India. She was a president of Belagavi, she is the president of Belagavi Menopause Society, past chairperson Karnataka chapter, past president Karnataka State KSOGA. With this, and she has many publications, awards to her credit, so I request her to proceed with her presentation.
Thank you very much, Dr. Bellat, for that kind introduction. I truly appreciate. Thank you, Chairperson. Thank you, KSOGA. So today my topic is on social egg freezing. I've been talking to a couple of my OBG friends. I've been asking, do you know anything about the social egg freezing? Majority said, we know a little bit, but we really don't know what is social egg freezing. This is the question. This is the answer I got. So I'm going to break down very basic things like what is social egg freezing, where do we stand now. So now egg freezing is an standard of care treatment for all cancer patients. Any cancer patient, we have to talk about fertility preservation. And it has also been extended on to autoimmune diseases, genetic disorder, hematological disorders. But now we are seeing a huge rise in something called as social egg freezing. We are getting patients who are coming to us telling that freeze our eggs, right? That's what we are going to talk today. So there are several terminologies. Now when we talk about social egg freezing, these are not preferred by many people because a woman's reproductive choice is socially embedded. They think it's socially, it's deciding like whether she has to freeze her egg or not. That's not very much preferred. It is also called as elective egg freezing or non-medical egg freezing or egg freezing for non-medical reason. It's also called as age banking. A stands for anticipated gamete exhaustion. Gamete, you are thinking that because of age is declining, so you want to preserve your egg earlier, right? So it refers to elective collection of the reproductive cells or tissues such as, it could be a oocyte, it could be a sperm, or it could be an embryos. You freeze them, you store it, right? And it is done at an younger age, so to preserve the reproductive potential in a healthy woman. This is most often as a safeguard against age-related decline. Age-related decline appears mainly to the oocytes, not to the uterus, and we all know this. Men do not have a predictable drop in fertility with age, so sperm preservation is usually not considered for age-related concern. So we are talking about egg preservation. So social egg freezing, we are talking about pause, preserve, proceed. And we are talking about the science of preserving fertility. How do we preserve fertility even when we age? You all know that there are two fertility trends which is happening in the 21st century, and this is society is changing. So there is a delayed marriage and there are fewer children. You can see that the trend of increasing age at first marriage, this is a sample registration system from India, which shows that there is a trend of increasing age at first marriage. It's both for a man and a woman, they're getting married at a later age. And why are they doing that? There are several reasons. Not having a suitable partner. I think this is not a societal, I think in our own life also, day to day we see this all happening in our own family or kith and kin. They're not finding a right kind of a partner, not getting married on time, this is very common. And there is an improved economy. Women are earning as much as a man and they don't see the need to get married. And there is a higher education, professional ambition, flexibility in workplace, nuclear family, nobody to take care of the kids, and premarital sex. These are all the reasons why people are getting married late. Marriage is taking a second turn. So India is the second most populated country in the world with population of 1.46 billion. It is home to over 440 million millennials. 34% of the Indian population are millennials. They are there somewhere in the age group of 29 to 44. What do these Indian millennials aspire? They are smart, intelligent, educated, independent. What do they want? So this was a survey which was done in 2019, and on 7,000 millennial women between 24 to 31, and they found the priority was financial independence. Next was higher education. Health and fame was a priority over marriage and parenthood. So for these millennials, it is me, myself and I. These millennials are looking at this. Look at the fertility rate. Fertility is lesser at 15 to 19 years. It is peak at 20 to 24, and then it just starts dropping down. At 30 it takes a dip, at 35 it takes a huge dip. So it's seen in both urban and rural area. This is a bell-shaped curve, and this clashes with our professional ambition. For every woman, when this age, the peak fertility is there, they are either studying or they are building up their career. So there's a huge clash between their biological clock and also their ambition. You can see here that the likelihood of getting pregnant starts dipping down, likelihood of infertility starts going up, and there is decline in both oocyte quantity and quality, and the aneuploidy rate steadily increases. It is 30%, aneuploidy rate is 30% at 30 years, reaches up to 90% at the age of 45 years. So you can imagine that this is a problem what a woman is going through now. So we all know that the germ cells in the female are not replenished. Whatever she has the quota in her mother's womb, that's the germ cell she is going to have. And there is going to be attrition and utilization of the follicle. There's a decline in the number of oocytes from the birth till menopause. And it happens at an accelerated rate after the age of 35 years. So what happens during the reproductive years, the number of primordial follicles decreases at a steady state. More than 99.9% of the primordial follicle undergo atresia at different developmental stages, and only we have 500 follicles which reach ovulation. In the whole lifetime, she has only about 400 to 500 follicles. So this is a limited stock what she has got. So there is a two-hit theory. There is a oocyte quality gets affected, oocyte quantity get affected. So when the woman is young, the good quality of oocytes are all recruited when she is young. The good quality oocytes are all recruited when she is young. When she becomes older, it's a poor quality of oocytes who are going to be recruited. And the quantity is also reduced. The quantitative decline is faster than the qualitative decline. And many people say, okay, no problem here, we have IVF, right? So when you looked at the historical cohort, in IVF also, everything drops down as the age advances. ERT makes up only for half of the birth lost by postponing to conceive from age 30 to 35 years, and 30% only from postponing from 35 to 40 years. That means ERT is not a panacea for all our problems. ERT doesn't solve all the problems for all the women. What is happening globally? Globally, you can see even in UK, the number of egg freezing and egg thawing cycles have taken a steep rise. In Australia, again, there is a steep rise. There's increase in the incidence of stored oocytes. US, both in Hispanic and non-Hispanic groups, we can see that there's increased incidence of egg freezing. What about India? We do not have a registry in India where we know how many patients are freezing their egg.
But we all know that in social media, this was which created a buzz recently. Upasana, who is Ram Charan's wife, openly told that she has frozen her eggs. And this is Karishma Mehta, who is a very popular podcaster. She's the CEO of Humans from Bombay, and she said she had frozen her oocytes. And they have this looming fear that, because their biological clock is ticking and they're not getting married and they want to have a baby, they don't know what to do. And she said they all have done it because they think like it's like an insurance policy. It's not only that, there's another reason why there is an increasing trend of social freezing is we have a technology breakthrough. What is the technology breakthrough? The technology breakthrough is now oocyte freezing. Earlier we were doing by slow freezing. Now we do by what is called as rapid freezing, vitrification. The technology is very, very good. It is as good as any fresh egg transfer. Based on this, the HIFA, that is Human Fertilization and Embryology Authority, has approved the use of frozen oocytes, highlighting that using frozen eggs in infertility treatment is safe. Then the Ethics Committee of ASRM 2013 has removed the experimental label from planned oocyte cryopreservation. So across the globe, they are telling oocyte cryopreservation is safer. So there are three reasons for increasing trend for social freezing. One is societal shift, increased awareness among the public. Third is our safety of the technology what we are using. When you come to your practice, how do we counsel the patient for oocyte freezing? What do we tell them? So we tell the woman that it gives an opportunity to preserve fertility and it reduces the anxiety or uncertainty about delayed childbearing. Oocyte cryopreservation and IVF in general does not adversely affect the future fertility potential. If she wants to get pregnant on her own, she can definitely get pregnant, and this is not going to affect. It does not reduce the overall oocyte pool available for spontaneous conception. Complications, though they are uncommon, need to be told to them. Finances is one of the important aspects when we are talking about IVF, we need to be explained, and the success rate need to be explained. Set a realistic expectation. You call them inside and they come and then you do the follicular scan and then show them, okay, now you have 6 eggs or 8 eggs like that. But not every egg, what follicle we show, it will result in a baby. This is what is very important for us to understand. It is not a definitive path to biological motherhood. At every step of IVF, there is attrition. Every follicle seen in ultrasonography will not yield a oocyte. Every oocyte collected, it's not mature. It may not be suitable for freezing. Every oocyte what we take will not fertilize. Every fertilized embryo will not grow. It will arrest somewhere. And every embryo what we have put, it will not produce a viable baby. So this is a plan B for them. This is a plan B. You have a plan A, but you have a plan B also, where you don't have to worry. You can freeze your oocytes. What are the fertility preservation options available? We have oocyte cryopreservation, we have embryo cryopreservation, and the freezing of the ovarian tissue. Generally for social freezing, we do not talk about the freezing of ovarian tissue. We are talking only about oocyte or embryo cryopreservation. What's the difference between oocyte and embryo? Oocyte cryopreservation is a recent technology. It is like, now it is all, it's picked up, but the oocyte survival rate is almost 97%. But embryo cryopreservation has been there since long time, very, very comfortable. Every lab is very comfortable doing that. But when we do embryo, both the partners share legal ownership on the embryo. So in case they separate or they divorce, both the parties' consent is required if you have to transfer. So that's why women want to retain their autonomy and they say we want to freeze their oocytes. So that's the difference between an oocyte and an embryo cryopreservation. What is the ideal age? What is the ideal age? When you want to tell them to freeze the oocyte, how many oocytes you want? Very interesting questions. So two things, woman's age and the reserve, that is what matters a lot, like when we are talking about oocyte cryopreservation. Most of the studies across the globe, they are telling somewhere between 32 to 37 years is the right age for a woman to cryopreserve her oocyte. And most of the European countries, they want to do it before 35 years. The older the woman, the quality will be poor, more gonadotropins are required. So that's not the right time. So you have to do it an ideal time. This is across Western society says 32 to 37 years. What about in India? That's a question which we need to answer. So how many oocytes are required? 15 to 20 oocytes. If we have a 20 oocytes, it can produce a clinical pregnancy rate of 60 to 80%. And to get the 20 oocytes, we need to do many cycles. We won't get one cycle, we won't get the 20 oocytes. So this demonstrates that the likelihood of live birth will often require more than one cycle of oocyte storage even in an younger woman. You can see here, less than 35 years, the success rate is 43%, 35 to 37 is 31%. When they go beyond 40, 42 years, it comes to 3.2%. That's the success rate. So age is one of the most important factor when we are talking about IVF pregnancy. What is the age and the number of oocytes cryopreserved? Look at that, you can see here, if she is 30 years, and if she has 5 oocytes, 64% is the pregnancy rate. But if she has 25 oocytes, the pregnancy rate goes up to 99%. At 40 years, it is 17%, it goes to 60%. So the age and the number of oocytes what we collect decide upon how many oocytes are required in that particular patient. So I was telling you in India like 32 to 37 is what Western standards are telling. In India, what is it? You can see here, the age of onset in an Indian girl is much earlier. Indian girls attain menarche at 12 years, much earlier than the Western counterpart. They attain menopause much earlier, 5 years earlier than the Western counterparts. So what happens is, ethnicity also like, Indian women, they show less response. So that means we have a very short period of time for her to get pregnant. They are attaining menarche earlier, attaining menopause earlier, getting married late. So for an Indian woman is a huge challenge which all of us have to really think. So the process is same as any IVF what we do. The process is not at all different. It is the same what we do in any IVF. The cost somewhere comes about 2 to 2.5 lakhs depending upon where they have done. That's the cost of an IVF cycle in India. Risk and safety, it's very safe, reasonably safe. Ovarian hyperstimulation or low oocyte yield are the minimal complications what we see with the oocyte oocyte pickup that can be there, but it's generally very safe. Is there a risk of congenital anomaly? It is same as any other naturally conceived infant. It is 1.3%. So the congenital anomaly is not more with the oocyte frozen embryos than a fresh oocyte. So congenital anomaly is not more. Chromosomal abnormality is not more. So to conclude, I would want to say that fertility decline with increasing age is inevitable. All of us will go through this. Every single person will go through this. The decline is bound to happen. Delayed childbearing is a fact which we are seeing in day to day in our own life, and also society we are seeing that there is a change in the childbearing trend. Social freezing offers women an opportunity to preserve fertility and reduce the anxiety and uncertainty associated with delayed marriage. So clinicians must provide a balanced, evidence-based counseling. He has to talk about the safety, efficacy, benefit, risk, cost, and realistic outcome before the and also complications. If there's a delayed motherhood, what's the complications? That has to be told to the patient. Given its novelty, raising awareness remains essential to ensure informed decision making. Trust me, wherever I've gone, whenever I've given this talk, majority of the girls who are looking after, the people who are sitting there looking after the IT thing, majority of the people, they say they didn't even know that, this can happen. They don't even know that if they delay the age of marriage, if they delay the pregnancy, what problems are happening. So I think there is really a need to create awareness and let them take a decision after that. We create an awareness and then leave them to take a decision. So now let us not count our impact on how many fertility preservation we have done, how many patients I've called them, I've done a fertility preservation, I've stored their embryo. That is not should be the aim. But we must rather count on how many patients we have counseled well, how many patients we have told that she has an option now. Tell her that she has an option which she can consider. So that was my last slide, I think. Thank you so very much. Thanks for the patient hearing.
Thank you, madam, for that. Thank you, madam, for that excellent and lucid talk. And this is, as madam told, very, very important. Every gynecologist, every doctor needs this awareness, and madam is doing it in many societies, in many platforms. By that, she is creating awareness not only among all doctors. We need to create awareness among all parents and the children that what can be the impact if pregnancy is delayed. You are doing a great work, and I think you are going to change the society. And we wish that You talk to children of most of the parents sitting here, so that children think of getting pregnant early. And this is a problem in every household. I'm telling you, this problem is there in every household. All the parents are always worried, my child is not agreeing for marriage, and then after marriage, not agreeing for getting pregnant early. They are preferring only profession. But they don't know. By your awareness, really we can change the nature and go with nature. Thank you so much.
Thank you, ma'am. Now I would like to call upon stage Dr. Hema Divakar madam for the talk on the topic Wheel of Wellness from Conception to Reality. From Concept to Reality. I request Dr. Anupama Sundar madam to introduce the speaker, please.
It's my great pleasure to introduce Dr. Hema Divakar madam. She doesn't need any introduction, but still I'll just go through the formalities. She is Medical Director, Senior Consultant OBGYN, Divakar Specialty Hospital, Bangalore, CEO and Chairman of Artist. Key achievements, FIGO Division Director, Well Women Healthcare 2024-27, FIGO Chair, Well Women Healthcare Committee, FOXY President 2013, National Technical Convener, FOXY Manyata Quality Accreditation, and so many of her social activities and everything is known to everybody. So, stage over to you, ma'am.
Thank you. Ellarigu namaskara. 35th KSOGA Conference ge ನಾನು ಬಂದು ಇಳಿತಿದ್ದ ಹಾಗೆ ನಮಗೆ ಮುಖ್ಯವಾಗಿ ಸಿಕ್ಕಿದವರಂದರೆ ಡಾಕ್ಟರ್ ನಾಗರಾಜ್ ಹಾಗೂ ಡಾಕ್ಟರ್ ಹಿರೇಮಠ್. ಅವರಿಗೆ ನಾನು ಹೇಳಿದ್ದೇನೆಂದರೆ ಇದು ನಮ್ಮದು ಕಾನ್ಫರೆನ್ಸ್ ಮಾತ್ರ ಅಲ್ಲ, ನಮ್ಮೆಲ್ಲರಿಗೂ ಇದು ಒಂದು ಉತ್ಸವ. ಸೊ ಕನ್ನಡ ರಾಜ್ಯೋತ್ಸವವನ್ನು ನಿನ್ನೆ ತಾನೇ ನಾವು ಎಲ್ಲ ಸೇರಿಕೊಂಡು ಸೆಲೆಬ್ರೇಟ್ ಮಾಡಿದ್ದೇವೆ. ಒನ್ ರೀಲ್ ಇಸ್ ಇನ್ ದ ಇರಾ ಆಫ್ ರೀಲ್ಸ್, ಐ ಆಮ್ ಸ್ಪೀಕಿಂಗ್ ಆಫ್ ದ ವೀಲ್ಸ್ ಬೈ ದ ವೇ. ಹಾಗೂ ನಮ್ಮಲ್ಲಿ ವಿಶೇಷ ಅತಿಥಿಗಳಾಗಿ ಬಂದಿರುವ ಶೈಲೇಶ್ ಪುಂತಾಂಬೇಕರ್ ಹಾಗೂ ಹಫೀಜ್ ರೆಹಮಾನ್ ಅವರಿಗೆ ನಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಆದರದ ಸ್ವಾಗತ. ದಿಸ್ ಇಸ್ ಪರ್ಟಿಕ್ಯುಲರ್ಲಿ ಐ ಆಮ್ ಟೆಲಿಂಗ್ ಟು ದ ಗೆಸ್ಟ್ in view of the viral reel which is going on with Vishwesh Bhatt. ಅವ್ರು ಏನಂತಾರಪ್ಪ ರೀಲ್ ಅಲ್ಲಿ ಅಂದರೆ ಇಟ್ಸ್ ಅ ಬ್ಯೂಟಿಫುಲಿ ಕಂಪೋಸ್ ಸಾಂಗ್. ಈ ಕಡೆ ತಿರುಗಿದ್ರೆ ತೆಲುಗು ಪ್ರದೇಶದವರು ಎಕ್ಕಡ నుంచి వస్తారు, ಈ ಕಡೆ ತಿರುಗಿದ್ರೆ ಎನ್ನಡ ಹೆಂಗೆ ಪೋರೆ, ಈ ಎಕ್ಕಡ ಎನ್ನಡದಲ್ಲಿ ಕನ್ನಡ ಎಲ್ಲಿ ಹೋಯ್ತು ಅಂತ ಅವರು ಅದನ್ನ ಕನ್ನಡ ಕಲಿಯಪ್ಪ ಅಂತ ಹೇಳಿರೋದು. ಕಾಸ್ಮೋಪಾಲಿಟನ್ ಅಂತ ನಾವು ಅಂತೇವೆ, ಆದ್ರೂ ನಮ್ಮ ಭಾಷೆ ನಮ್ಮ ಕನ್ನಡ, ಇಲ್ಲಿ ಕನ್ನಡ ರಾಷ್ಟ್ರಗೀತೆ ಆಯಿತು, ಎಲ್ಲರಿಗೂ ಸ್ವಾಗತ ಕೋರುವಾಗ hugely congratulating Dr. Durgadas and his entire team for the wonderful work that they have done. Now coming to my topic, Wheel of Wellness. Well, in Paris, when I was the chair of the Well Women Healthcare Committee, just now Shobana spoke Plan A, Plan B. So our Plan A is prevent illness and promote wellness. Plan B is, if you are ill, detect it early so that the best can be done. So that is the philosophy of the Wheel of Wellness. It depicts from number 1 to 11 every phase in the life of a girl or woman. Keep her ready for the next phase of her life. If she comes for something in pregnancy, don't quick fix only the problem there. Before, beyond pregnancy also she has a life. So you need to you have an opportunity to do a lot of things. And one of our conference brochures said Femtech OG. So Femtech is the new era of technology, which is going to transform the women's healthcare in India. 2 years ago, when we had the KSOGA conference in Bijapur under the leadership of Dr. Vidya Toppi, we asked a show of hands about how many people have heard the word Femtech, and there were like 50-50, few people, maybe they just raised their hands. But even in the international arena, we're just returning from Cape Town FIGO conference, every Femtech session was full, but when we asked, have you heard of Femtech? Again, the response was less than 50. So there are people, the buzz is going around. We cannot escape the answers to the question, do you think that technology adds value to the patient? 80% said yes. Next generation will largely rely on technology and personalized care. There also the answer was yes. But are you using technology for getting things further? Maybe, may not yet be, but we are getting there. So the transforming every phase of life, connecting it to the bridge of technology. Reaching the unreached is also the motto of this conference. So, last mile to be reached again with the wellness. And needless to say, there was somebody from the US who visited India, and they said even the beggar has the QR code because nobody is carrying cash, but he needs to collect something. So welcome Durga, I just congratulated you. Once said is not enough, so once again, ladies and gentlemen, put your hands together. I'm very, very proud and pleased of the conduct of this conference. So Digital India, New India, Naya India is like this. So across the wheels, we'll just focus on a few things which are low-hanging fruits, which are easily doable. How do we translate the FIGO nutrition checklist? By the way, nutrition and mental well-being goes right across at every phase of life. These two are really, really important. FIGO nutrition checklist, even when we train the remote Anganwadi, Asha workers and Sanghinis in remote parts of Kanpur, I said, you were anyway doing this before. Does this checklist add any value? Then they said, hum to puchte the, wo kehte the. We used to also say some nutrition advice and we used to walk away. But the 2 minutes of the use of checklist has made us realize that the structured format and our focused counseling has indeed made a difference to the improvement in nutrition. So this is a very, very simple checklist, vegetarian or not, height, weight, BMI, and what kind of food substances, how many times in a week and what portion. So when we did this in several of our centers, everybody said it was simple to use, but again, do you want to change? Yes. Will you change? Maybe, may not. You know, that is the kind of an attitude that most of us have because behavior change is not easy. And then, when we grumble that there is not enough time to counsel the patients, you can always extend. The technology extends your hand, lends it further for her to go and explore every app that speaks of the nutrition. So FIGO is also thinking of coming out with validated FIGO endorsed technology, point of care devices, applications, so that any clinicians who wants to unlock the potential of technology can safely rely on what has already been vetted out by the experts, because use and misuse both are there. So the power of technology, again, we bring home the point that yes, you can shift the task to the paramedical teams, as we have done in various of our programs, including Manyata. You may not have the time because your expertise is needed for the complicated cases. Your health is in your hands, we say to every patient who carries a mobile, and we can explore more to do with nutrition. Here again, I see Rangan Basu in the audience. The menstrual cups, please do visit his stall. Environment friendly, easy to use. The new generation is in a large way taking up to this. And where do these little children get this information? Again, it's awareness building through technology. They come and ask their mother a few questions for which she doesn't know the answers. When she comes and tells us, my daughter is already using a menstrual cup, is that the right thing to do? So that is how the information dissemination is also happening. And again, when we ask the practitioners, if you know that your patient is using a menstrual cup, do you encourage her to continue the use of it? They say yes, very much. But when we ask, do you proactively counsel them to use menstrual cups? Maybe, may not. So this is a whole new era movement towards climate change and environmental safety, because using the menstrual pads, discarding it, dumping it in the wastage is again becoming a huge problem. So we are slowly moving towards that. Mental well-being, then right across every age group, the helplines that have been established in association with NIMHANS, FOXY, Dr. Bhaskar Pal is also going to expand this in a big way, because every age group needs this online help for the counseling, because many, especially girls and women, do not have a go-to person. So an authentic way, if we do this, it could really transform. Then the stage of pregnancy. pregnancy, pre-pregnancy, postpartum. There are several things happening through technology. This is another new article we are bringing out through the FIGO team, which says, by use of point-of-care equipment, many things can be tested in a remote manner, and the smart way of tackling the pregnancies with fewer physical visits and n number of touch points. Maybe you ask her to come 10 times, but she's able to come only 4 times. But 4 times she physically visits, 14 times, 18 times, 20 times, as many times as you want, you can connect with, asking her to give the feedback on the home devices as well as the telecommunication. This is the Femtech Revolution article. Please go to figo.org website. There's a lot of insights into this. Beyond pregnancy, you see in our rural centers how the community volunteers, today she has hyperglycemia, diabetes in pregnancy. She needs a check after 6 weeks, after 3 months, after 6 months, after 1 year. Who is to do it for her when she goes back to her village? This is the cadre which we have created, who do the test and convey, and we do the teleconsult online. Coming to the Wheel of Wellness, which was recently launched. Here you see in the picture 2 gentlemen across the wheel. One is Dr. Amit Shah, who is the country head of Japago, who is already transforming the rural settings with the use of technology for the safe motherhood care. And the person next to him, Dr. Shantanu Pathak, who is a health tech person from IIT Mumbai, who has carried this small box which is full of treasure of point-of-care equipment. So Wheel of Wellness, thanks to all my champions across Karnataka, we have launched this Wheel of Wellness concept where every month a select set of women come for like a well baby clinic. They'll come for the well women health check. And what do we do in the well women health check? A, B, and C. A is know your numbers. Height, weight, BMI. Simple to do. Blood sugar, blood pressure, hemoglobin. 1 drop of blood and everything gets done, and it's also Bluetooth enabled, so it will come straight onto your dashboard. The B component is bone mineral density. Several medical companies are haunting us every day and night that they want to come with their bone mineral density machine. Not the best, but it's still something that you can alert the patients with. The C is cancer check, the breast and the cervical cancer, which needs to be really scaled up to the best that we can. So we train all the staff nurses in these setups where we plan to do the well women healthcare camps. The reason being that they should be completely aware to respond to the basic questions for these women. That becomes a part and parcel of the counseling as well. So the checklists on which they are trained, they are the main pillars of these wellness camps, because it has to happen repeatedly. You take a small number, but you keep doing it over and over again, and they will flag off. It's a green, amber, and red zone. If it's green, they will only counsel the patient and send them. If it's amber, they'll send to junior doctor. If it's red, they'll send to the senior doctor. So the doctor concerned within her hospital or a clinic premises where we host these camps is not burdened. The junior level takes care of everything, but the right kind of cases are referred. Even simple things like many women tested 8 grams hemoglobin, flags to the main doctor, scope for giving parenteral iron. Many who have never ever tested the sugar or BP. First time they're diagnosed as high sugars, oh namak gotte irlilla, because after her delivery nobody has even seen her, so that becomes a great thing. So this is the know your numbers, bone density, breast and cervical cancer check, vaccination and contraception are adjuncts to it, and we are doing a lot of programs, again thanks to my very beloved champions across the state, and we want to make Karnataka the role model for the well women. Wheel of Wellness has kick-started from here, and we want to expand it in the entire country. The box is now open, and you see all those small gadgets, including the weighing machine and the made in India point of care devices, and this is the branding for the uniforms for this wellness, portraying that we need girls and women in the pink of health, and all the staffs are very excited to have them. These are the equipment inside the box when we are thinking out of the box. Inside the box we have locked these equipment. The Thermalytics has come up with a simple thermal camera, tripod stand, laptop is all that you need. One click and it shows you the hot spots in the breast to pick up suspicious cases which have then to go for ultrasound and mammography. Simple. There are villages in the country, the groups who are doing their self-testing, because after COVID self-testing, people have realized that they can self-test. So cervical cancer self-test is also happening, but paramedics can easily take this swab, or the consultant can do it, and the foundation is offering it at a very minimal cost so that the expanded cervical cancer screening. It is very, very shameful for us to say only 2 to 4% of our women in India are screened. We need to escalate it beyond 50%, up to 70% as per the WHO. And again, the technology for the maximal use for training the staff wherever they are and at whatever time of the day they would want us to train. So we've already kick-started the camps from last month after it was launched, and you would see from table to table, the doctors are counseling and taking the checklist, the blood tests being done, the BP being taken, the bone mineral density, and it's coupled with an awareness program as well. Lot of FAQs, lot of exchange, and they say, we didn't know this, and then, they're ready to. So next camp is happening in Dr. Hemavati Srinivasan's place in Bengaluru, and pillars are right behind. You can see all of our champions who have already had their staff trained, and the schedule has been drawn for the entire month of November to host these camps. The Well Women Checkup will happen because one of our big banners are screen the mother, vaccinate the daughter. So we will enroll the daughters for HPV vaccination. Bellad was mentioning that's such a crucial, important step ahead, and we can't forever and ever wait for somebody else to do it. Let's do our bit. And then, things will pick on. Something is better than nothing has always been our principle. Now, it's a very strong red flag because all these NCDs, India being diabetic capital, so many in India having hypertension and heart attacks, so many mothers whom we are saving today in childbirth are going and falling in the cardiovascular risk zone because they are not taken care of after that. So this intergenerational transfer has to absolutely be interrupted with kicking the wheel of wellness across the life course. And I think truly the time's up. We need to wake up now and get started with the best we can do to every girl, every woman, everywhere, every time. Thank you very, very much.
Hello, thank you, madam, for such a innovative talk. Hello. Thank you, Hema madam, for such an innovative talk. And such innovations are done by such stalwarts like you, madam. We are very thankful for such an innovative talk. And such actions should be started immediately everywhere in all societies. And I'm sorry for chairing the session late. I'm Dr. Gangambika Nishti. Actually, I have come here to invite to the future conference, next conference, 30th KSOGA conference. I invite all the KSOGians to come to Gulbarga conference. Thank you.
I think you have 1 or 2 questions. We want some discussion, important topics. So anybody has any questions? If no one has the question, I have question for one to Shobna and one to Bharti. Dr. Shobna, in the current era of the age, the ambition and professional growth and development, how we should counsel at the school age. Is there any role of school age education? Because in Western world slowly they are addressing. And in Figo, there was a Edgar who spoke that emperor is naked, without clothes. So that was a fantastic. What is happening, as your point I just want to say is, lesser children, less age of fertility later. In Japan and some of the developed countries, schools are getting closed. No students to the classes. So I just want to highlight that, how we should give the education at the school. And to Bharti, pre-viable, yesterday there was one of the presentation by Soumya Dinesh on the platelet-rich fibrin and plasma, so to block the leak. So please elaborate those two.
Yeah. So I just want to tell Bella, like, you are talking about school age. They're very young, right? So in that age group, I think now what Vidya spoke and what Hema spoke, and like, we are talking about overall wellness of the girl, rather than going and addressing them and telling your fertility is coming down. At the school age, we will not do anything like that. We will only have to talk about overall wellness, how to improve the health. And we all know that all this deficiency can lead to poor ovarian reserve. So this is all like, we have to talk more and more about preventive medicine rather than curative, like, go for oocyte freezing. No, it's not like that.
No, it's not exactly school means primary. You can say higher and PUC, because that's where the adolescents are.
Awareness, create a health awareness. Awareness we have to create. That's the only mantra I feel.
Thank you, Dr. Bella. Due to paucity of time, I did not mention what Dr. Soumya Dinesh's study she has presented, and it is one of the first in the world. It was there yesterday. She has done 10 cases of periviable gestation where PPROM was at around 14 to 16 weeks, and PRP injections were given intra-amniotically, and out of those 10, 6 of them have continued beyond the term of viability and around 34 to 36 weeks, and we have had a successful outcome. And this is a very simple procedure. The video can be shared to any one of you. Dr. Soumya Dinesh will be ready to share it. It's just like we were talking about PRP in aesthetic gynecology, PRP in endometrial receptivity, similar PRP preparation, and very under ultrasound guidance, it has been injected into the intraamniotic cavity, and the leak had sealed. And this has, further studies are of course required, and of course we have got the doyens of KSOGA and a lot of trainers of teachers here. I think they can give it to their postgraduates and take this up as a study. Thank you.
Thank you for the wonderful session. Due to paucity of the time, we would like to rush to the next session. Thank you very much. Thank you very much for the wonderful talk. I would like to request volunteers to please guide the chairpersons and eminent speakers to the gratitude desk. Thank you. Next, we will move on to our next session, plenary talks. And meanwhile, I would like to request all those faculty members who haven't had their pics clicked at 6 and molecule booth outside for their mementos, please do it before 12 p.m. Thank you. Now, the next session is plenary talks. I invite the respected chairpersons for this session. Please welcome Dr. Hema Divakar Madam, who is Medical Director at Divakar Specialty Hospital, Bangalore, FIGO Division Director, Well Women Healthcare, past Foxy President. I welcome you, Madam. I welcome our next chairperson, Dr. Madan Kamble, sir. Consultant, obstetrician and gynecologist, Jayashree Nursing Home, Tembur, Solapur. I welcome you, sir, to the dais, please. I request Dr. Suman Gaddi, Madam, to the dais. Consultant and obstetrician, gynecologist at Danama Super Specialty Hospital, Ballari. Madam has been past KSOGA President, former professor and head of the department at WIMS, Ballari, KSOGA Treasurer. We welcome you, Madam, please. I request our first speaker, Dr. Hafiz Rahman, sir, to the stage, please.
and I request Dr. Hema Divakar Madam to introduce Dr. Hafiz Rahman sir. Over to you, Madam.
Welcome to this plenary session. What does 35th KSOGA offer you? Well, it's the best of the people in their fields, not only in the entire country, but across the globe. This session has two very, very distinguished speakers, Dr. Hafiz Rahman and Dr. Sailesh Puntamekar. It's my proud privilege and a pleasant duty to introduce very, very quickly, because we want to absorb ourselves into what is going to deliberate on. That is something to do with the vaginal approach for laparoscopic surgery. He's always, going the paths less traveled. That is Hafiz for you. He's the chairman of the Sunrise Hospital, rising very tall, pelvic floor, laparoscopic and oncosurgery, pelvic reconstruction surgery, founder chairman, Sunrise Group of Hospitals, former board member of the MCI Lifetime Achievement Award from IAGE at the Endo-Robo-Gynec 2025 at Agra. And there are many more innovative ideas that he will present to this august audience. Over to you, Hafiz.
First of all, can you hear me? No, it cannot be elevated. Okay. First of all, thanks a lot for inviting me to this conference, and a great job, Dr. Durgadas and the team of KSOG for such a wonderful event. Now, as Hema was telling that why should an endoscopic surgeon go laparoscopically to correct vaginal defects? When the vagina is open there, you can just go inside. But I'll tell you the reasons. I'm not going to talk about the usual problems or septums or things in the vagina. I'll just take you through because all these things are there in textbook. I don't have to tell you all these things. There are enough videos in the net where you can see things and study things, but I will take you through my experience and how I view vaginal defects and some of the abnormal defects which I've come across in my 30-35 years of practice with a huge volume of Mullerian and vaginal abnormalities. Now let us look at transverse septum. Transverse septum, all of us think that it's quite easy, but at times you find that you cut a transverse septum and it recurs again. It comes back again. 10 times you cut that same transverse septum, thinking that it is transverse septum, it keeps coming back again. Some of this transverse septum, if you see, simple transverse septum should be less than half a centimeter. This is the actual transverse septum where there is no unification of the vagina, upper part of the vagina and the lower part of the vagina contributed by sinovaginal bulbs. Now, if the septum is more than half a centimeter, understand that you are not dealing with a transverse septum, but you are dealing with a mid-vaginal atresia. You keep cutting it, it will come back again and again. If you see here, this is a simple transverse septum with no hematocolpus, and these are the cases which can be very difficult to operate because you have a blind vagina, patient may be even menstruating because there may be a small hole somewhere, and these are the cases you will find it very difficult. If there is a hematocolpus, it's quite easy to cut it, but if there is no hematocolpus, these are the cases which can be quite difficult. And this one, we had gone laparoscopically. This is something which is presented in AGL also. Laparoscopically, because the difficulty here when you go vaginally is anteriorly you have the bladder, posteriorly you have the rectum. So you are not knowing exactly where to cut. You may go into the bladder or the rectum instead of going into the upper part of the vagina. Now laparoscopically what we did is we just dissected the bladder down nicely. Now the bladder is in my hand. I will not anyway cut the bladder in these cases, and then we had put a gauze piece from below onto the septum and opened into the upper part of the vagina. Now my gauze piece is there in the lower part and I am sitting in the upper part of the vagina endoscopically, and there is no reason why I should injure the bladder now because it is in my hand and I can easily cut the septum there. As you can see here, I can just cut the septum there and I can enter into the upper part of the vagina. As you can see here, that's the upper part of the vagina. Open it there completely and then you can see how easily the septum can be cut. See, that's the upper part of the vagina. Now there is no reason why I should go into the bladder or the rectum. Rectum is much posterior and I can easily cut the septum and unify. You can see the thickness of the septum, it is just 0.5 centimeters, that's all. And the nature of the septum will be, it's a very friable mucosa, basically vaginal muscularis and mucosa, and not a fibrotic area. Whenever you come into a fibrotic area, you be careful that you are not dealing with an actual septum. This is a septum. This is something which, one of my first case, actually twice the septum was cut and then the patient was sent to me. I saw there was even a cervical atresia for this patient, and we had done a cervical reconstruction for this patient. And then we saw this one, but then we had actually, I myself excised the septum. Then it recurred again. That is how I found out that this can be a mid-vaginal atresia. See here, you can see we are doing endoscopically vaginoscopic surgery. You can see how much of fibrosis is there. If you can see the lateral vaginal wall, you can see how much of fibrosis is there. I'm just cutting the fibrosis with the resectoscope. You can see almost 1.5 centimeters laterally, the entire fibrotic structure is going on. And when you see inside, you can actually see the Foley's catheter which was kept. That is a left lateral wall. And when we go inside, see the amount of fibrosis. This cannot, if you just cut this septum kind of thing and just leave it, it will recur again. How much ever you cut it, it will recur again. As long as you remove this entire fibrotic tissue and re-anastomose the upper and lower vagina, you will find that it keeps recurring again and again. You can see the cervix which was reconstructed. That's the cervix which was reconstructed. And now what we are doing is, I am resecting, this is the vaginal resection of the fibrotic area. Like a resectoscope, like a TCRE or a histoscopic myomectomy, you can see that fibrotic area is resected completely, but you have to be extremely careful that you will enter into the lateral vaginal wall vessels if you resect it more. So you have to be very careful in resecting this area. On both sides you can resect it, you can see the amount of fibrosis there. Now at the same time, after this incident, I started thinking of it and we started going laparoscopically. Now we have mid-vaginal atresia, almost 25 cases we have done. So mid-vaginal atresia, you can see here what happens. This is a hematocolpus which you can see there, and we are going laparoscopically, dissecting the bladder down nicely. See, basically what happens is, if you want to actually do a surgery on the vagina, if you want to do a real surgery on the vagina, you need the vagina fully naked from above. You need to dissect the bladder, you need to dissect the rectum, and you need the full vagina with the lateral vaginal wall vessels. Unless you have the vagina properly in your hand, you cannot dissect or you cannot anastomose the vagina. Here you can see that we have gone into the upper part of the vagina. There is a hematocolpus. Now we are opening the lower part of the vagina. That's the lower part. You can see the amount of fibrosis which is there, and there we have opened into the lower part of the vagina, and this entire area of fibrosis, this mid-vagina has to be completely excised, so that this is the posterior. That mid-vagina has to be completely excised laparoscopically, and this I felt is not really possible if you are doing a proper vaginal surgery. You can do it with a resectoscope or a vaginoscopy, but it is not possible if you are doing a proper vaginal surgery. That's the lower part. You can see how the excision is done completely. And then you can anastomose this vagina after you excise it completely. That's where you can anastomose the upper and lower part of the vagina. Of course, laparoscopically. This can be done vaginally also if you're not that good at suturing, but the dissection has to be done laparoscopically. And nowadays we always use V-lock, which is much better compared to Vicryl, because Vicryl disintegrates quite fast. And that's how the anastomosis is done. And that's a vaginoscopic picture where after the anastomose, then you can keep a mold there and finish the procedure. This mold is usually kept for almost 45 days. Isolated cervical atresia is another thing which you have to be very careful when you deal with. We have a large number of cases. Initially we started repairing the cervix. But later on we found that repairing the cervix has almost 40% recurrence. The cervical canal will get closed. We tried all methods. We kept Foley's catheter. We took out the appendix of the patient itself, threaded on the Foley's catheter. We kept the appendix instead of the cervical canal. All those methods we have tried, but we found that there is almost 40% recurrence. So we started doing trachelectomy in those patients, remove the cervix completely, and do a uterovaginal anastomosis. All this done laparoscopically. You can see a blind vagina. When you see the vaginoscopy, that's a blind vagina, but good length of vagina is there. And that's a dissection. And you open the uterus, see that's a uterus, you can see the mucosa, you can see the endometrium. This is the cervical part, you can see the cervical part there. You split the cervix to understand how much of cervix is atretic. The fibrotic area of the cervix is there, and then you will open up into the vagina. That's the vagina you can see, and this is the area, this much area of the cervix is completely atretic. You can see that it cannot be, it's better not to try to repair it. It will be much better if you can excise it, if you can do something like a trachelectomy and anastomose the vagina onto the uterus. As you can see here, that's a complete trachelectomy being done, and after trachelectomy, you can easily anastomose the vagina. You put in a Foley's catheter, and you can anastomose it completely like here. The vagina can be nicely anastomosed, and we have seen that the recurrence chance of this kind of problem or the recurrent stenosis is extremely less. So far we have not had one, because once you do these surgeries and the patient goes into a recurrence of stenosis, it becomes extremely difficult to correct it again. And another advice is, please do these kind of correction at the earliest possible. What I have seen in some of the cases where the patient has come to me after 5 to 7 years, we had corrected it, and all these patients, 100% of the patients went into severe menorrhagia at a later age. We just investigated into some research papers. We saw that the ferritin content in the menstrual blood, if it is sticking on to the tissues for more than 5 years, there has to be some DNA changes which occurs, because there is high ferritin content, and this DNA changes can lead to severe menorrhagia because endometrium changes completely. That's where you can see that it's posteriorly also anastomosed. The vagina is completely anastomosed, and we see to that the vagina actually engulfs the uterus. You know, there is a colpose which is created when the vagina engulfs the uterus. And there is something called as oblique vaginal septum, again extremely difficult to operate vaginally actually, and it's much more better to operate it with vaginoscopic surgery. As you can see here, oblique vaginal septum, you can have the typical Overa syndrome, you can have something partially open but oblique vaginal septums, you can have the connection through the cervix. In all these cases, you will not have the hematocolpus, that's the difference. You can have a very small septum also where you will not have a hematocolpus again, but you will have a hematometra, but still it is an oblique vaginal septum with a patent cervix. Here you can see a patient who was operated 5 times for pelvic mass, pelvic blood collection, and laparotomy was done 5 times. You can see the mess which was created just because this oblique vaginal septum or Overa was not properly diagnosed. She was an Arab lady, she was not allowing anybody to go vaginally. So we actually, when this was a 20-year-old video, we actually went vaginoscopically, one of the first vaginoscopical surgeries, because she didn't want a hymen to be ruptured. So we did vaginoscopically, and we saw that it was just an Overa syndrome. That is a hematocolpus which you can see there. That is a vagina being dissected. That's a hematocolpus. So we went vaginally with the resectoscope and excised the oblique vaginal septum, and it cures completely. These kind of septum, they are actually septum. Just cut it and leave it. It takes care of itself, and the entire thing is cured, and it usually doesn't recur as such. But at the same time, this oblique vaginal septum need not be that simple also. You can see that this is a patient with diadelphys. You know, there was a diadelphys. When I did the vaginoscopy, I could see one clear cervix, one exact cervix is there, but I could not see the other cervix. Diadelphys, there should be two holes actually. So I could not see the other cervix because MRI showed that this was a dicholis. So the diadelphys dicholis. So we put methylene blue through the other uterus and we saw that it's coming somewhere in the vagina. So why I'm telling is oblique vaginal septum or this vaginal septum need not be always in the center. You can see methylene blue is coming somewhere on the lateral side. So we went in through the lateral side that you can see the septum there, and we found that on the lateral side where it was coming there was a hole, and when we went inside we were surprised to see that there were three passages. Three passages were there. One was a vesico-vaginal fistula but still not leaking urine. One was the normal cervix and other was an endometriotic cavity. You can see here all the three passages as you can see here. That is the endometriotic cavity which was there. And when I come backwards, you can see that there is another cavity which is going into the cervix. You can see the anteriorly you can see the vesico-vaginal fistula, and that is the cervix here. And going into the cervix, you can see the that's where we have injected the methylene blue with a Veress needle. The advantage is you should understand that all these kind of cryptomenorrhea can lead to infiltrating endometriosis. This is a very important thing. Cryptomenorrhea, long-term collection can lead to infiltrating endometriosis, and this can lead to even fistulas. We have come across 3 cases of cryptomenorrhea long-term with vesico-vaginal fistula, and the biggest advantage is you correct the cryptomenorrhea, this fistula usually disappears. Most of this fistula usually disappears. You don't have to actually resect it, or you don't have to do a closure of the vesico-vaginal fistula in such cases. Now here again, this is an interesting case where you can see we did vaginoscopy. This patient actually had been referred because nobody could understand what exactly was the pathology she has. So we also actually, MRI was not very clear. It could not understand because we saw masses in the pelvis on the left side and there was only one vagina. So we did a vaginoscopy. You can see a nice uterus, cervix, and it was looking like a unicornate uterus. Unicornate means so one side ostia is there, the other side there is no ostia. And we came down, so it could be a diadelphys. When you see like that, it could be a diadelphys or a complete septum. We came down. As we came down, we could not see the other opening. So we thought that it is unicornate. You can see the cervix. There is a complete cervix is there, as you can see here. And on the vagina, we could not see a vaginal septum also, but we could see some puckering there. On the lateral vaginal wall, we could see some puckering there. And then we went laparoscopically. This was the picture we saw. It was a complete unicornate uterus with endometriosis on the other side, and it was looking like a rudimentary horn. But it was something little different. That rudimentary horn was looking too much lateral. So we could not understand what exactly it is. And the MRI was showing there was a vagina. There was a vagina in the pelvis. There was a cystic mass in the pelvis actually. So this patient actually had a vagina which was pulled up into the pelvis, and the entire rudimentary horn when vagina was going lateral to the external iliac. You know, the vagina rudimentary horn has to be medial to external iliac. So this was going completely lateral to the external iliac. So you can see the complete dissection. These are the cases which can be dangerous. If you do not understand that these anomalies can occur, you will easily go and cut the external iliac. You can see here, the complete dissection is there. You can see the external iliac. That's an anomalous external iliac. External iliac is again anomalous. There was no clear-cut internal iliac. The common iliac was completely continuing, and the internal iliac was much down after the uterine artery was given. The internal iliac was splitting after the uterine artery was given, because uterine artery was actually coming from the external iliac, and we had a rudimentary ureter which was attached to the vagina. We have again this rudimentary ureter attached to the vagina we have had in many cases, and you can see here, just 2 minutes, you can see here that is the ureter, and we dissected it nicely there, and that is the vagina where we have injected methylene blue into the cystic mass there, And when we injected methylene blue into that cystic mass, you could see that coming completely through the fallopian tube, as you can see here. That's a cystic mass injected. And you can see that completely coming through the fallopian tube there. And then we resected that rudimentary horn. That was the only thing which is possible. We resected it, and you can see that it's going completely lateral to the external iliac. That's a uterine artery. That's a uterine artery which is there. And we pull the vagina lateral from the lateral part of the external iliac. And this is the external iliac, and you can see the uterine artery. I would say this is the external iliac, or you can say the common iliac basically. And that's the uterine artery. You can see the anatomy, you can see the internal iliac going down here. That's the internal iliac beyond the uterine artery, beyond the origin of uterine artery. So thank you so much for your patient listening.
On behalf of Dr. Basavaraj, Dr. Mahesh, Suman Gaddi and myself and all the esteemed audience here, we would like to immensely thank Dr. Hafiz Rahman. Can you kindly be seated here, Hafiz, on the hot seat for the speaker before we call in the next distinguished guests and take a few questions if we are allowed to. Yeah.
I would like to thank Dr. Basavaraj sir for joining us, chairperson, KSOGA. And I request Hafiz Rahman sir to be seated on the stage as we have a felicitation session at the end of this session. And now I would like to call upon our next eminent speaker, Dr. Shailesh Puntambekar sir, to the dais please. Sir will be taking us through the journey from radical hysterectomy to uterine transplant. I would like to request Dr. Madan Kamble sir to introduce sir, please.
Thank you so much.
Audio
Hello.
card bhaiya.
Hello. It's my honor and privilege to welcome and introduce Dr. Shailesh Puntambekar sir. Actually, this person doesn't need any introduction. Everyone knows sir. Still formality. Sir is a medical director at Galaxy Care Hospital, Pune. He is an international laparoscopic surgeon and robotics surgeon. Currently, he is working as consultant oncosurgeon at KM Hospital, Pune. Welcome you, sir. And the dais is yours.
Good morning, everybody. At the outset, let me thank Dr. Durga Prasad for inviting me for this wonderful conference. When I met him in Bangalore, he insisted that I should come and talk on the topic, which is very close to my heart, and thank you, all of you, for coming in large numbers. In the next 20 minutes or so, probably I'll take you through this wonderful journey of radical hysterectomy to uterine transplant. So this is a journey of 1,000 miles, but it began with a single step. If you see the history of radical hysterectomy, the first radical hysterectomy was done by Overdymes, and then it progressed to laparoscopy and to robotics. I did my first radical hysterectomy in 2002, and these were some of my milestones, and this is where we also did the first live transmission of radical hysterectomy to the AAGL. But the eureka moment came to me in 2017 when we did the first laparoscopic uterine transplant. In this process, what did we achieve? We achieved that we could understand the anatomy better, and then we coined the term called as predictive anatomy. So anticipate your structures before they come. And it was all about anatomy, anatomy, and nothing else but anatomy. So much so that these sentences were used worldwide. Fat belongs to the rectum, fat belongs to the bladder, and remain parallel to the tubular structure. So it was all about anatomy. And when we were actually unraveling the mystery of anatomy, we realized that in 2002, when I did my first radical hysterectomy, there were very small numbers, though the first radical hysterectomy was done in 1991 laparoscopically. So for 11 years, this surgery was not progressing. So if you see this, this was the first publication, 8-year experience of 50 radical hysterectomy. So understand the numbers per year. They didn't have the numbers, so there was no standardization of the procedure, and the procedure just did not progress. When we entered, this is with the area that it is very easy to defeat someone, but it is very hard to win someone. With this thing in mind, we started what was considered as most impossible.
The those who dare to imagine the impossible are the ones who break all the human liberty.
So we started and we entered the world of laparoscopy oncology. At that time, the world was completely dyslexic to the use of minimal access surgery in oncology. So in 2002, we did our first radical hysterectomy, and this took us more than 8 hours. And I vowed to myself that I will never do it laparoscopically. The important thing was, when I saw the patient next day, the patient started walking. This had never happened in my life with open radical hysterectomy. And those days, this was a time when I used nothing but the bipolar scissors and nothing but the monopolar scissors and bipolar scissors. So this was the way that we did radical hysterectomy. And then we progressed to very, very basic instruments. If none of you remember, this was a 10 mm harmonic probe. With such a large probe, we started doing radical hysterectomy, and of course using different energy sources. Then also different methods. We used the colonoscope through the vagina, and through the vagina I used the colonoscope and did a single port radical hysterectomy called as the OASIS, Orifice Assisted Radical Hysterectomy, wherein I put the port down and then you can see the colonoscope going through this, and then 2 ports, we use the colonoscopic camera and just 2 ports in the entire umbilicus to complete the procedure. That's when we realized that this is the non-duplicable procedure and should not be propagated at any point of time. Unfortunately, no standard protocol, less patient acceptance and less acceptance from the colleague was the trigger to develop a better technique. Change of mindset is what we needed, and adaptation to the newer technology. So we started developing a classical radical hysterectomy, which you have all seen in many workshops, and developed certain techniques which were important. But was it a smooth ride? No. We had a lot of problems in the initial days. We had problems of ureteric fistulas. We had problems of ureteric fistulas. You can see we had problems of the bladder opening. You can see this dissection over there, and all these were associated. So this is the bladder complication, and this happened in the first 20 cases of my radical hysterectomy. Not a very encouraging task for me. And of course, we had some vascular injuries, which some we could repair, some we could not repair. This is the external iliac injury. And then we also had a complication which actually put me back by 10 years when we started doing the para-aortic dissection, and we had a vascular injury. You can see on the kidney side, and this was a renal vein which began bleeding, and this we could not control, and we had to open the surgery. So not everything was flowery. It didn't happen overnight. The success didn't come overnight. We had our share of problems, and this is what happened. These complications, we tried to repair it laparoscopically, and this is what was more important. Because if we had the complication, then why not do this entire laparoscopically? And this is what we tried to do. We tried to clear the ureteric fistulas we had, and we tried to repair the ureteric fistulas. We tried to repair the vesico-vaginal fistulas, and this also happened in the early years of my testing. That's when we realized that standardization of the procedure and good amount of colleagues who understand what I do is important. This was like a baseball diamond contract. We standardized the position of the patient, we standardized the port position, and of course we standardized the technique which we then published in 2007 as the Pune technique. And what was the Pune technique? This was a classical Pune technique. You have all seen this. We refined the technique into 6 baby steps. Step 1 was the posterior U-cut. Step 2 was a dissection of rectovaginal space. The entire mindset was to make the procedure duplicable and not related to just one surgeon. So knowledge of conventional anatomy, knowledge and adherence to the anatomical pace, and of course the teamwork. So instead of using the manipulator, because we did it, we started the first step, which was the posterior U-cut. You go from one infundibulopelvic ligament, taking the peritoneal cut into the rectovaginal pouch, and this was the first step of the radical hysterectomy, which we started doing. And then the next step was going into the rectovaginal space. That's where we coined the term fat belongs to the rectum. I remember Ramesh telling me that I knew where to go. You just gave the words to my mind, and this was very, very important. Fat belongs to the rectum. And then, of course, we did, this is one step which made me famous worldwide, the pararectal dissection. That is where you can dissect the ureter and go to the uterine artery in 30 seconds, remain parallel, push, and lateral to the ureter. This is how we could do this. There were 2 approaches that we designed, one medial to the infundibulopelvic, one lateral to the infundibulopelvic. The lateral one we called as the oncological method, and the medial one you can see parallel and lateral to the ureter. Just push, parallel and lateral to the ureter, and this now more than 600 people that I have trained use this to go to the uterine artery in 30 seconds. And this is the most important step that was absolutely important. Then of course the step 4 was to do the anterior U-cut from one end of the round ligament to the other. That's where the term was coined, fat belongs to the bladder, remain below the fat, and this is how we could do this. Then the dissection of the ureteric tunnel, which we use Maryland to avoid any kind of ureteric fistulas. And of course, this is how the lymph node dissection was done. Because there are no branches, no tributaries, just remain parallel and push. Parallel and push. So much so that everybody knew this in their mind. Just put parallel and push to the vessels, and you can see the entire nodes coming up. Because the anatomy doesn't have any branches, any vessels, had there been branches, this technique would not have been done. So God created the anatomy for us. We have to just use this anatomy in a better way. So this is how we used it, and of course we published this as the first radical hysterectomy from an Indian, and that's the time when we had the female president first time, and this is where we published our first case as radical hysterectomy, and we named this technique Pune technique. Had I named it as my name, it would have been a selfish endeavor, because when I achieved this, it was the patients who believed in me and the colleagues who believed in me. Therefore, it was a tribute to them that this is the true story we developed in our city, and that was very important. But the world did not believe us. Why did not the world believe us? Because we wrote that this radical hysterectomy can be done in 90 to 120 minutes. And when I published this in the American Journal, they said he's bluffing, so much so that there were so many letters to the editor, and I was allowed to do a live surgery to the AAGL.
Silas, one more thing. Thank you very much. Thank you. You've been vindicated finally, because as our members know, there's been some discussions in the AGO JMIC journal where people disputed your results time-wise, and you've proven to us that you work like a robot. I guess you don't need a robot there. I'm not saying that, okay.
So then we finished this, we were given 1 hour, we finished in 58 minutes, and 2 minutes we saved. So lessons learned. Thank you very much, better understanding the anatomy and involvement of the peritoneum. Then, of course, we realized that these patients that we were doing radical hysterectomy were having a lot of bladder problems, and this was the most important thing. So we developed the nerve-sparing radical hysterectomy. Not everybody can dissect the nerve. Again, the idea was how to make it duplicable, and that's when we realized that the best part of doing the radical hysterectomy is to suggest a thing which is an anatomical landmark, and that's when we devised the landmark. If you cannot dissect the nerve, how do you understand to preserve the nerve? So dissect the uterine vein, which comes from below the ureter, take the uterine vein, medial to the ureter, the nerve gets automatically preserved. One anatomical landmark made a lot of people understand that nerves did not be dissected, but nerves can be preserved. You can see the uterine vein just take the uterine vein, clip the uterine vein medial to the ureter because the nerves go below the uterine vein. And that is what made everything realized. And that's when we realized, and then of course, when we had the ureteric fistula, we implanted the ureter into the bladder, first ureteric implant into the bladder in the world, cysterneo-ureterostomy, for which I won the first Golden Telescopic Award. I thought that this was a landmark because after that, the ureteric complications could be easily handled by everybody. So this was a thing which was there, and of course then we won. Following the radical hysterectomy, the natural progress was to exentrations, preservation of the autonomic nerves. But the most important thing which I take pride, that this procedure was now duplicable. Every Tom, Dick and Harry could do this procedure. Because when my boss said, only I can do the procedure, I always used to wonder what will happen when he dies. Who will take this procedure forward? So this was my thing. McDonald's burgers, same size, same taste, worldwide. India has to create the same thing, and that is what we created. So technique is duplicable. More than 600 surgeons were technology, and of course it was an oncological wonder. And this later on progressed to doing a lot of exentrations, and this exentrations was there. So our Golden Telescopic Award number 2 came for exentrations that we did in the world for the first time. This was the laparoscopic posterior exentration, and of course this was the most important thing. From exentrations, we progressed to radical hysterectomy. We were the first to use the robot in 2009, when nobody even imagined using a robot for radical hysterectomy, and this was a radical hysterectomy done with the robotic technique. Then we published the robotic technique. Again, nothing was left to just words. It was with publication. You can see the robotic radical hysterectomy, which is in published. Then came the next robotic system, which was CMR, which also I used for the first time in the world, and this is a robot which was developed by England. So it is developed by UK, and the first robotic surgery in the world was done in India on 15th of August 2019. And I'll tell you the reason it was done on 15th of August, because the relationship between a robot and a surgeon is master and slave. Now the master, which was the robot, was developed by UK, and the slave was developed by UK, and the master was an Indian. So we gave it back to the UK people that you are now the slaves of the masters from India. And therefore it was done first time in 2019 on 15th of August. Various robotic radical hysterectomies and exentrations were done. I will not take you through this video, and we will show you that we had published all this laparoscopy, radical exentrations, posterior exentrations, and total pelvic exentration. So all varieties were done, including the urinary divergence, completely laparoscopically. And if you go and read the literature, we were the first to do laparoscopic exentrations in the world also. So we all progress, and then this is what we publish: duplication of conventional multiple ports, first publication going against single port, because single port is not duplicable, and that is the technique which should not be done, that we said. So this is what we did. Nerve sparing also, single institutional experience, and our radical hysterectomy experience of 910 remains the highest experience which was there. So it is not related, this is like Olympics. So do not wait for getting the gold medal, just keep on doing your work. And then in 2018 came our landmark publication in the FIGO journal, Surgical Pelvic Anatomy, where we defied Gray, where we defied Frank Nater's anatomy, and published a lot of things which were not there. So much so that 2023 paper says contribution of us, fat belongs to the rectum, though wrong English, fat belongs to the bladder, remain parallel to the vessels, and two approaches to use the pararectal space: the medial approach as endometrial approach, the lateral approach, and all this is thanks to a publication from Dennis Curlo, who has given enough cognizance to this entire thing. Everything that I said is published, because my word is, if you don't publish, you perish. Nobody will believe an Indian in the world if you don't have a publication. Just telling the numbers doesn't make the difference. So there was a paradigm change in anatomy. Everything that I said was now considered as the landmark training in anatomy. Then came in 2018 the LAC trial, which prevented us from doing laparoscopy in cancer cervix. Everybody shouted, we did not shout, because whenever there is any kind of new technique and a level 1 evidence, don't answer the criticism by words, answer the criticism by work. And we published this. So we started, they used a manipulator. We published uterine hitch in 2009. And they realized that manipulator was the cause of local recurrence. 2009, our publication out now. And then, of course, they used to do the colpotomy without opening, without securing the colpus. The thing that Dr. Mitra taught us, Mitra's modification of Shauta, they were not following. So the tumor cells were falling into the vagina, leading to the entire area. So we started using Shauta's maneuver, but Mitra's modification. Laparoscopically, we used the bursting suture before we did the colpotomy. This prevented the vaginal recurrences. And secondly, this is the anterior parametrium. They did not do the dissection of the anterior parametrium, which is also called as the infrauretral parametrium. And this is what we saw. If you do not take the anterior parametrium, there is a recurrence. We published this, and this is a very big publication in the annals. You can see the anatomical dissection, for which in 2020, 2 years after the LAC trial, we won our 5th Golden Telescopic Award for anatomical description of the anterior parametrium. You can see that. And then this is also about the exentration. So ladies and gentlemen, Alexander Brunswick did the first exentration of the world and gave the message from Chicago to all over the world to do exentration in cancer cervix. We had the proud privilege to bring the laparoscopic version from India back to the world, because we were the first to do it in this area. And this is what we did first time. And of course, this is the exentration, the largest series so far published. You can see this is the gynae oncology. I'm not going to take you through the videos, but you can see that total, this is the review article 2024, which says that laparoscopic version was done first in India, another big international journal of surgical oncology. And this, I'm not going to show you all the videos, but you can see that list is very, very important. So don't tell people your plans, show them your results. This has been my motto in my life: speak less, work more. And that is the most important thing I would like to tell you. So with this we progress to our latest thing that we did, and therefore, just 2 minutes if I can have. So this is, from here we progress to making the dream possible in India, thanks to Narendra Modi. I will not take you through this. With the uterine viability, we started doing the laparoscopic transplant for 2 years of training that we did on cadaver. We did not progress. And of course, then with this, we did the first laparoscopic donor of the world. This is what we did. And this is the team of the operating surgeon. So we did not do only the transplant. We did the first laparoscopic donor, which was the first important thing that we did. And we, of course, use ovarian veins for the first time in the world, and we decrease so that the uterus can survive with one uterine artery and one uterine vein. This is what we did. So we did not use the internal iliac vein, and this is the publication of laparoscopic uterine retrieval. And this technique to use the ovarian vein first time in the world was done by us, and this acceptation of this publication was in 8 days, unheard of in an American journal, because we changed the paradigms in anatomy. And this is what we did. Of course, we did it, and in 2018, we had our first child through this transplant, which is there, and this was published all around. We did this with uterine pedicles. You can see the laparoscopic pedicle. Again, we made a history to do laparoscopic transplant 2 in a day in a civil hospital, that is a government hospital in Ahmedabad. And this is what we did, and all this was thanks to everything that we were there, so much so that our work was acknowledged in AAGL. Can I have the
last step of our evolution, but for the moment, because evolution is temporary, because always changes. In 2017, my very good friend Shailesh Puttenbecker translated this creative surgery under the eye of laparoscopic approach. And so the first uterine transplant with the laparoscopic approach, the minimally invasive procedure proposed by Harry Rich in the 80s, was performed. This is the further evolution.
So we are following the Gurukul Parampara, and we have been teaching a lot of people all around the world duplicability and duplicability. And with this, I received the AAGL highest award for mentoring more than 600 Indian surgeons and 300 international surgeons. Again, the highest award. It is not about individual, it is about we making it duplicable, making it possible, and therefore we are as a team. I always acknowledge my team. Had there no been team, we would not have been able to do this. And this is what is important. Our vision, anatomy remains constant. So ladies and gentlemen, it's not about the type of surgery. It is all about anatomy. And with this, with Indian degree, I have operated now in 51 countries all around the globe, traveling there and operating there. So your work speaks, degree doesn't speak, and you have to create all this, traveling all around the world. So find your path, leave your journey, transform your life. When others say it is not possible, I followed my dream, I followed my instinct, I presented my work with publication. So publish or perish, and continue to learn and teach people. That should be our life's motto. Thank you very much, ladies and gentlemen.
Thank you, Dr. Puntabekar. Please kindly be seated. I think Madan wants to be sandwiched between two stalwarts, so yeah, so you be seated there. See, the title of this was from radical surgery to transplantation. So the radical surgeons are right here in front of us, Hafiz and Shailesh Puntabekar, and they have transplanted the seeds of innovation, imagination, and creative thinking, and the path should begin with the first step, but the leap has been taken by the likes of you. So we congratulate you on a variety of achievements. You really make us proud. And since the chair is here, it's symbolic of the fact that the honors to be done by the team of KSOGA is in the process of making. So over to you, ma'am.
Yes, thank you, ma'am. Thank you, sir, for taking us through the journey of these incredible advancements. May I now request all the chairpersons to kindly felicitate Dr. Hafiz Rahman, sir.
Dr. Hirenmat, Dr. Durgadas, Dr. Shobha Guri, Dr. Nagraj would kindly join us, please.
Sir, to join the ceremony, please. Welcome you on the stage, sir. Dr. P.C. Mohapatra, sir. We welcome you to this dais, sir. All the dignitaries on the dais to kindly felicitate Dr. Shailesh Puntabekar, sir.
appreciation to these world-class surgeons. They have come to KSOGA. They have blessed this conference. We are so proud to honor them.
I request all the chairpersons to kindly move towards gratitude desk. We now move on to our next session, that is Dr. S.N. Kaulgod Memorial Oration. I would like to invite respected chairpersons for the oration, Dr. B.R. Barkol sir, Professor K.L.E. JGMM Medical College, Hubli. I would like to invite Dr. Keshav Murthy sir, Consultant, Senior Consultant, Obstetrician and Gynecologist at Adarsha Hospital, Tumkur. May I call upon stage Dr. Ambarish Bandiwat sir, Professor of Obstetrics and Gynecology, Al-Azhar Medical College, Kerala. Now I request Dr. P.C. Mohapatra sir to the dais. We welcome you, sir. May I now request Dr. Ambarish Bandiwat sir to speak about the importance of this oration, Dr. S.N. Kaulgod Memorial Oration. Over to you, sir.
Very good morning to all. I am really happy to introduce Sir. Dr. Kaulgod is known as a Sir. He is a noble man, great human being, library of knowledge, mastery over surgery. He has a magic hands. The first person in the medical field to be honored with Karnataka Rajyotsava Award. To his credit, he has donated maximum number of times the blood, more than 30 times. Very, very bold to face any challenges, any complications. Very skilled person. He had a fire to teach, transfer all his knowledge and skills to his students. He was the first person to start laparoscopic sterilization training center at Chalomba Hospital with locally available, very cheap instruments like cardboard boxes and colored rubber bands. Mastery in performing vaginal hysterectomy, trained juniors and encouraged and insisted them to do vaginal hysterectomy always. He had a magic wand in his hand. His surgeries were a feast to all our eyes, very interesting and informative, encouraging junior colleagues and students to learn things. very good organizational capacity. He organized All India OBG Conference in 1988 in Mysore. But unfortunately, we lost him in that year only. He couldn't able to see. A respected senior colleagues and offered founder president of our MOGS, and then he didn't become the president. Actually, he offered the presidentship to the senior most in Mysore, that is Madam Stephen. So that is his greatness. Though he started, he didn't become the president, he became a secretary to her. This shows her humbleness. Popularly amongst all the patients, irrespective of the religion, you will be surprised to know all the communities. Chalabamba Hospital is surrounded by the Muslim community. Actually, sorry to say this, he was so popular among those Muslim women. They wanted to see, हमारे को कॉलगुट सर को देखना है. This is a thing that he has popularized. Popular among all the patients, and somebody used to call them, all used to call them as God. He is such a noble person, and in his name, this oration is being given by none other than the great P.C. Mahapatra, who will be introduced by my colleague chairman.
Good morning, everyone. Dr. P.C. Mahapatra, teacher par excellence. He doesn't require any introduction to this audience, but as a routine thing, I'll like to introduce him. He is a Professor Emeritus Obstetrics Gynecology. He was past President FOXI 2011, FOXI representative to SFOG 2014 to 15, Vidya Bhushan Award by FOXI and ICOG 2021, FOXI Lifetime Achievement Award 2023, IMA Odisha Lifetime Achievement Award 2025, Academy of Clinical Embryologists Lifetime Achievement Award 2025, Satisfied Soul as a teacher, and his life mission is born to serve, living for others, working till last breath. Teaching is my passion, to be a man rather than great man. Over to Sir for conducting this oration. Thank you.
Revered teachers of the teachers, my revered chairpersons, the Dean of Obstetricians and Gynecologists of all the societies of Karnataka, and the delegates of this magnificent conference, KSOGA, 35th KSOGA, organized by a team of veteran gynecologists of excellence in Karnataka. Ladies and few men, I don't know whether they are gentlemen or not. Well, at the outset, I'm really honored and blessed by all of you to be standing over here to give this prestigious oration in the name of the legendary teacher, surgeon, and academician, Professor S.M. Kalgood. And it's really, I think, I feel honored personally. I don't know whether this is I can give a justice to this oration or not, but you have selected me as an orator, and I really pay tribute to this great legendary person as a teacher, and by virtue of experience of a teacher for the last 4.5 decades, I think I am privileged and honored today to give this oration for that. Well, the organizing committee, and particularly Dr. Durga, has impregnated me 9 months before and made me fertilized. And 9 months before he was telling that yes, KSOGA 35, you have to come and you have to give an oration in favor of a great legendary person. Thank you very much for the love and affection given to me. And in the last, I'm really skeptical. I'm feeling nervous after the two veteran speakers, Hafiz Rahman and Sailesh, speaking before me. I feel nervous whether I can do anything more than that. And the lovers of vagina and the lovers of umbilicus, these two persons are the lovers of umbilicus, I'm one of the lover of vagina for that. I'll change my topic to this particular aspect as per your requirement for that. Well, I bring greetings from the place of Lord Jagannath. Now there are various conferences. Today itself, there was a conference. I came back from Durgapur to here. I found that yesterday and today, there are about 6 conferences in the subject in the field of Faculty of Obstetrics and Gynecology in the country for that. And if you count 365 days, all days, there are more number of conferences, particularly in our Faculty of Obstetrics and Gynecology for that. So the definition of a conference, I say, conference is a conglomeration of elite people where one alone knows nothing, and together with the group, after knowing many, many things, cannot do anything. But this conference is something special. This conference is something special. I went to the scientific brochure and the program for the whole couple of days for that, including the workshops and the total program. I think it is definitely different from this conference. And the preceding 2 lectures, 2 beautiful orations by these 2 legendary persons have explained this and justified this, that this is something different for that. Another unique quality in this conference I found out, that there are no stalwarts and there are no outstanding personality. In the stalls I visited, stalls are empty, nobody is in the stalls, and nobody is standing out, everybody is inside the hall for that. And that is the uniqueness of your KSOGA 35th. Everybody will remember that for that. Well, Shova and the team has told that yes, you should be speaking on some subjects, some difficult vaginal hysterectomy and how to tackle for that. And as a gynecologist and a signature of gynecologist, I think this is very, very important for all gynecologists for that. So the basic concept of any surgical procedure, selecting the right patient for the operation, and if there are 2-3 modalities, you have to select the right operation for the patient, and third is performing the operation correctly, the skill which Silas has always emphasized for that. And last, post-op care. One of the most important post-op care is a good piece of surgery. You do it and forget it. Don't see the patient for that also. And that's important when you develop a good skill for that. And knowledge and understanding of the physiology of reproductive organs, pathology and clinical manifestations of pelvic disease, and dynamics of psychosocial and sexual development is mandatory as a pelvic surgeon, as a gynecological surgeon. I am reminded about 20 years back, there was a live workshops in Hyderabad, where a general surgeon had done a beautiful TLH, total laparoscopic hysterectomy for that. Not a single drop of blood was there during the whole of this surgery for that. So the whole crowd was really exhaled for that and congratulated the surgeon for that. And I was chairing the session. Unfortunately, the surgeon wants a comment from the chairperson from me. I have to comment. I was keeping quiet. When he poked me, I had to give a comment for that. I commented, the dissection is fantastic, but the decision is dangerous. So everybody cowed, and the surgeon felt nervous for that. I told, in a 38-year-old lady, multiple fibroid of 14 weeks, yes, it's important that you are doing and symptomatic, not relieved with medication. Hysterectomy is justified, and laparoscopic hysterectomy is absolutely justified in this particular case. But he has chopped both the ovaries. Ovaries are normal, and both the ovaries are chopped. So the decision is important. The surgery means it's not only a dissection, but the decision is important for all surgeons, maybe general surgeons, maybe gynecological surgeons. Now the glamour, fortune and commerce still evolves around hysterectomy. Complications likely, but more often with simple cases, not with difficult cases. Whatever you have imagined, that whatever complications are, most of the complications occur with simple cases, with overconfidence. If you have difficult cases, you become cautious and complications are less. Will to perform and skill to acquire is the theme for that, and no dogma in science. I think if there are 3-4 different types of surgery, either an abdominal, laparoscopic, robotic or vaginal, there is no dogma in science. Because I am a vaginal surgeon, I will do vaginal all cases. Because I am doing a laparoscopic surgeon, I am doing a laparoscopy in all cases. No dogma in science for that. It is not the need of the patient is most important, not the mood of the surgeon. So mood of the surgeon is not to be taken care of. The need is important for that, and that's why you have to decide for that. And if you go to the history of these different modalities of hysterectomy, First vaginal hysterectomy is 1813. 1813 was the first vaginal hysterectomy. Then first abdominal hysterectomy in 1863. And first laparoscopic hysterectomy by Hari Rich in 1989. And that is the history tells that vaginal hysterectomy is the one oldest recorded in the history for that. So difficult vaginal hysterectomy, my talk will be concentrating on that. What are the difficulties? There are two main factors for that. One is a patient profile, another is a surgeon's profile. Patient profile, large uterus. It's a large uterus, I will not be able to do it. Fixed uterus, because of the adhesions. Previous surgeries, nulliparity, there is not ample of space in the vagina, and concurrent adnexal removal is required for that also, so that these are all difficult vaginal hysterectomy. And surgeon's profile is a fear psychosis is most important. Skill development and training is required for that, and of course the surgeon's dogma for that. Let us find out the large uterus. The large uterus, what is the optimum size for vaginal hysterectomy? There should be a limit for that. And that limit is variable from person to person. As experiences increases, the size also increases for that also. There is a recommendation, global recommendation that 12 weeks is the standard size for that. You have to remove vaginally. Beyond that, it is there. I always agree. If somebody asks me what is the size of the uterus to be removed vaginally, I say, what is the size of the fetus that is removed vaginally? So it's about 36 weeks size. So 36 weeks uterus can be removed also by vaginal route for that also. So if the vaginal can admit about 3 kg baby, why not 3 kg uterus would come out for that? This is a fantasy. I cannot say that this is the thing. So this is the case I'm demonstrating the multiple fibroid. In the first case, the large case, about 24 weeks size the multiple fibroid. So in the case, this is a paras women, para 2, vaginal delivery. And here we always use the, nowadays after 2005, I've left our suture and always with the vessel sealing devices, we head up for that. And here, the vaginal hysterectomy, the myoma, you go to the correct space. That is the secret, that is the key. If you go to the correct space, you find the correct space is there, even large myoma can come out without bleeding for that. And that is the important, the pathology of the uterus is very, very important for that. And this particular case, I'm telling that this is a case where it was higher up, and before normally the myomectomy should be done. After the uterine has to be tackled for that. But it's not possible always for that. But if the space is good, if you're going to the right cleavage, I think it can be done, removed very easily for that. So this is important, that debulking and myomectomy is very important for that. And therefore I say that the cephalocaudal versus transvaginal, I think this is important. Normally we say that is a 24 weeks, means cephalocaudal, but the transverse dimension is ignored for that. If the transverse dimension is more and uterus is 16 weeks or 14 weeks, it's more difficult than the cephalocaudal where there is a fundal fibroid of about, and it's a 24 week size uterus for that also. So that is important. So the sonographic estimates is very, very important now. The important machines are there, the mapping of sonography is there, so that you can map the site of the lesion and the volume of the lesion. Normally what is there in the sonography, there is a different misinterpretation of the dimensions. So the size is most important. The dimensions, say for example, if it is more than 10 centimeter, I always say clinical examination correlate, the uterus is about 20 weeks size for that. It's absolutely fallacious to find out a dimension. So the volume is most important, measurement of the volume for that. And then last is the uterine pathology. Myoma versus adenomyoma. Myoma like this, you can easily deliver it even if it's a big size. But adenomyomas is very difficult, and you have to do a debulking piece by piece for that also. And more so when it is transverse, the location, dimension, number, calcification, all the parameters for that, and therefore the mapping is very, very important for that. A posterior myoma is much more easier than an anterior myoma for that, and therefore the location is very important, and sonography can demonstrate all this. Now previous surgeries. Previous surgeries, earlier the cesarean section was the contraindication. Previous myomectomy was the contraindication. Previous positive repair, amputation, or a previous adnexal surgery was the contraindication for that, in vaginal surgery for that. Now no more. I think series set has given a lesson for that, and the concept is the lateral vaginal space is very, very important for that. The main problem of the previous cesarean section is the central dissection. The bladder is adherent for that. So go from lateral to medial, and even with the 2-3 previous sections. The first case is a 3 previous cesarean section with the myoma. And same philosophy, same technique I have adopted, that lateral vaginal space, and then come to the medial and separate it, and don't push it. The blunt dissection, don't do it. Always with the scissor and the sharp dissection in the proper cleavage, you go for that. And cesarean section is no more a contraindication for the vaginal hysterectomy for that. Even myomectomy. Again, the site of myomectomy, site of myoma there, and the procedure, whether it's done by laparoscopic myomectomy or an abdominal myomectomy. Normally in myomectomy, the adhesions are there in the distal part for that. So be very cautious about that. If there is an adhesion, see that there is no gut in that, and gradually with the vessel sealer, you can eliminate the problem. Father's repair or amputation, the main problem is their initial phase. To get the space above the cervix is important for that. Once you get it, I think everything is settled. There is no problem for that also. And previous surgery, adhesions, undiagnosed endometriosis. In many cases, you do a vaginal hysterectomy, you have not suspected endometriosis, but the whole erectosigmoid is adherent for that. Don't convert it. You have to complete it vaginal route, and it's completed. There is no problem. Because earlier, the concept was that open the A pouch, open the P pouch. No more. Don't open pouch. And really you go, and Silas concept, go closer to the uterus and fat belongs to the rectum and fat belongs to the bladder. Same principle we adopt in the vaginal case for that also. And therefore, you go closer to the uterus, rectosigmoid is safe for that, and you can complete the procedure. In fact, purposefully knowing that it is an endometriosis, I have tried a couple of cases vaginally also. You should not. You go for a laparoscopic procedure for that, if you know that is a case of endometriosis. But I have tried for that, and the same technique I have adopted, closer to the uterus, you can really deliver the case for that. Even some cases when I put a laparoscope, I didn't find anything. The whole thing is pasted. I couldn't find out the uterus and all that. Even with the lateral dissection, lateral pelvic wall dissection also, it's very difficult to get it. I started vaginal, completed the procedure, put the laparoscopy and find out, and the situation, I think the bleeding or the ovarian remnants can be removed through that also. We call it, people call it total laparoscopic assisted vaginal hysterectomy. I call it vaginally assisted laparoscopic hysterectomy. I think VALH could be another form for that also. Now nulliparity. Nulliparity again, because of the lateral vaginal space is less, and therefore it is difficult. But it's not an absolute contraindication for that, because nowadays the suture, we are not using the suture, the space. For the suture we require a normal space for that. So the vessel sealer, they developed for that, starting from the sealer with the mechanical blade, or even with the shearer. Shearer is an Indian context. Indigenous is India, genius is indigenous. Shearer is a concept where you coagulate it, and the tip, the current strength is much more. And therefore, after the shearer has been there, the harmonic people are begging for that also. They've almost all surgeons have left the harmonic, particularly replacing by shear for that. So this is another case. I designed this by me, and this is by the German people, Martin people, where a coagulation is there, and then automatically, if you press it, there is a mechanical cut or a blade is there and cuts it for that. And without cut also, the current also cuts, and this is in case of the nulliparity. Even if with the inadequate exposure, difficult lateral vaginal space, and lack of pelvic relaxation with the top tissues, it can be done for that. Now, about the adnexal removal. This is the case where adnexal removal, people say that when the ovaries has to be removed, don't do vaginal hysterectomy. You do it by laparoscopy. No more. I think normal cases is very important that adnexa can be removed. The only thing is that you hold the same technique, you duplicate it with the abdominal laparoscopy. Catch the round ligament first, separate it round ligament, and go and enter into the infundibular pelvic and remove it. And with really a good lighting and a retractor, it is very much possible for that. And more so with the vessel sealer, in comparison to the suture, it is much more easier for that also, and takes little time. And even if it slips also, the question of the coagulation serves the purpose for that. This is a case where hysterectomy, the case of a bilateral dormant tumor with abnormal uterine bleeding, and I started thinking of doing a 10 centimeter each on both sides, and dormant cyst with that. The other side says that salpingo-oophorectomy, which I have depicted about the separation of the round ligament and then going to the infundibular pelvic for that. And this is a case of vaginal hysterectomy with a dormant cyst, and you go the same technique you develop with that, and with the vessel sealer, you go for that. After removal of the uterus, I think the two adnexa in the upper pedicle, you catch hold of that and enter the, visualize the ovary, and there are two big ovarian cysts, the dormoid cyst of about 10 centimeter diameter. At the upper pedicle, I have given a separate clamp for that and removed that because the space was not there. Don't think that I will suture it, and this is only for having a good space for that also. I delivered the uterus and see the adnexa, whether the adnexa, what is the character of the or nature of the ovarian cyst, whether it's an endometriosis or it is a case of dormoid. But endometriosis, right from the dissection, we find that it's not a case of endometriosis. You find a big dormoid cyst, puncture it, reduce it, and I think put a clamp, the same thing, and it's very easy to deliver it for that. So adnexa removal means laparoscopy. Don't take it for that. The vaginal surgeons can remove adnexa from below, vaginal surgeons can remove appendix from below, vaginal surgeons can remove the gallbladder from below, and any structures can remove from below, because it's a signature of the gynecologist. They can do it, access it for that. Now, second is about the surgeon profile, the fear, psychosis, the factors. Will I be able to do it? There is no dissent. Uterine contour, dimension, and mobility could not be ascertained. Uterine size is large. Previous surgeries are scar, nulliparous, possibility of adnexa. This is the fear psychosis amongst the surgeon for that. And I think develop your confidence and the surgical technique you develop one step by step, and things will be removed for that. And don't think that it's a blind procedure with inadequate space and surgical field. Many people believe that vaginal surgery is a blind surgery. No, if somebody is saying that blind surgery, he should discard surgery and enter into medicine, not in the surgical profession. But the basic difference between us gynecologists and the surgeon, like Silas is not a classical surgeon. She is a combination, hybrid gynecological as well as a surgeon for that. And the basic philosophy between these two are that they cut and see, we see and cut. That is the basic difference for that. And therefore, see and cut. It's not a blind surgery for that. Don't cut and see and then manage the complications for that. Will I be able to do it? I will face complications. How to tackle? There will be hemorrhage, there will be rectal injury, bladder injury, ureteric injury, and others. I think in the medical curriculum, either in the postgraduate particularly, we lack in this particular training for that. We are very much apprehensive about the ureter. We are very much apprehensive about the bladder. Gone are the time we are very much apprehensive about the bladder. Now all the gynecologists are repairing the bladder if there is a bladder injury. They are not calling the urologist for that. But ureteric injury, they are very much apprehensive. Till today, they are calling the urologist for that also. And if there is a rectosigmoid injury, I think sleepless nights will be there whether to repair that or not. I think now there has been a lot of change. The prevention is important, and therefore the prevention is go closer to the uterus. If you go closer to the uterus, posteriorly, no rectosigmoid injury. Go closer to the uterus anteriorly, no bladder injury. Go closer to the uterus laterally, no ureteric injury. This is the mantra in vaginal surgery for that, to prevent complications. And if at all there is a complications, manage yourselves with that. And these people will teach us. They have taught us. The neurosurgeons have taught us, and the GI surgeons have taught us. This is what. And I blame the curriculum of the medical curriculum is mainly responsible for that. When I was an HOD in my college, earlier there were less number of postgraduates. Almost around 6 to 8 postgraduates in the whole 3-year curriculum. Now the seats have increased. I've got 22 postgraduates in each year, 66 postgraduates. So now I have distributed them that in the 3 years postgraduate curriculum, 1 month in gynec oncology department in cancer center for that. 1 month in the surgery department and for the GI surgeon for that. And 1 month for the urology department, 15 days for the plastic surgery department, 15 days for the anatomy department. I think that is important. The fear psychosis will vanish if we do that. Now, I will not be able to complete the procedure. Need for conversion or laparoscopy. If you are not able to complete the procedure, you adopt the laparoscopy, or even laparotomy, you do it for that. So people are egoistic. They are egoistic. People will think that I am inefficient surgeon, I am not able to complete the procedure. That is in the mind, and need for conversion is important factor. Post-operative period will be stressful for me. Previous bad experience of mine as well as others, always in mind, and lose confidence. If there is one complication, one rectosigmoid injury, you forget. I will never do in vaginal surgery for that also. Don't keep it in mind for that also. So prerequisites for difficult vaginal hysterectomy, pre-op assessment and planning is important. Anesthesia, the role of EUA should be done. In OPD, we have assessed the case and planned for vaginal hysterectomy. Again, examination under anesthesia, in the OT itself, you assess it, whether it's possible or not. Otherwise, you take help of laparoscopy or other gadgets for that. Special surgical techniques, the setup, the team, the anesthetist, assistant, paramedics, all are important. Gone are the time when the surgery was done, the quality of the surgery depends on the main surgeon for that. Now no more is the surgery of the team and tool by the gadget-oriented surgery. The quality of surgery is good. If the team and tool are good, then only the quality of the surgery is good in a gadget-oriented surgery for that. Now these are some of the equipments which is there for that. Prerequisites for vaginal hysterectomy. You see hardly 10 or 12 instruments are required. We don't display lot of instruments in the table for that. For vaginal hysterectomy, these 10, 12 instruments, even if it's a difficult case also, I do it for that, and I've customized this instrument, 10 instruments in one set, which can be autoclaved in the whole tray for that. And these 10 instruments are enough for that. And second important is the vessel sealer. The designing of the vessel sealer has really propagated us to do more and more difficult cases of vaginal hysterectomy for that, and that is important, vessel sealer. More so now with the Vitam, with the laparoscopy. People are used to do the surgery looking at the monitor for that. You do the same thing. And Vitam is the camera. You do an endoscopic camera in a difficult case for that and see the monitor and do the operation for that also with that. Or the surgicum is there in the camera monitor in the light, the surgicum is there and you can do that for that. And therefore, this is, and last but not the least, if there is a need for a laparoscopic gadgets, is there, you can do more and more difficult cases of vaginal hysterectomy. You are feeling confident that I'm in. So laparoscopic gadgets, if the setup is there, I think you are confident of doing more and more difficult vaginal hysterectomy and complete the procedure in that particular case for that. So measures to be about fear psychosis, optimum knowledge regarding pelvic anatomy and altered anatomy. We know the pelvic anatomy. You have clearly demonstrated, Silas has clearly demonstrated pelvic. But the altered anatomy, if there is a surgery, if there is an infection, there is an altered anatomy for that also. And altered anatomy has to be known for that. And understanding the surgical principles and philosophy, the decision and dissection should be important. Proficient mentor, the need, acquiring a good technique, preventive surgery and managing complications. You always do a preventive surgery. Don't take a credit of doing complications and managing complications for that. And a urogynecologic and GI surgical exposure, as I have already told, endoscopic exposure could be also there for that. Therefore, a gynecologist who is trained in endoscopy will be better doing more and more difficult vaginal cases for that. An ideal surgical temperament should be there. The philosophy of the surgery could be there for that. And these are the four important things: the conviction, inclination, perseverance and indulgence, paving the way for difficult vaginal hysterectomy for that. And descent. If there is no descent, we can do it. Gone are the time when there is a descent, we used to do a vaginal hysterectomy for that. Now the reverse is there. When there is a descent, they are doing laparoscopic repair. When there is no descent, we are doing a hysterectomy from below for that. There is a reversal. The science is changing for that. And access is not there. As you see, the equipment's designed and the equipment's access, they compromise with access for that. Size and adhesion. People say that I say that there is a mental adhesion in the brain of the surgeon rather in the pelvic cavity of the patient for that. Elaborate that. Man learns as he lives, and experience is the greatest teacher in the world. I feel that experience, as Silas reminded, there's complications. You learn from your own complications, you learn from your own mistakes and improve on that particular gadgets for that. And Swami Vivekananda has rightly said for that. And other factors like the surgical team, the efficiency, surgical tools, the limits of the surgical school, tools, surgical skill, upgrading the surgical skills and surgical technique, changing trends and changing techniques you have to adopt for that also. Handling complications, pre-op planning and mindset should be there for that. Which cases I'll be expecting this complication for that. Pre-op assessment should be there. Operative technique, meticulous, non-complacency, tissue respect, assessment of altered anatomy, surgical timing. Don't look at the watch and do the surgery for that also. People take a credit. I think surgical timing, don't do, and that I will finish it within half an hour for that also. Identifying your learning curve, more and more with the time and skill, you do more and more difficult cases for that. So preventive surgical techniques are the managing complications, early recognition of complications, managing it efficiently, and asking for help. Learning from experience. And one of the important things about the early recognition of complications, in the era of minimal invasive surgery like laparoscopy or non-invasive surgery like vaginal hysterectomy, the principle is that day by day, hour by hour, minute by minute, patient should improve. If the patient doesn't improve post-operatively, think about it, that says something important for that, particularly in the case of minimal invasive surgery, and that is the message we can give it. Preventing hemorrhage, tackling vessels, technique of dissection is important because the right space we can go for that. Coagulation, now the electrosurgery is there, bipolar vessel filling devices are there. You can suture also if there is a difficult case, there is no problem, you can suture it. Tackling generalized hemorrhage, dissection in proper planes can avoid that. Aqua dissection, spray, ABC and medical management and targeted areas, you find out for that. Don't be complacent that they're bleeding, I will have a put a drain and then come out for that. Drain is not for that. And you have to be absolutely very, very meticulous that, but in generalized oozing for that, I think as far as possible the primary arrest of the bleeding is there, then you can put a drain for that. But drain is not the approach for that. Approach to adhesions, recognizing the vital structures, recognizing the vessels, dissection in avascular space, dissection under tension, use of vessel sealing device, and finding the safety plane, both utrovesical and rectouterine. These are the two important planes of dissection and the lateral planes to prevent the ureter, as I have already told you for that. So the preventing injury to organs, again, I must reiterate again that bladder injury, ureteric injury, rectosegment injury and other vessels injury, the closure to the uterus is the key. Is the mantra, closer to the uterus, no injury will be there to either to the posteriorly rectosigmoid or bladder or the ureter or any other vessels for that. So have a surgical confidence, don't have an overconfidence on that. You should be crazed for surgery. From the beginning you should be crazed for surgery, and preventive surgery, mentor's influence and God's blessing, and the key for transforming operators to surgeons. There are innumerable operators in the globe, but very few surgeons. I think the time is there to convert these operators to the surgeons for that also. You mean that surgeons, what I mean by that, the decision and dissection should be there for that. And it's not a gifted thing. Yes, some things are gifted from the birth for that, but I feel that many things can be acquired for that also, and you can learn from your own mistake and update your knowledge and a clinical skill and a surgical skill for that, and transform yourself from operators to surgeons for that. So therefore, if you follow that, the big hole surgery, keyhole surgery and no hole surgery, abdominal hysterectomy, big hole surgery, keyhole surgery is a laparoscopic surgery, but no hole surgery is our vaginal surgery for that. And if you want to designate you as a gynecologist, and choice is yours. No dogma in science. Be lovers of vagina, don't be lovers of umbilicus and all that. For that. And every surgery, my teacher always says, every surgery is easy, every surgery is difficult. It is the surgeon who makes the surgery easy or difficult. You have seen Silas operating just parallel and go and all that, and no bleeding is there for that. And the same other surgeons are operating absolutely bloody business and all that, whole of the pelvis for that also. So the surgeon is important. It's the surgeon who makes the surgery easy or difficult. All of you must be watching a surgeon doing very well. You can say that it's my left hand, I can do the surgery for that. Another surgery you done by surgeon, we say that in my life I can never do a hysterectomy for that also. So this is the key importance of a good surgeon for that. Thank you very much, ladies and gentlemen, for giving me this opportunity. And really I am honored to give this prestigious oration in the name of a great legendary teacher and a surgeon and academician, Professor Kalgur.
Good morning, dear friends. And we are really happy to have Dr. P.C. Mahapatra for this wonderful subject, vaginal hysterectomy in difficult cases. And really it is a blessing for the freshers who are yet to learn and how to decide about the case regarding whether to go for a vaginal or in a mini lap or laparoscopic surgery. But I feel all the cases can be had through the vaginal surgery, and we have to really adhere to the hints Dr. Mahapatra has given. I really thank each and every of you to follow his guidelines, and really we can end up with vaginal surgeries. And whatever it is, the laparoscopic surgery setup is there. We can really venture on any surgery, especially vaginal surgeries. Any difficulties, we can switch over to laparoscopy and finish up the things. That is really an advantage. I thank you once again, Dr. Mahapatra, please.
Thank you very much, sir. As we are running short of time, I request all the chairpersons to kindly keep their talks brief and crisp. And now, I request all the chairpersons to kindly felicitate Dr. P.C. Mohapatra, sir.
May I call Dr. Vishnu Priya on stage and to be ready by the side, please. Call the patrons of KSOGA to felicitate sir
Rajeshri
and
Paldi, ma'am.
the
Welcome
immediate
you
past
to the
president and past presidents of KSOGA and the president-elect.
Dr. Bharati Rajshekhar, ma'am.
I am really blessed, we are really blessed today that the Guru of Gurus, Sir P.C. Mahapatra is there with us today. Sir, thank you so much for that brilliant lecture, for that demonstration of your, one of the finest surgeons in India. Beautiful vaginal approach. Sir, I request you to perform a little more for us now by, okay, let us read the plaque first, yes. Sir, it is my honor to read the plaque, sir. Karnataka State Obstetrics and Gynecology Association hereby confers Dr. P.C. Mahapatra the distinction of delivering the Professor S.R. Colgood Memorial Oration titled Vaginal Hysterectomy in Difficult Cases on the 35th KSOGA Conference, 2nd November 2025, held at Sri Gangadharaya Sri Siddhartha Medical College, Tumkur, in appreciation of his dedicated service to the upliftment of women's health and for being an inspiration to his fellow members. Thank you very much. We request you to stay on the stage for a few more seconds, and very importantly, I request the audience to have a few minutes of patience before the next Dr. M.G. Hiramat Yuva oration can begin, which is a very important part of this conference. We'll come to that in just a few minutes. We have a very pleasant task of giving prizes for the Gestosis Score competition. The Gestosis Score implementation is the flagship program and the idea of Dr. Durgadas Asrana. This is a preventive strategy for hypertensive disorders in pregnancy. The scoring is purely clinical and is done through an app which has been developed by faculty from St. John's Medical College, Dr. Vishnu Priya and Dr. Madhva Prasad, who is not here. And he's here? Come man, come. Good of you. So tell about the app and the prizes as quickly as possible.
On behalf of the Justice Core Cell of KSOGA, which was initiated by Durgadas Asrana sir 2 months back, this notice was put up, and sir, as an encouragement, had promised that the highest users for 2 months will be awarded. So this served as an encouragement for both institutional and private medical practitioners. Next slide, please. So, yeah, so this technological tool has been used by 1031 patients in just a span of 2 months. So 1031 patients have benefited out of this, out of which there were 807 usages from private practitioners and 224 usages from medical colleges. We now call upon the prize winners of the highest usage. Can we have among private practitioners Dr. Manohar from Mandya with maximum number of usages, Dr. Swati Kishore from Karthik Consultation Center with 127 entries. From institution and medical colleges, can we have Dr. Nagabhushan from District Hospital Tumkur and Dr. Pooja K.E. from Saptagiri Medical College.
Thank you. See, my vision is to, we have to do something to the society. With that vision I started this, sir. Implementation of Justice Score is one of the simplest thing we can at least reduce the incidence of preeclampsia. So what we did is we launched this project online through Dr. Sanjay Gupte sir and Dr. Hema Divakar, and the app has been developed none other than by the St. John's stalwarts, Dr. Vishnupriya and Dr. Madhava. Please download the app, and every day, once you see the patient, apply the Justice Score, and within 5th of every month, send it through the website, which Vishnupriya will, has already told. Once in 3 months we will assess. There will be 2 categories. One is the individual category, another is the institution, either government hospital or the corporate hospital or the medical colleges. And we have, to have some motivation, we have given some prizes. First prize of money 5,000, second prize 3,000, once again 5,000 and 3,000. And it will be given through the hands of stalwarts. And first batch is, we are fortunate to have Dr. Mahapatra sir with us, and I wanted this from his hands, so that it becomes a motivation for the subsequent doctors to implement this. I am very sorry for taking this time. Thank you sir, thank you.
Thank you, sir. A very big thanks to Dr. P.C. Mahapatra and to the scientific committee for giving us this time, and also to the audience for having patience. We have, yes, yeah. Name yenidu, Madhva? Already announced? Yeah. So we'll go ahead now. We have 2 conferences coming up by the next team. The next conference is at Mandya. Dr. Manohar will tell you about it, and following that, Dr. Rajeshri Paladi will announce the next annual conference, which is going to be held at Gulbarga. So over to Manohar. Dr. Manohar.
So good morning everyone. At the outset, I'd like to thank the Tumkur OBG Society for conducting a wonderful conference out here. And I also thank on behalf of the Mandya Ops and Gynec Society for the KSOGA team for having faith in us and giving the Yuva KSOGA. So we will be conducting the Yuva KSOGA in the month of April 4th and 5th, 2026. We'll be having on the first day 2 workshops, postpartum hemorrhage workshop, which will be attended by Dr. Samartham sir, and medical legal workshop in the afternoon session, which will be hosted by, along with the KSOGA members and Dr. Hitesh Bhatt sir from Mumbai. So we request, we'll try to keep up the best in Mandya, and as they have got a lot of hope, we request all the delegates to kindly make registrations, and we'll be reaching out to each of all the medical colleges of 77 medical colleges in the state and 24 societies, OBG societies, shortly within December, and registrations will be open shortly. We request all the delegates to kindly participate and make it a success. Thanks. Thank you a lot.
I'll request, when we indicate, you can please play the video. Yeah? The video, conference video from Gulbarga. Yeah. 1 minute, let us speak first. Yeah.
My pranamams to everybody assembled here for this wonderful conference. I stand with gratitude, with respects to all the seniors, to the patrons, and dear friends who have bestowed upon me this honor of being the president of KSOGA for the year 2026. And this onus on me lies to host and conduct the conference in Gulbarga the coming year. We expect to see you all in large numbers. The tentative dates are November 20, 21 and 22. Please come to Gulbarga and participate in this wonderful deliberation of scientific sessions that we have planned up. And this is a short display of what Gulbarga is. Please.
Yeah. Can I ask other from Gulbarga,
Please
to come on the stage?
President
very quickly.
of Gulbarga OBG Society,
Please
Dr.
come.
Annapurna, Vice President
This
of
presentation
Gulbarga
is
OBG,
spearheaded by the
Dr. Mahadevi and Rupa.
elect President of Karnataka State Obstetrics Gynecology Association, Dr. Rajshri Paladi. Dr. Paladi is a respected figure with decades of dedicated service to Gulbarga's medical community. Crucially, Dr. Paladi also holds the significant position of President-elect for 2026 for the Karnataka State Obstetrics and Gynecology Association. This team, comprised of senior practitioners, key administrators, and dedicated volunteers, represents the finest medical talent and leadership from the Kalyan Karnataka region. They are the operational core, ensuring every aspect meets meticulous local insight and professional precision. Gulbarga, now officially called as Kalburgi, is a major urban center in Kalyan Karnataka region, boasting a population and infrastructure base large enough to successfully accommodate and cater to a substantial state-level conference audience. Its status as a divisional headquarters lends it the administrative and logistical capabilities needed for such a significant event. Excellent connectivity with travel infrastructure. Delegates will have multiple convenient options for traveling. The newly functional Kalburgi Airport, codenamed GBI, offers direct connectivity, streamlining travel for national and international attendees. The Kalburgi railway station is a major junction on the South Central Railway, providing excellent connections to major cities across India. Gulbarga is connected to the nearest metro city, Hyderabad, via well-maintained national highways, making road travel efficient and accessible. The city is a significant center for higher education, particularly in the field of medicine. With 4 established medical colleges, Gulbarga is increasingly recognized as a medical education and healthcare hub. This presence of academic institutions demonstrates a sophisticated and a knowledge-driven environment, adding intellectual weight to any conference hosted here. The city offers a variety of comfortable and modern lodging options suitable for hosting conferences, delegates, and VIP guests. This includes Pijaspur Royal Tree Resort, SR Continental, which is conveniently located near the railway station, Grand Hotel, Hotel Dul.
So this is a brief introduction of the city of Gulbarga. Please come. Thank you so much.
We welcome you all with wholeheartedly. Thank you ma'am. And we from TSOG wish you all the very best for the next upcoming 36th KSOGA conference. We move on to our next session, that is Dr. M.G. Hiremat Yuva KSOGA oration. I would like to call upon stage the respected chairpersons for this session, Dr. M.G. Hiremat sir, Chief Patron, Founder Secretary KSOG, Director, Hatch IVF Matashri Women Hospital Hubballi, past President KSOGA. May I now welcome Dr. Durgadas Asrana sir, our own beloved President KSOGA. I welcome Dr. Shobha N. Goody ma'am, Secretary General KSOGA, Professor and Head of the Department, St. Philomena's Hospital, to the dais ma'am. I welcome you ma'am. May I now welcome Dr. Kavya Pradeep ma'am to the dais, please.
Thank you.
Thank you, sir. May I now request Dr. Durgadas Asrana sir to kindly introduce.
Start with you. Thank you. Good morning to all. At the outset,
It's a very emotional moment for me, having been the founder secretary of KSOGA 35 years back. And I'm happy to tell you that God was very graceful to me to keep me physically and mentally fit to attend all the 35 conferences. I owe great gratitude to all my KSOGians, particularly the office bearers, for having this prestige of chairing my own the oration session, which is a very, very rare event. We hear that orations are kept after they are away. The oration has been kept here when I am among you. I think this is the greatest happiness one can have, and I am very thankful to all the members and all the KSOGA office bearers. Please give them a very big clap to all the KSOGA past presidents and managing. I feel it is a very prestigious oration for two reasons. One is that we always think that orations can be given only by the seniors. Orations can be given only by the highest people. But we thought that let us give an opportunity to youngsters, those who are less than 45 degree and years, they should give this oration. I tell you, they have made rules so strict that even if I apply now, saying that I am less than 45, I will not get this oration. Such strict criteria have been given, and I am very great that the Kavya has come. Kavya was selected long back, 2 years back. Unfortunately, because of her personal problem, she could not give this oration. But this time again, she has excelled and she has scored highest marks in all the categories. Please give her a very big clap, and she is going to give the oration today. I request our KSOGA President, Dr. Durgadas, to introduce Dr. Kavya.
Good afternoon, everybody. I am pleased to introduce Dr. Kavya. Because of one major reason, she was selected as the as a orator last year, before 2 years back, and she could not, at the brink of the time, she could not come for the conference. And once again she applied this year, she was selected. What I mean to say is, persistently she had held her quality of work for 2 years, winning the competitions twice in fact, though you are getting a chance once. Here I am introducing Dr. Kavya Pradeep. She is a consultant, a clinical director and consultant in Navasrishti Fertility and IVF Center and NU Hospital, Shimoga. Her area of interest is infertility and reproductive endocrinology and genetics. She was the past chairperson of KSOGA Reproductive Endocrinology Committee, past secretary and past EC member of Shimoga OBG Society. She was a patron member and Youth Brigade PCOS Society of India and Youth Brigade of ISAR, clinical director at Navasrishti IVF and VC at NU Hospital, Shimoga. She has lot of feathers in her cap. She was a young doctor, talent award, and as upcoming role model in the field. Role model in the field of infertility at ISAR conference at Mumbai. PCOS Championship Award in 2024, bagged first prize in poster presentation in International Virtual Conference, Best Paper Poster and Award at ISAR Conference in 2020, faculty at international and national conferences, published many papers and articles in index journals, articles in Indian Express and guest lectures in various schools and public forum. Over to you, Kavya.
ಎಲ್ಲರಿಗೂ ನನ್ನ ನಮಸ್ಕಾರ. A very good afternoon to all. It's my privilege to stand before you all
who stand in the front line of reproductive health to deliver this oration. I extend my heartfelt gratitude to Dr. M.G. Hiremat sir, Founder Secretary of KSOGA and Chief Patron, whose dedication and visionary leadership have greatly strengthened KSOGA and inspired countless professionals across Karnataka and beyond. His commitment in promoting the medical excellence and nurturing next generation of doctors stands as a shining example of service and passion. And my heartfelt appreciation for the wonderful tradition of this Yuva oration, which gives a young doctor every year the stage to inspire, to perform, to lead and showcase their talent. Thank you, sir. I bring you the greetings from Shumaga Obstetrics and Gynecological Society and Navasrushti Fertility Center and NU hospitals. Every day, all of us help women and couples navigate some of the most intimate and emotional aspect of their lives. Yet one area that continues to challenge both medicine and society is infertility. Nearly 1 in 6 couples worldwide that struggle with infertility. We should just remember it is not just a medical condition, but it is a deeply emotional journey that affects millions silently. As gynecologists, we have frequently faced this situation and very often we have noticed this pain, and today we stand at the turning point to break all these barriers through science, support and strength. Breaking barriers begin how we define and discuss the infertility, ensuring that patient will understand it's a medical condition and it is not punishment and certainly not a reason for shame. Breaking barriers, it just doesn't imply that we are going to treat the reproductive health of a person. It should be like we need to treat the whole person through the science, support and strength. We all know there is a clock that ticks very quietly inside everyone. That is the biological clock, which is the real alarm and which does not stop for anyone or listen to us. It is just like a telomere. As we age, it shortens. In the same way, the ovarian health and the sperm health deteriorates as the clock ticks. And why I am speaking about this biological clock in this context? See, as the world is facing the population shrinkage globally, there is a declining fertility globally, and around more than 50% of the countries are below the replacement level, and most affected countries are urban and developed nations. The declining fertility has beautifully explained by Shobana Madam in the previous lectures. China once worried about overpopulation, and so it bought a norm of 1 child. And then now it is seeing the population shrinkage. That is, the total fertility rate is around 1, and India's fertility rate is 1.9, which is below the replacement level. Entire countries are seeing the birth rate fall below the sustainable levels. And one more area we are really worried about is male infertility, which is in explosion worldwide. I think all of you have seen in this reality picture in your WhatsApp group. Our great-grandmother had 12 children, and our grandmother had 9 children, and our mother had 4 children. Now, and all of us, majority of us might be having like 1 children. The future may head towards like extinction. As MB Bellet sir was telling, in Japan now the schools are getting closed. And just like I was discussing yesterday with the declining fertility with Shukla Shetty madam, she told me that just few months back she had visited Japan. In Japan, she saw a girl with a pram. Out of curiosity, she just peeped into the pram. She saw a cat wearing a frock. This is what our like future is heading towards. There are like lot of like delayed marriages, parenthood. I'm not against it. That like people are like our youngsters are like they are more of financial insecurity. They want to delay their marriages, delay their childhood. But they should remember that biological clock will not wait for anyone. And other in the modern era, because of this lifestyle factors, environmental toxin, and we know PCOS and endometriosis, and explosion of this male infertility, and increased access to these contraceptives are all causing declining fertility. This graph very well explains the progress and paradox.
Progress is like the women have fought to break the barriers of education, equality and expectation. But the paradox is the ovarian does not recognize the empowerment and it cannot recognize or rejuvenate the aging ovary. And one more cause we forgot is in 2020 and 2019, the roads stood still, the streets were empty, borders were closed, and the hospitals were full. But there was another silence too. That was an empty cradle which was waiting to be filled. COVID-19, it didn't just attack our lungs, it also slowly invaded our reproductive health. That is, in males, it hampered the spermatogenesis, resulting in a decrease in the sperm count and quality and corona-induced arthritis. And in females also, the stress and illness caused, impaired the hypothalamo-pituitary ovarian axis, resulting in menstrual irregularities, and we are also seeing the decrease in the ovarian reserve. Yes, in order to break all these barriers and in order to bring a smile on an infertile couple to fulfill the dream of parenthood, there are a lot of innovations in today's science to break these barriers. Sir Isaac Newton said, explaining regarding the journey of IVF, if I can see further, it is because I am standing on the shoulders of giants. In this context, the giants refers to great minds from the past, that is Robert Edward, Patrick Steppo, Pincus, Chang and Heap. Standing on the shoulders means we modern fertility specialists, using their ideas, discoveries, hard work as foundation, and today's innovation like ICSI, egg freezing, reproductive, like AI in reproductive medicine are all built upon this innovation. Before going in depth regarding the breaking barriers in female infertility, I would like to first talk regarding the male infertility, as it is less unspoken, as it is still less unspoken, as globally the male infertility accounts for 40 to 50% of the infertility causes. Yet in many consultations, the women bear the burden of these investigations and blame. There is a saying, when a couple struggles to conceive, society often looks at the women, but what if half of the answer is from the other side of the equation? So breaking barrier means it has to start initially from our consultation chamber only, like we need to break the gender bias. We need to change the narrative from her problem to their condition. We need to also break the powerful gender bias and with the other innovative methods. The breaking barriers in infertility, it started with, and these newer innovations has transformed the sterile males into father, marking a revolutionary shift in the scope of reproductive medicine. In male infertility, before we had a simple microscope to visualize the sperms, but now with the advancement of technology, we can analyze the sperm and even identify the subtle changes with the help of AI methods. And we can also assess the sperm at the molecular level by this DNA fragmentation. There are many strategies to improve this DFI, just to decrease the shorter abstinence level 1 2 day. And the antioxidants, yes, they have a certain role in decreasing the DFI. And if clinically, if varicocele is detectable, grade 3 to 4, yes, of course, surgery will help. And in case of previous failed IVF and high DFI, use of testicular sperm. And during these days, we have started using Zymote and microfluidics, which usually gives a highest number of progressively motile sperms with less DNA breaks, so that the pregnancy rate can be improved. This is a model of microfluidics where we are going to load the sperms in the lower chamber and the sperm wash media in the upper chamber. Through these micropore channels, the sperm, which are capable of good motility and less DNA breaks, will be collected at the outlet after incubation of 30 to 45 minutes, so that we can use it for the IVF or ICSI and also in IUI. The pregnancy rate when compared to the density gradient in an IUI cycle, definitely yes, this use of microfluidics has given us a better results. And another breakthrough in this male infertility is genetic and epigenetic changes. As we know, there are over 200 genes linked to the sperm production and function. The whole genome sequencing, by using this Y chromosome microdeletion in azoospermia cases, we can at least predict the percentage chance of getting the sperms. We often see in our consultation rooms that two men might be having the same semen parameters, but one may not conceive, the other may conceive. The fertility outcome might be different. This is well explained by the epigenetic profiling, where because of the lifestyle factors, substance abuse, nowadays we are seeing young males with 25 to 30 years, they are having substance abuse like more of tobacco, smoking, which definitely hampers the semen or sperm parameters. With the advent of ICSI, actually it was a turning point, making conception possible even with a single healthy sperm. And now in case of non-obstructive azoospermia, where it poses a challenge both for an experienced clinician and also an embryology team, this AI in sperm selection had paved the way so that even the hidden sperms can be identified and used for the procedure. This has been witnessed for the first time in United Arab Emirates under the leadership of this Dr. Ranjit Ramaswamy sir. Doctors at Dubai have located extremely rare sperm. The male partner, he had non-obstructive azoospermia. Now his wife is 14 weeks and running into a normal, healthy pregnancy. This is how the AI helps in selection of the sperms. It identified the best sperm. That circle, which is that green circle which is going around is like it is the best sperm which is capable of fertilizing and giving a good embryo. And one more witness to this artificial intelligence is the couple who struggled with infertility for 18 years and who had multiple failed attempts with the use of AI and microfluidics. 3 viable sperms, rare sperms were identified in 1 hour, and this resulted in a successful fertilization, and this was under the STAR report. The STAR is the sperm tracking and recovery method, where it uses hidden cameras are there to identify the rare sperms. And this lady is due for pregnancy in, delivery in December. And there are other regenerative and stem cell therapies which are still under research, the 3D bioprinting and tissue engineering, nanomedicine. In this nanomedicine, a drug which is to be delivered at the target system, they are in order to restore the function of the sperm at the cellular level. Usually they use this drug at the target system to restore the things. And this is still an emerging technology. Now coming to the breaking barriers in female infertility. Now clinics have started using these AI algorithms and the custom algorithms in order to choose the protocol, what they must be using for right dosages, timing of trigger and retrieval based on the hormonal profile, age and previous response. And the other is time-lapse imaging. As you all know, it is an embryoscope that it is a specialized incubator where it records each and every development of an embryo, and it takes the picture every 10 minutes so that and no need to remove the embryos out of the incubator, so that the embryologist can assess which is the best embryo that implants and give a best successful rate. And the other thing is endometrial receptivity error in case of recurrent implantation failure. Of course, yes, endometrial receptivity error tells us which is the best time to put embryos, resulting in a good embryo implantation rate. And the one more beacon in the field of reproductive medicine is pre-implantation genetic testing. By testing this aneuploidies, monogenic disorders, structural rearrangements, this has definitely increased the pregnancy rate, implantation rate, decreased the miscarriage rates, and given high live birth rates. In modern medicine, it is hard to imagine to practice reproductive medicine without this embryo or like oocyte cryopreservation, and even this has been beautifully explained in the previous lecture, so I am not going in depth. The fertility preservation for both medical reasons and non-medical reasons. Before, and this role of lymphocyte immunization therapy. Before, we didn't had any answer what was the, if there is any failure in unexplained infertility or in recurrent miscarriages and recurrent implantation failures. But yes, where immune factors are suspected to be the underlying cause, there comes the role of lymphocyte immunization therapy, where the lymphocytes collected from the husband is injected into the wife so that she develops the antibodies against it, so that after the embryo transfer, it tolerates the pregnancy, and this has been enhanced. We have seen the enhanced pregnancy outcomes via this lead therapy in recurrent implantation failure and in recurrent miscarriages. And we more commonly seen in our day-to-day practice women with poor ovarian reserve or decrease in the AFC count and so. So there are advanced hormonal and adjunct therapies in poor ovarian reserve. Use of DHEA or testosterone, it is available in the form of gel and DHEA in the form of capsules, where we will be giving in the pre-treatment for 2 months so that it increases the ovarian reserve, and also there is a role of growth hormone that improves the quality and we get more of M2 rates, and the use of supplements like coenzyme Q10, which increases the mitochondrial activity of the oocyte. And other regenerative therapies like stem cell therapy, these are the newer innovative approaches which aim to rejuvenate the ovaries by activating the dormant follicles and improving the ovarian environment. And one more thing is the platelet-rich plasma, where it can be injected through the laparoscopic or the vaginal route through opio needle. And this has emerged as a promising tool adjunct in reproductive medicine, both in case of decreased ovarian reserve and also to improve the endometrial thickness, thereby increasing the endometrial receptivity. And the other breakthrough is the artificial womb, where in 2025, the World Robot Conference in Beijing, China Kaiwa Technology has unveiled a groundbreaking innovation, the Kaiwa humanoid robot equipped with the artificial womb. This is still remains in an experimental stage, but China has told it will be unveiled even by 2026. And uterine transplantation, it has been beautifully explained by the stalwart Dr. Shailesh sir, making it a significant advancement in the field of reproductive medicine. And first it was done in 2017, and the country's first uterine transplant baby was born in 2018. There are like newer horizons, that is the potential future tool. These are not yet adopted in fertility per se, that is the gene editing using the CRISPR-Cas9 gene. This removes the faulty gene and replaces with a healthy gene. This is used only for the somatic disorders. It is not legalized in India. It is legalized in UK and US for sickle cell disease, beta thalassemia, transfusion dependent conditions. And the other is 3-parent IVF, that is mitochondrial replacement therapy. This is also strictly for a mitochondrial disorders, where the unhealthy mitochondria of the parent is removed and the healthy mitochondria of the donor is used. And it is, as we know, the mitochondria is the powerhouse. It is central to fertility and embryo development. Even this is not legalized in India. It is followed in Australia. As per 2025 statistics, there are 8 babies born through this mitochondrial replacement therapy. And one more, the world has witnessed this groundbreaking evidence, that is robotic or AI-assisted IVF system, which replaced the traditional manual process of ICSI. A person operating from New York, and this happened in Mexico. This is a milestone moment, definitely a milestone moment in reproductive technology, as it highlights the possibility of AI and robotic revolutionary fertility treatments by using this advanced technique. And the last thing is the US researchers have achieved a groundbreaking milestone, successfully creating early stage human embryos from adult skin cells in the controlled laboratory settings. All these are still in experimental stage. The second pillar is the support. Yes, counseling for the individual and couple is needed. There should be an awareness campaign mainly to remove the gender bias and legal reforms for the easy accessibility of this IVF and also surrogacy. And the third is the silent strength of the patients, of course, to try again, strength of doctors to innovate, and strength of families to stand together to support the couple. So my take-home message is, let us break the barriers through brilliance of science, the power of strength, the unshakable strength of human spirit. As gynecologist and fertility specialist, our greatest achievement not only be in helping the women to conceive, but in ensuring that no woman ever loses hope. And lastly, I would like to thank the whole KSOGA team for organizing such a wonderful event, and also Dr. M.G. Hiremat sir, Dr. Durgadas sir, Dr. Shobha madam, and Dr. Nagaraj sir for giving me this opportunity. And actually I was thinking I am growing old, my biological clock is ticking, but Hiremat sir made me think you are young and giving me with Yuva oration. Thank you, sir. Yeah. Thank you once again for a memorable experience. Nice.
Working? Is this working? Yeah. So very well done, Kavya. And that was a very comprehensive lecture. And we are very happy that you were selected actually this time. You made it through a very tough competition. And I think the panel of judges were all KSOGA presidents and past presidents. Now, you have taken us through a lot of, many barriers that you spoke of. And I'm very happy that you brought in the human element first. The stigma that society still has towards infertile couples. And if the anguish of that can be removed in some way by fertility specialists, I think that is a great service. And it helps them to go through the treatment very easily. Right now, the treatment sometimes feels more difficult than the condition itself because of the stress and because of the stigma and of course the cost. So you have brought in a lot of latest cutting edge technology. You apprised us of a great many advances and we really congratulate you for keeping a very cutting edge feel to your presentation. All the very best to you.
Thank you, ma'am.
And may you achieve all the advances that you showed today. God bless you.
Thank you, ma'am.
I request the judges who contributed to selecting her as the orator to come on stage. Yes.
I would like to call all Shumaga Society members to accompany me.
Can I have the EC members of KSOGA also to come on the stage because she's a young orator? Yes. Sir. Yeah.
Thank you, Dr. May I now request chairpersons to kindly felicitate Dr. M.G. Hiramat.
Yes, sir. So I request the past presidents of KSOGA also to come, whoever is here. And the EC members of KSOGA, some of them are here.
Meanwhile, an important announcement. Dr. Palani Velu sir's autobiography book is there for sale in the stalls. Kindly don't miss out on the opportunity to take one home.
Thank you very much, sir, for being such an inspiration for all of us. Thank you, sir.
I immensely thank all the KSOGA office bearers and all the KSOGians for this great honor. TSOG and Dr. Durgadas and his team.
Dr. Girija, please come. You should, yeah. And Rekha Murthy. Rekha, come.
Thank you, sir. May I now request dignitaries to kindly felicitate Dr. Kavya Pradeep, ma'am.
Come. Yes. May I read the plaque now? The Karnataka State Obstetrics and Gynecology Association hereby confers on Dr. Kavya Pradeepa the distinction of delivering the Professor M.G. Hiramat oration titled Breaking Barriers in Infertility with Science, Support and Strength
at the 35th KSOGA conference on 2nd November 2025 held at Sri Siddhartha Medical College, Tumkur, in appreciation of the dedicated services to the upliftment of women's health and to bringing the recognition in her to her fellow members. This is the plaque which says.
Thank you very much. I request all the chairpersons to move towards the gratitude desk, please. Now it's time to take a well-deserved break and recharge for the rest of the conference.
Thank you, ma'am. Thank you. Thank you, sir.
For your return and continued engagement. And our next session is Vivada Goshti, debate on the topic routine induction of labor at 39 weeks, to do or not to do. PM sharp, please. Welcome back from the lunch. I hope you all are recharged and refueled. Let's dive back in the renewed energy and enthusiasm. Let's move on to our next session, that is Vivada, Vada Vivada, debate. Get ready for a battle of intellects. The stage is set, the topic is hot, and the debaters are ready. Let's kick off this debate and see what insights we can give. I may now welcome Dr. Chinmay Kulkarni sir, CEO at Chinmay Infertility Center, Tumkur, Director. May I now welcome Dr. Lokesh CM sir, Senior Specialist MCH, GH Hodenarsipura, to the dais please. May I now welcome our debaters, Dr. Rekha Gurumurthy Madam, Professor, Head of the Department, OBG, Sri Devi Medical College, Tumkur. May I now welcome upon stage Dr. Aruna Muralidhar ma'am, and I request Dr. Chinmay Kulkarni sir to introduce Dr. Aruna Muralidhar ma'am.
Good afternoon, everyone. Welcome to a spicy session of debate. So, to introduce our first speaker, Dr. Aruna Muralidhar. She is a senior consultant, OBGY and MRCOG trainer. She is a consultant at Cloud9 Jayanagara, Bengaluru. She is a chairperson, Adolescent Health Committee, KSOGA, and author of 9 Months podcaster. Her co-curricular activities are singing, running, and gardening. Over to you, ma'am.
Good afternoon, everyone. So at the outset, I'd like to thank KSOG and KSOGA. Actually, it's not thank, it's just that I've offered to step in. So I'd like to first announce that the initial speaker was Dr. Srimati, and because of an unfortunate incident in her house, she was unable to take part in this debate, but she was very kind enough to share these slides with us, and we had a thought of even, Dr. Aruna doing both to and against, both the discussions she will put forth, because it's a very beautiful topic, need of the hour, and something which will help all the practitioners, and we didn't want to scrap this program. So at the last minute, I have stepped in
to have a debate with Dr. Aruna. I don't know how much of justice I'm going to do to this. I'll try to do the justice to this.
Sorry to interrupt you, ma'am. May I now request Dr. Lokesh CM sir to kindly introduce Dr. Rekha Gurumurthy, ma'am.
No, that's fine. That's fine. I think. So thank you. We'll have the concluding. Sir. It's okay. It's okay, Chinmay. No, it's okay. I think.
Good afternoon.
Thank you, sir.
It's my pleasure to introduce Dr. Rekha Gurumurthy. She's Vice Principal and Director PG Studies, Professor and HOD, Department of OBG, Sridevi Institute of Medical Sciences, Tumkur.
Thank you, sir.
Area of Institute, innovative teaching methodologies to make learning an interest. Position head, 24 years of UG and PG teaching experience in medical college across Karnataka and Andhra Pradesh.
Thank you, sir. Thank you, sir. We'll go ahead.
Thank you.
So what I was trying to tell you was, see, I'm not playing the sympathy card over here to win over Aruna. Don't sympathize with me because I'm the last minute speaker. Just judge me on actual capacity of the slide which is shared by Dr. Srimati, and whatever the credit which goes to how the debate goes is all I'm going to attribute it to Dr. Srimati. Okay, and she is heading the committee on research, and her slides are, over the top. I'll try to simplify. I'm a medical college teacher and try to simplify it for Aam Aadmi. Okay, so my thing is, I am for induction of labor at 39 weeks of gestation. So it is recommended in the interest of the maternal and perinatal risk to reduce the risk, and we have to weigh the risk and the benefit against the risk of continuing the pregnancy versus the risk of induction of labor. Induction of labor at the outset, I'd like to tell that it is not without its risk, but we have to weigh the pros and cons. So the risk of continuing, so we'll start off with the evolution of induction of labor. So basically it was started for maybe pelvic deformity and disproportion, where they're using the word right now or not, and lot of other indications like advanced maternal age, raised BMI, FGR, FTP, HIP. But prolonged pregnancy is one of the leading causes of induction of labor, why we consider it. Why in prolonged pregnancy? Because we need to reduce the incidence of stillbirths. Okay, so the absolute, some statistics over here, and that is the risk of stillbirth at 38 weeks of gestation is 1 in 2000, which increases to an alarming rate of 1 in 750 at the gestational age of 41 weeks. For us, it may look like a small figure, 1 in 750, that's fine. But for the person who has the stillbirth, it is 100%. We need to think about that. We have seen patients who come to us with 41 weeks, with stillbirth, and it's very, very painful to see that mother who's been through this pregnancy for 9 months and does not have a live baby to take home too. So when you are affected, definitely what. The other reason why we need to discuss this particular topic today is the race and ethnicity. So Asian babies mature early. Lot of statistics which point out towards this. There is early fetoplacental maturity among Asians, and also there's an increased incidence of meconium stained liquor in advancing gestational age. We'll just look at 2 stats over here. What happens at 38 weeks of gestation, which is the meconium staining is at around 8.6%, which increases to 41 weeks, which is 24.4. I'm not going to 44 weeks at all, but these are the stats I just like to mention here. And okay, so lot of, I'm not going through this because of the paucity of time. Let's quickly look at all these evidence-based medicine, which says the minority of South Asian population have an increased, have a higher, earlier fetal maturity. Okay, the concept of gestational age, what I would like to tell, the last word is that 39 weeks of gestation is now the new 40. So induction of labor at 39 weeks of gestation reduces the problems associated with prolonged pregnancy. Okay.
Coming to, yeah, so maybe like, when we are talking about most people, we think go with nature, go with, what is naturally happening. That is what most people would tell. But we are also trying to go with nature, but we are thinking of the placental alarm which is ticking early. Okay, so and also another thing is perinatal mortality. These are the studies which was published in Nature America, and the perinatal mortality is 13% higher and the absolute rate of stillbirth is higher in South Asian women. At 41 to 42 weeks of South Asian born women, it is nearly 5 times the risk of stillbirths compared to the Australian population. So we need to keep this in mind whenever we are talking about this induction of labor, the feasibility or the wise, whether it's a wise decision or not. Okay, so this is about fetal surveillance, skipping to what are the risks after 39 weeks. So abnormal CTG may not be there. Nearly 40% of the healthy women, apparently healthy mothers, experience perinatal compromise is something I'd just like to highlight. So we have to balance between continuing the pregnancy and delivery at 39 weeks of gestation. Let's have a look at what the NICE recommendations say. It says consider induction of labor at 39 weeks. Okay, because of, especially in this population, that is the Black, Asian and minority population. And it is reasonable for obstetricians to offer, this is what we are talking about is the ARRIVE study and ARRIVE trial, where they said elective induction of labor to low risk nulliparous women. Okay, what are the risks? So historically we have always thought of induction of labor is associated with higher risk of cesarean deliveries, but the evidence is not pointing towards it. So the women who have undergone induction of labor have a significant lower cesarean delivery rates, lesser hypertensive disorders of pregnancy, and there is no associated perinatal adverse outcomes. So there is a reduction. This is all the studies which are saying. I am repeating the same thing here. So elective induction at 39 weeks of gestation reduces cesarean, peripartum infection, respiratory morbidity, meconium aspiration syndrome, neonatal intensive care unit admission and perinatal mortality. Okay. So women with, who continue pregnancy beyond 39 weeks may progressively have a lesser likelihood of a successful vaginal delivery. This is what the data says. So 39 weeks is the ideal time for us to induce labor in these women. So yeah, this is what the Cochrane study of 2020 says. Elective induction at 39 weeks of labor of gestation is likely to be safe and beneficial. And what are the other other advantages that we have? The logistics, when we talk about the logistics, and this study talked about obesity, age, more than 35 years, Paris women, in all of them it was found to be beneficial, and the Indian experience also supports it. And the logistics, when you are electively inducing labor, the logistics say that you can have better planning, and the women tend to have a better mindset, they're mentally prepared, and we take care of the stress factor, and they will more likely to have a successful vaginal delivery. So respect the autonomy of the patient. So, and the last word what I would say is, summarizing, the benefits are less HTPs, less stillbirth, less cesarean sections, less of lower 5-minute Apgar scores, decreased respiratory morbidity, reduction in the MAS and NICU admissions, less perinatal deaths, and the only risk of, there are no risk of, continuing the pregnancy. Consider the value, the options for the patient, value her opinion. The staffing and facility resources can be optimized with planned induction, and if you have a robust plan, then there is less chances of a failed induction. Audit all your inductions so that you know how to do it best. So with this, I'd like to end my talk saying routine induction of labor at 39 weeks, emphatic yes. Thank you.
Thank you, ma'am, for that wonderful talk. I now invite Dr. Aruna Muralidhar, ma'am. Over to you, ma'am.
Thank you. I have my slides, please. Dr. Rekha, indeed a very, very worthy opponent I have today. So yeah, I mean, She started by saying a big emphatic yes to elective induction of labor at 39 weeks routinely. So the question here is routine, and that's the emphasis that I want to pay all of us. So how many of you actually routinely induce your patients at 39 weeks? We've got how many? Okay, out of maybe about 100 here, 4 hands or 3 hands are going up, right? So let's start off with this. I would like to say an emphatic no. And if I place buttons in front of you, you would always, I'm sure, would press no. Because it all started with this ARRIVE trial. It us. Yes or no, the ARRIVE trial. Now when you look at it in detail, right, it was done in the US. It was a multicentric randomized control trial in a high resource setting, Caucasian mostly, high resource, and they looked at low risk nulliparous singleton women, highly selective population. They also looked at elective induction at 39 to 39 plus 4, okay, and expected management up to 42 weeks. Now, how many of us are willing to wait till 42 weeks in our Indian women? We're not going to wait until 42 weeks. So we are comparing against a very, very different standard. For us, beyond post terms, we don't wait beyond a week at the most, right? So we're looking at 40 plus to 41 weeks here. That is our comparison here. Then they looked at, 6,100 women. It's not like 10,000s or a lakh, right? The power was low. Then you go to lower cesarean section, well, no significant differences in the neonatal outcomes. There you go. You're not doing it for the baby, right? No, lower cesarean section in the 39th week IOL group, about 3.6% absolute reduction only, right? Then, when you induce labor at 20, in about 28 women, you have to induce 1 in 28 women in order to sort of reduce 1 cesarean section. So that numbers needed to treat is 1 in 28, right? And they also found that 1 in 20 numbers needed to treat to reduce hypertensive disorders. So we're looking at a very varied numbers here as compared to our Indian population. The length of labor, what about that? Induction group had a longer latent and active management phase. And we can imagine our own ladies going through this long latent phase. Don't you see people just asking for a cesarean? How long am I going to have to wait? The logistics around it. So I'll come into some of these. And this is only in some analysis that they showed a shorter overall hospital stay. Only in some analysis. Now going on to the secret sauce that they used, right? They said they checked the modified Bishop score at between 38 39 weeks. They randomized them into either expectant or the induction, right? They used every method possible. They used mechanical methods plus mesoprost plus PGA2 gels and plus ARM plus oxytocin as per local protocol. There was no standard protocol, but these were all highly specialized and very long periods of induction just to get her into labor. And they had to use continuous electronic fetal monitoring and all those ladies, right? Now, the nurses, the midwives go like that. The CTG machines go like this with long pages of reams of paper, longer stay as well, right? So now, as per the ARRIVE trial, okay, because we're talking about this, because this is the trial which causes confusion, you have to wait at least 12 to 18 hours of adequate uterine activity to diagnose failed induction. I totally agree with this. Even for any induction post-terms, diabetes, hypertension, I agree with this. But we're looking at routine induction at 39 weeks. Right? Even in the latent phase, wait, which is absolutely fine for me if they have, sort of have a medical reason for it. Now, what about wrong dates? A massive 25% of our patients are going to have wrong dates because of various reasons, right? So we know in India, 39 weeks they will go into labor, 35% of them, more than 1/3. We know in India at 40 weeks, another 24% will go into labor. So you've got to look at it, about 60% of them will go into labor before you're looking at 41 or 42 weeks, right? So natural is better, isn't it? A fixed 39-week elective induction policy may clash with natural variability and patient preference, which is extremely important. And my friend Dr. Rekha also referred to patient preference. Post-term risk reduction was not a central arrive finding at all. Now, what about risks of routine induction? You've got you're coming in the way of natural progression, the social issues, the mother-in-law, the husband, the entire family, the patient expectations. First of all, we know how some of the women want to wait and wait and wait, yeah, in spite of having medical comorbidities, right? What about the workplace, constraints and strain? In many of our settings, we do not have that kind of staffing in the night. And when you induce in this manner, you're going to definitely have labors happening between 12 midnight and 8 in the morning, right? So where's your workplace? So we're opening a Pandora's box if you're trying to routinely induce everybody at 39 weeks. Longer labor, greater need of an analgesia, IV lines, monitoring, staff, of course, the tachysystole and the fetal heart rate abnormalities which come with it, more induce a risk of PPH, so you need sufficient staff to deal with that. Failed induction, of course, cesarean, notwithstanding uterine rupture, of course, rare. You have shoulder dystocia, you have iatrogenic early term birth, especially if your dating is off. So your dating has to be absolutely exact, isn't it? And stress on the system. You've got potential to crowd out the higher risk center. So you have higher risk patients to look after. If you routinely induce everybody, what about prioritization of your high risk? And you will lead to loss of our deliveries, tired staff, tired obstetricians. That's the most important peril for us, right? Now, the final verdict I would like to say that yes, ARRIVE, the trial offered an option, but it's not a mandate. There is no neonatal advantage. We know that from the statistics. And the context matters. The condition's not universal in everyday practice. It's not everywhere that we have the same sort of, sets of women who understand what's happening. We have to individualize. We've got to, we cannot generalize. Cervical favorability, the Bishop score is the most important point that we've got to, document and act accordingly. Patient preference is important, local capacity is important, a blanket policy definitely ignores all these differences. Medicalizing the norm, that is, IOL risks turning to natural healthy pregnancies into managed medical events without proportional gain. This is the bottom line. There is no proportional gain in doing routine inductions, so we need to promote choice, my dear friends. We need to promote choice and not convenience, shared decision making and a thoughtful, expectant management protect both the autonomy and safety better than a one-size-fits-all policy induction culture. So I say that trusting nature, respecting choice, and empowering our own women with choice and not enforcing routine is what we all need to do as obstetricians. Thank you very much. I rest my case by saying Indians will automatically go into labor naturally, so there's no need to push for a 39-week routine induction. That's not my practice. Dr. Rekha, over to you as to what you want to say. Thank you.
Wonderful, Dr. Aruna. I think you have taken all my arguments piece by piece. Rather than attacking me, I liked her very nice spirit of, rather than attacking me, she's attacked the trial, the ARRIVE trial. Yeah. So the things is, only two things in my rebuttal I want to address. One is cervical ripening. When we were talking about, you were talking a lot about, the pressure. Yes, I do agree on already overburdened obstetric department to have, routine inductions would be a real burden. But one option I think would be to consider OPD, on an OPD basis, the cervical ripening on an OPD basis. This is something we do in our setup where we do not burden by admissions. I totally agree with you, and I'm also against it. Admitting a patient for induction of labor and that admission and going through the repeated probably PGE2 gels and all these things, that itself is counterproductive. In that point, I totally agree with you. We are considered mifepristone, which is a very good alternative. I don't know how many of them in the audience are going to agree, but it's a very good alternative. Not yet approved. Yes, I agree. I take that point, but it's a very good alternative for an OPD basis for low-risk women to consider. The second point which I wanted to address was when you said, the 39 weeks, the gestational aging, not properly. See, we are not talking about somebody whose gestational age is not properly mapped. We have to consider, we are not just going on the, LMP, EDD thing, or definitely we are going to consider the first trimester scanning, and we are going to date the gestational age appropriately. We are not going to just, jump into the bandwagon saying that 39 weeks I'm just going to induce labor and not going to look into these aspects of it. Definitely we are going to look into it. If in doubt about the gestational age, we better wait rather than do something drastic like this.
Absolutely.
But still, at the end of this, I would like to rest my case by just saying, consider the choices of perinatal, the stillbirths, which is considerable. In my practice, what I have seen, the stillbirths, which are considerable, and also the meconium aspiration and consecutive admission to the NICUs, and not so optimal outcome of the babies. I think these two things need to be strongly considered when we are
Absolutely,
these,
Dr. Rekha. But how
choices.
many of us, let's say in the private practice, I know you are in Sri Devi Medical College, and you probably have women who can understand what's happening to them when they're sent home with the induction agents. How many of you would agree in private practice or any other practice, it's as safe as to, send them with induction agents home? Right? You've got fecal tachysystole. I mean, mifepristone, to be honest, I cannot comment because I have not used it in my own practice and it's not licensed. But we would like to know more about what you do with mifepristone. But I honestly, hand on my heart, wouldn't be happy to send a woman home or giving her meso or progesterone gel or even the pessary, right? I don't think I would do that. So that is completely out of question. The second thing that she alluded to is that the risk of stillbirth, right? So once again, we are looking at a 25% people who slip through the net when we actually date their pregnancies. So we're looking at these 25% of women either being preterm or postterm. So it's extremely, extremely important. I agree with her on this point that the estimated due date has to be very thoroughly calculated using various means and methods and should not allow her to go beyond post date. So we are looking at stillbirth, as her graph very clearly said, we're looking at stillbirth rates at 40 and beyond. So I don't think that would happen if we have a very clear dating. So with that, I rest my case, and I would say, I think mother's choice and the parents and the family's choice comes first. Favorability, cervical favorability comes next, and thirdly, of course, the hospital and the logistics that can support you, lest you have a medico-legal case against you. Thank you very much indeed. Thanks.
Good afternoon, everyone. I think it would not have been handled better by any two other persons than these two speakers here. I think a wonderful discussion, and I don't consider myself worthy or deserving of judging their debate. So I just want to add few points on it. Recently we had a case in Kerala where a doctor was persecuted. I mean, she was convicted for inducing at 41. When something comes in the public domain, anybody can search something on the internet and they are free to open their own judgment. So I'm not sure, something like that was going on in the social media. She has induced a patient at 41 and some stillbirth has happened. Why was she not induced at 39? Some court has asked the question. Point number one. Second point, a patient comes to you at 39 weeks with a good NST. You see the patient asks, sir, after next week I'll be coming, everything will be okay? If you say yes and send home, if something happens, this I leave it to the audience to decide. So these are a few questions, practical questions, which however strong you may be, however sound we may be, this field makes us grounded, keeps us grounded. If a patient asks this question, how many of us will be in a position to say everything will be perfect at 41 or 42? I don't know. So I think this needs some clarification.
I just wanted to add one point. Thank you for that. I didn't know about the social media, news. But we all know that if we induce somebody below 39 weeks, we got our dates wrong, and below 39 weeks, we definitely will have a higher risk of RDS, respiratory distress syndrome. So that's something we want to avoid as well by inducing them beyond, 39, 40 weeks. Sorry, over to you.
Good afternoon, everyone.
both of you, madam, presented well. As you told, it's depends on the patient satisfaction, consultants and facilities available. As we are working in government hospital, MCH hospital, if you do 39 weeks inductions, it is difficult to manage. And also patients in the long duration of latent phase, the patient won't accept. And I will go with 40 weeks plus induction is better, I think. Thank you.
I think they have to give a vote, audience vote or something? Yes. Sir? Audience vote. I think, do you want to mention that or? You will ask, is it? You will ask.
Yes, ma'am. May I from the audience, please, who say yes for induction at 39 weeks, please raise your hands. Myself also. Who said no? Very few neutral answers, many more for no. Thank you, ma'am. That was indeed a brainstorming session, and thank you, judges, for adding a real charm to the session. Thank you. Now we have finally arrived at our final session of the day, that is Vidwan Ghoshti. We would like to call upon stage our respected chairpersons for the session, Dr. Anuradha V. Ma'am. Ma'am is consultant obstetrician gynecologist at Proprietrix Anuradha Women and Ortho Day Clinic, and she has been past president of IMA Bengaluru branch, and currently ma'am is a state coordinator IMA headquarters for HPV training program. Now I would like to call upon stage Dr. Ashwini Harish Pai ma'am, who is professor and head of the unit at Subbaiah Institute of Medical Sciences, Shivamogga. We welcome you, ma'am. And now it's my privilege and honor to welcome my UG and PG teacher at Bangalore Medical College and Research Institute, Dr. K.V. Malini madam, to the dais, please. Madam is going to deliver her talk on preventing vault prolapse, vaginal assisted laparoscopic sacrohysteropexy. I request Dr. Anuradha ma'am to introduce Dr. Malini KV ma'am, please.
Good afternoon all, to all our friends and our teachers. And first of all, sincere thanks to Dr. Girija and team for organizing such a wonderful session. It's my privilege to introduce my BMC alumni, Dr. K.V. Malini, MD, DGO, PG, DMLE, FICOG. She has had a distinction in MD, recipient of Subbalakshmi Memorial Prize from KMC Manipal, Women Achiever Award from Karnataka Government, Best Teacher Award from BSOG, IMA and BMC Alumni Association. She has been past president of BSOG, Joint Organizing Secretary for AICOG 2019, and she is very famous amongst her teachers for her expert vaginal surgeries, operative and high-risk obstetrics, as well as postnatal property insertion. Over to Dr. Malini. Thank you.
Thank you, Anuradha, for that kind introduction. Good afternoon, everybody. At the outset, I would like to congratulate the KSOGA team 35 and Tumkur Ops and Gyne Society for hosting this wonderful conference, and I would like to thank them for making me a part of this lovely conference. The task that is given to me is prevention of vault prolapse and VALS. So you all know that hysterectomy is the commonest operation that is performed, and vault prolapse is one of the complications of any hysterectomy, be it abdominal hysterectomy or vaginal hysterectomy. And the incidence of vault prolapse varies from 0.2 to 43%. That's a wide range. It's more common after vaginal hysterectomy, but it is only 1.8%. It is almost compared to abdominal hysterectomy when it is done for benign condition. That is, say we do non-descent vaginal hysterectomy for gynec conditions, benign conditions. And it is 11.6% following surgery for pelvic organ prolapse as compared to abdominal hysterectomy, which is only 1.8 to 2%. it also depends on other risk factors. Now, for women who are at high risk of post-hysterectomy wall prolapse, preventive measures can be taken during surgery or even afterward to minimize the chances of this kind of vaginal cuff descent. So the best strategy depends on woman's individual risk factors, the type of hysterectomy that is performed, and her medical history. So now what are these risk factors which a surgeon has to identify to prevent this post-hysterectomy wall prolapse? So that he will consider all these risk factors while planning a hysterectomy. So one, as all you know, pre-existing pelvic floor weakness. This is the single most important risk factor, and parity and childbirth. Multiple vaginal deliveries, especially with forceps or vacuum assistance, increases the risk because there is a lot of damage to the pelvic floor muscles and pelvic cellular tissue. And as all you know, increased age and menopause, the loss of estrogen after menopause leads to weakening of pelvic muscles and tissues. Obesity, carrying excess weight puts additional strain on the pelvic support structures. And connective tissue disorders, some women may have weaker connective tissue due to genetic factors. Then what is the point in using her own native tissue for doing the repair, repair, say anterior-colporrhaphy or even posterior-colporrhaphy. So maybe the surgeon should identify whether this woman is at risk for this kind of she is having this kind of a problem and she is at risk for wall prolapse. And of course the type of hysterectomy which I already mentioned, it is more common after vaginal hysterectomy as compared to abdominal one. Now failure, this is the most important factor, failure to attach the cardinal uterosacral ligament complex adequately to the pubocervical fascia and rectovaginal fascia at the vaginal cuff during hysterectomy is the most important cause of vaginal wall prolapse according to D. Lancey. So we all know D. Lancey was the one who actually described about the supports of the vagina. Now we know that these are the risk factors. How do we prevent wall prolapse? We know that it is the fixing of this cardinal uterosacral complex to the cuff is the most important factor. So do it, reattach the uterosacral to the wall at the time of abdominal hysterectomy, at the time of laparoscopic hysterectomy, or at the time of vaginal hysterectomy. Now during vaginal hysterectomy, you can also do some additional procedures like say McCall's scaldoplasty, could be external, internal, or even modified where we combine both external as well as internal, and sacrospinous fixation if we find that she is at a risk for wall prolapse as a preventive measure. And during laparoscopic hysterectomy, we can also do an additional procedure which is a sacrocolpopexy if she is at a risk for wall prolapse. Now some of the procedures, I am going to elaborate on that. The prophylactic technique at vaginal hysterectomy, which all of you know about this, McCall's scaldoplasty. I don't know how many of you make it routine that at the time of prolapse operation, you put McCall's scaldoplasty. How many of you do that? Please raise your hands. Very few, yes. Okay. So it's a very simple procedure, additional 2 minutes. Please put this McCall's scaldoplasty stitch. It uses sutures to incorporate the uterosacral ligaments into the vaginal cuff, providing additional apical support and closing the cul-de-sac behind the vagina. And vaginal cuff suspension, the cardinal, as I already mentioned, it is the most important step. The cardinal uterosacral ligament complex should be sutured to the vaginal cuff. So you know that these uterosacrals are attached to S2, S3, S4 there, okay. So once it is detached while doing hysterectomy, you can reattach that uterosacral to the wall to prevent wall prolapse. This is effective both in abdominal as well as vaginal hysterectomy. And sacrospinous fixation, in vaginal hysterectomy, see after closing the vault, you find that the vault is almost at the level of the introitus. You do one more additional procedure which is sacrospinous ligament fixation as a preventive measure. And during laparoscopic or robotic sacrocolpopexy, suppose the patient is at a significant risk for wall prolapse, you can prophylactically suspend this vaginal cuff from the sacrum using a synthetic mesh or tissue graft. So you can see here, like it is fixed to the sacral promontory over there, and this is an open this thing. You can see the vault is almost above the pubic symphysis. While doing like hysterectomy, we have done this using a mesh. So that will lift up the vault and it will prevent wall prolapse later on. Now, while I was searching for this, literature search I was doing for this presentation, I found a very interesting technique, which is Agarwal's technique. It is done in our own country, Raipur Hospital. Here, it is a combined vaginal and laparoscopic approach where after hysterectomy, mesh is sutured to cardinal and uterosacral ligament vaginally, and the vault is fixed to the sacral promontory laparoscopically. They have studied almost 25 cases over a period of 5-year follow-up they have done, and they have found that it is 100% subjective. There was 100% subjective as well as objective improvement. But one thing I failed to understand is, like after doing hysterectomy, when you fix that mesh to the cardinal ligament, how they could take it retroperitoneally to the sacral promontory I just couldn't understand it anyway. So you have so many procedures now, which is the best method to prevent wall prolapse. So the effectiveness of surgical procedure to prevent post-hysterectomy pelvic organ prolapse, it is a systematic review of the literature which says that performing variations of Meckel caldoplasty at the time of hysterectomy might be the most effective prophylactic surgical procedure for preventing post-hysterectomy pelvic organ prolapse. So some people believe that, you do subtotal hysterectomy, why do, especially younger ladies, you preserve the cervix, it will be for sexual activity also, and the cardinal ligament and uterosacral ligaments are attached to it. So does it prevent that procedure, subtotal hysterectomy with the uterosacral and cardinal complex intact, does it prevent wall prolapse? So according to GTG, the answer is no, okay. So that may not be a recommended procedure to prevent wall prolapse. These are some of the non-surgical methods to prevent prolapse which can be advised to the patient, like lifestyle changes, advising them to have these pelvic floor muscle training exercises so that the pelvic floor muscles get strengthened and it can compensate for the loss of uterine support. And a pelvic floor physiotherapist can teach the proper technique to these patients and maintain a healthy weight, because especially the abdominal weight, it plays a significant effect on and constant strain on these pelvic floor muscles. So ask her to reduce weight and avoid heavy lifting. The repetitive or sudden heavy lifting dramatically increases intra-abdominal pressure, which can weaken the pelvic floor, and it is important to use proper lifting techniques and avoid heavy loads, especially during the initially recovery period after hysterectomy. And of course, constipation. Straining during bowel movements puts immense pressure on the pelvic floor. So you have to treat this constipation by advising high fiber diet, adequate fluid intake, and using footstool, which will help prevent constipation and straining. And of course, suppose she has got persistent chronic cough, it can contribute to pelvic floor weakness. So conditions like chronic cough, or if she has got asthma, or if she has got is a chronic smoker, all these things should be managed. And if it is a mild kind of wall prolapse, you can even advise pessary treatment after hysterectomy. This is a small video on Meckel's caldoplasty. I'm sure most of you are doing, but I usually do it almost in all my procedures of pelvic organ prolapse, because the risk of pelvic organ prolapse is more. So you take a stitch, actually this was not prepared for this conference, just for PG teaching it was taken, and I'm very sorry about the poor quality of the video. So a stitch is taken from the posterior vaginal vault and then through the cardinal uterosacral complex, that is the last pedicle, and then you take a series of stitches over the posterior peritoneum. So whenever you take the stitches from the posterior peritoneum, you have to pick it and prick it, because otherwise you may injure the underlying rectum, because it's a recto-uterine pouch of peritoneum. And then you come through the opposite uterosacrals and come to the posterior vaginal wall. Now some people put series of internal Maccal stitch. Remember, the internal Maccal stitch will reduce the enterocecal sac, and external Maccal stitch will stitch the uterosacral to the vaginal cuff, and that will prevent the wall prolapse. So a combination of internal and Maccal stitch will be a better option, okay? So this stitch is kept till the end, and only after doing anticolporaphy, and usually I take a stitch from the pubo-cervical fascia and I fix it to this uterosacral complex also, so that pericervical ring, that anatomy is restored, and at the end it is sutured. So when we suture, the vault is pulled higher. So when you do rectocele repair, you get the proper vaginal length and vault will be some more higher up, okay? Now this picture I wanted to show because this was a young lady who underwent prolapse surgery. It was a stage 3 pelvic organ prolapse. She underwent surgery just 3 months back. So what is wrong with this? So you can see a bulge on the posterior vaginal wall. The rectocele was not repaired. You can see a bulge in the anterior wall also. So anticolporaphy was not properly done. I'm sure they wouldn't have put any Maccal stitch also. And on traction you can see that it was the stage 3 wall prolapse, okay? So we had to do sacrospinous fixation. If only you had taken extra 2 minutes to take one Maccal stitch, maybe you would have prevented this kind of a disaster. That's what I wanted to stress. Now Walsh is totally a different entity which is not at all connected to prevention of wall prolapse. It is vaginally assisted laparoscopic sacrohysteropexy, and it's a new surgical intervention that is offered to women with advanced uterine prolapse. It consists of 3 sections: laparoscopy, vaginal and laparoscopy. In the first section, the peritoneum over the sacral promontory is incised and a subperitoneal tunnel is created about say 5 centimeter long up to the cervix, and a lightweight mesh is placed over the sacral promontory. In the second section, a curvilinear incision is made over the cervico-vaginal junction on the posterior wall, and the retroperitoneal tunnel is established, and through blunt dissection from the vagina to sacral promontory. You can see the ring forceps here down. It is taking one end of the mesh, and that is fixed to the posterior surface of the cervix, and the other, and you push the uterus up to the level of the say ischial spine. Now you know that it is up to the max optimal level, and then you fix the other end of the mesh to the sacral promontory. So this is Walsh. But I really don't understand, like all the expert endoscopic surgeons, why can't they do a laparoscopically assisted sacrohysteropexy, rather vaginally assisted sacrohysteropexy. There is no need for vaginal root at all. You can, when you have established a tunnel, you can as well fix it to the posterior surface of the cervix. I really don't understand the advantage of this, but then this is quoted in this literature. 33 women with POPQ stages 3 or 4 between 2012 to 2015 were operated. Follow-up was done for 5 years. Anatomic cure rate was more than 90% and symptom cure rate is 100%. According to them, it is feasible, easy and safe to perform. Just I'll take 2 minutes to conclude, okay? So these are the key takeaways. Fixation of cardinal or uterosacral ligament complex to the vault at the time of hysterectomy is the single most important factor, along with Maccal's scaldoplasty. And sacrospinous fixation at vaginal hysterectomy and sacrocolpopexy at abdominal or laparoscopic hysterectomy can be performed for advanced prolapse to prevent wall prolapse. And newer techniques include sacrocolpopexy through combined vaginal or laparoscopic approach. And as I already mentioned, the non-surgical methods like, pelvic floor muscle training and ring pessary and, prevention of other risk factors also can prevent wall prolapse. Walsh is a combined vaginal laparoscopic approach for advanced prolapse where preservation of the uterus is needed. So Walsh is for those women who want to conserve their uterus and who are not and who are having advanced prolapse, say stage 3 or stage 4 prolapse, where sling operations cannot be offered to them, maybe for such women, you can go for what is known as Walsh or maybe laparoscopic histosacropexy. That's what I feel. Thank you so much. Thank you again for the opportunity that is given to me.
Thank you, Dr. Malini. And all that I need to add is elaborate counseling and assessing the patient is also equally important, so that we know which patient is got a predisposition to develop what, like how for other certain procedures or anything, we tell them that in spite of your hernia repair, you can still develop hernia. Similarly here, for all of us, wall prolapse is not that common, but still counseling, spending some more time with the patient and taking some more steps like Dr. Malini, fixing the uterosacals. Thank you.
Yeah. Thank you.
Thank you, ma'am, for sharing your expertise with us. KV ma'am to be seated on the dais, please. And I also humbly request all the speakers and chairpersons to kindly adhere to the stipulated time period, as we are running short of time and we are lined up by valedictory next. May I now invite Dr. Shobha Shavi ma'am, our next speaker, to present on Justosis score, a critical assessment tool aiding in the evaluation and management of hypertensive disorders during pregnancy. I request Dr. Ashwini Pai ma'am to kindly introduce.
Good afternoon, everyone. Our next speaker is Dr. Shobha Shevai. She is an obstetrician gynecologist from Shevi Sanjeevani Hospital, Ilkal. Her areas of interest include fetal medicine and genetics and recurrent pregnancy loss. She has been a secretary of the Bagalkot Obesity Society and the secretary of Critical Care Committee of KSOGA 21-23, and she is a chairperson of Safe Motherhood Committee KSOGA 23-25. Over to you, ma'am.
Thank you, madam, for your kind introduction. First of all, namaskara ellargunu. I bring greetings from Silk City, Ilkal and Bagalkot OBG Society. As obstetricians, we work day and night to decrease the maternal mortality, morbidity, perinatal mortality and morbidity. When we do this job, the three most important villains we fight against are anemia, hypertensive disorders of pregnancy and PPH. Hypertensive disorders of pregnancy and its related obstacles are of vital concerns of maternal morbidity and mortality, with an overall occurrence of 14 to 19% of all maternal deaths. The National Eclampsia Registry tells that the incidence of preeclampsia is around 10.3%. That means among 26 million pregnant women who are in our country, 10% means we are dealing with 2.6 million women who are suffering from HTP, and we can imagine the amount of mortality and morbidity it causes. And compared to other villains like anemia and PPH, which we are able to control in a better way, HTP is on the rise due to multiple contributing factors such as increasing maternal age, obesity, underlying subfertility, rising incidence of medical disorders of pregnancy, and pregnancies using assisted reproductive techniques and multiple pregnancies. Unlike maternal death due to other causes such as hemorrhage and deaths due to HTP are known to be rising over the years. So there is a very, very great need to have a screening system to detect mothers who are at high risk and to do some intervention to prevent hypertensive disorders of pregnancy. Prioritizing our attention to the preventable and modifiable risk factors of HTP can create a window of opportunity to reduce the incidence and subsequent complications of hypertensive disorders of pregnancy. Justosis is the alternative nomenclature for the pathogenesis of preeclampsia. The pathogenesis of preeclampsia is a sequential process, as you all know. The first stage is because of shallow and defective placentation, which is followed by maternal factors which create imbalance amidst angiogenic and anti-angiogenic factors. So the challenge is to recognize the at-risk patients early in pregnancy. We all know prevention is better than cure. So there have been many studies. Clinicians have used a combination of risk factors because HTP is a multifactorial disorder. ACOG, RCOG, NICE and WHO have also come up with many guidelines which use maternal characteristics like age, obesity, multiple pregnancy, IVF conception, mean arterial pressure and existing medical disorders. And there are also other tests like uterine artery Doppler and biomarkers like PAP, A and PLGF. But none of these risk factors have had great sensitivity or specificity, and few are very, very costly. The recent most study, that is ASPE study, suggests maternal age, MAP and uterine artery Doppler and PAP-A and PLGF, but it is a very, very costly test. And we Indians are known to be, we are famous for doing jugaads. So our Indian doctor called Dr. Gorak Mandrupkar has come up with a very good scoring system incorporating all the risk factors. So when we consider screening test, we should understand that screening tests are better for predicting early onset than late onset preeclampsia, and combination of risk factors and uterine artery PI increases the prediction. Combination of uterine artery Doppler, PI, biomarkers can predict up to 82% of early disease, but only 45% of late onset diseases. Maternal factors like mean arterial pressure gives us about 40% predictability with 10% false positive rate. So, can we simplify screening? That's what. So, Dr. Gorak Mandrupkar has come up with this screening system called as gestosis scoring. And another drawback of other screening system is like uterine artery Doppler and PLGF, we are doing it around 12 to 14 weeks of gestation. So, we are missing out the period of early presentation and missing out the chance to intervene. So there was a need to develop screening system which is affordable, easy to use and effective. Dr. Gorak Mandrupkar came up with a beautiful scoring system incorporating many of the risk factors. This was further modified by Foxy stalwarts like Dr. Sanjay Gupte, Dr. Girija Wagh, Dr. Suchitra Pandit and Alpesh Gandhi. It was first published by Foxy in 2019. This identify risk women early in pregnancy. It creates a window of opportunity for counseling the patient and the family, and to advise dietary changes, lifestyle modification, and also to start low dose aspirin and high dose calcium, which all go a long way in preventing hypertensive disorders of pregnancy. So he went through most of the studies, and the factors, risk factors which had an incidence of 10 to 15%, they were termed as mild risk factors, and they were given a score of 1. And these are age older than 35, age younger than 19 years, maternal anemia, obesity, primigravida, short duration of paternity, women born as small for gestational age, PCOS, women with PCOS, interpregnancy interval of more than 7 years, conceived with ART, mean arterial pressure of more than 85, chronic vascular diseases, and excessive weight gain during pregnancy. The other risk factors which had a percentage of 15 to 30 were given moderate risk factors, and the scoring of 2 was given to them. Maternal hypothyroidism, family history of preeclampsia, gestational diabetes mellitus, multiple pregnancy, obesity of BMI more than 35, and hypertension during previous pregnancy are considered as moderate risk factors. Severe risk factors are the pre-existing medical conditions like pregestational diabetes mellitus, chronic hypertension, mental disorders, inherited or acquired thrombophilia, maternal chronic kidney disease, autoimmune disease, and pregnancy with surrogacy or donor ovum or sperms. These factors are given 3 scores, a score of 3. So every time a patient comes, we have to take a proper history and make the scoring. A score of more than 3 is considered as high risk, and these patients will undergo interventions. And there have been many studies to validate this scoring system. Almost 92 studies are there, and most of them have confirmed its efficiency. So what is the advantage of this scoring? It is a very easy to use scoring because we don't have to remember these 27 factors. We can have a hard copy, or even there is an app which is free of cost available on Android. And also our respected president, Dr. Durgadas sir, is pushing this endeavor, and he has also come up with a QR code where we can scan the code and do the scoring, and we will get the total calculated score. It's an affordable test. There is no extra cost involved. It involves mostly history taking along with BMI calculation and mean arterial pressure calculation. For BMI, you can either calculate it, or there have been weighing machines which show BMI directly. And mean arterial calculation, pressure calculation, you can either do it manually, or there is, you can use a monitor to calculate the same. And blood tests like CBC, OGCT and TSH are done routinely, so there is no cost involved. It's a dynamic scoring system. That means we don't do it one time, we do it every time. Every time the patient comes, if there is anything abnormal, like if there is an excess weight gain, or if the pressures have increased, MAP is increased, or TSH has become abnormal, or OGCT has become abnormal, extra points are added. And every visit, we can do simplified additions. Every visit, we can identify new risk, and every visit is an opportunity to reduce the risk by doing interventions. And every visit is an opportunity of prevention, because every time we do the justosis scoring, patients will come to know, okay, there is an entity called as HTP, it can affect our pregnancy, and these are all things we can do. So I would like to give few practical examples, because initially I also used to think it's a tedious process, but when I kept on doing it, became very, very easy, and I could see that it is so much more beneficial than doing just uterine artery Doppler. Primary with 16 weeks of gestation, married life of 7 months, known case of PCOD, came to us for the first time. She had done NT scan elsewhere. The uterine artery Doppler was 30th centile, so she was not put on aspirin. But when we did justosis scoring, the score was 3. Because she is a primary and there is short duration of sperm exposure and history of PCOS. So the score was 3 and we started her on aspirin. And at 35th week, she developed PIH, which was mild, and we could terminate her around 36 weeks. So we prevented early onset PIH in this patient. And there was one more patient, Mrs. XYZ, named age 30 years, gravida 3, para 2, living 0, death 2 with previous LSCS. She came with history of missed period and UPT positive. She had undergone septoplasty in our hospital, and she had episode of CVT also, and her APLA profile was also positive. So in the first visit, her score became 6. So at first visit only we started her on aspirin and Clexane, and till 36 weeks she did not develop any PIH, because previous pregnancy she had PIH and IUGR. So this is her scoring. And one more patient, a primary, age 26 years, married 4 months, came with early pregnancy, BMI was 31. So when we did the justosis scoring, it was 4, so she was started on aspirin. And her uterine artery Doppler was actually normal, but starting aspirin helped her, and she developed HTP at 35th week. So this is how we do the calculation. Actually, we can train our staff to do this calculation. We don't have to do and waste our time. If we train our nurses, they can do this. So why we should use justosis scoring? As seen by above examples, we can screen early. When we start it at around 6 to 8 weeks of gestation, we are intervening before the presentation problem starts. It can be done by nursing staff, detects many cases missed by uterine artery Doppler. It's made in India. It can be used multiple times and it is free of cost. So these are the times when we are talking about Atmanirbhar Bharat and Make in India, and it's such a beautiful and easy method to prevent such a big problem in pregnancy. So I think all of us should take up this scoring system, which is easy to use and very, very beneficial. I thank Dr. Hema Divakar Madam and Manyata team for introducing our hospital to this beautiful system, and Dr. Vidya Tobbi Madam for encouraging us to use it continuously, and Dr. Durgadas Asrana Sir for promoting and advocating this intensely. Maybe if all of us take this up, maybe our maternal mortality will definitely come down. As seen by the example of Maharashtra. In Maharashtra, they're using it very, very regularly, and Maharashtra's maternal mortality is very less compared to our own mortality. So I urge all of you to take this step, and you will definitely see great decline in early onset preeclampsia, eclampsia, maternal mortality and morbidity, perinatal mortality and morbidity, and decreased stress levels, because we have less high risk cases and less or no referral to higher centers. I've been using this since 2 years, and I'm very glad to say that the pre-eclampsia rate in our hospital has come down drastically, and I have not seen eclampsia in 2 to 3 years in my booked cases. So thank you Tumkur Society for this opportunity. If there are any questions, I will be happy to answer.
Thank you, ma'am. Thank you for elaborating very beautifully on the justosis score. And I'm sure after this talk, we will have many more candidates the next year for the prize which sir has introduced this year.
Thank you.
Thank you.
Thank you, on the dais, please. Now I call upon stage our next speaker, Dr. Sumangala P. Biranoor, ma'am. We welcome you, ma'am. I request Dr. Anuradha Parameshwar V. madam to kindly do the introduction.
Yeah, it's my privilege to introduce the next speaker, Dr. Sumangala Biranoor, MBBS DGO, Fellowship in Reproductive Medicine. She practices at Vedika Fertility and Maternity Center. She is infertility and fetal diagnostics and interventions procedures she does. That's her areas of interest. She is co-founder of Vedika Fertility and Maternity Center. She has won first prize in quiz for consultants in fetal medicine and infertility during the KSOGA 2022. She has done invasive procedures, amniocentesis about 200, fetal reduction, etc. She is member of Imaging Science Committee OBG 2023 and 2024 Karnataka. Over to Dr. Sumangala for a talk on endometrial pathologies causing subfertility.
Okay, today we are going to learn about endometrial pathologies that result in fertility issues. And if yes, what are the endometrial pathologies that are bothering for us, and also how to evaluate and find the explanations. Whenever the infertility couple comes to our clinic, first thing we do is look at the ovarian reserve. If it is good, we look at the semen parameters. Yes, it is good. We do the tubal patency test by HSG, and then we reveal it to the patient that everything is good, and we start treating them with ovulation induction, IUI, and sometimes IVF after some years. And still, if the pregnancy doesn't result, we put a seal on the file that it is an unexplained infertility. Is it really so? We forget something here. For example, ನಾವು ದೇವಸ್ಥಾನಕ್ಕೆ ಹೋದಾಗ ಹೊರಾಂಗಣ ನೋಡ್ತೀವಿ, ಒಳಾಂಗಣ ನೋಡ್ತೀವಿ, ಕೈ ಮುಗಿದು ಬಂದ್ಬಿಟ್ಟೆ ದರ್ಶನ ಚೆನ್ನಾಗಾಗುತ್ತಾ? ಇಲ್ಲ. ದೇವರ ಮೂರ್ತಿನ ಅಟ್ಲೀಸ್ಟ್ ಫ್ಯೂ ಸೆಕೆಂಡ್ಸ್ ನೋಡಿದ್ರೆ ಕಣ್ ತುಂಬಿಕೊಂಡ್ಮೇಲೆ ದರ್ಶನ ಚೆನ್ನಾಗಾಯ್ತು ಅಂತ ಹೇಳ್ತೀವಿ. So we all have come out of the endometrial cavity, which is a receptive organ for the embryo. So we have to learn and spend some time looking at the endometrium. If we get to see some pathologies, especially chronic endometritis, including tubercular endometritis. Yes, we also come across endometrial polyp, submucosal myoma, and other things. Then how do we evaluate and diagnose these pathologies? We all know, we have learned to do TVS over the years, and as it is two-dimensional sonography, but the uterine space is a three-dimensional space. When we do TVS, we get to see the sagittal view and the axial view, but we don't get the coronal view. So, to see that, we have to do 3D sonography. We have to master doing this for every patient, infertile patient that comes to us. It is compulsory to do 3D sonography. It not only gives a coronal view, but also the endomyometrial junction in 2D, if is not very clear, it is looking better in 3D, endomyometrial junction. And whenever we do TVS for the uterus, we usually see the endometrial thickness, right, and finish it off. But no, we have to also struggle and look at the endometrial structure, how does it appear, hypoechoic, hyperechoic, and also we should not forget to mention about the endomyometrial junction, that is this line. And also we should see central echogenic line. We should start writing these components in the sonographic report so that we won't miss any pathology.
This is a saline infusion sonography where we put a sterile saline into the uterine cavity and we get to see some of the pathologies if they are present. Coming to chronic endometritis, it is very common and prevalence is not mentioned anywhere because we forget to see it and forget to diagnose it. How it is different from the acute endometritis? In acute endometritis, the lymphocytes will come into the playground and there will be a white discharge and we treat with the antibiotics. Whereas in chronic endometritis, the plasma cells come into the playground and hence it doesn't cause any symptoms there. It goes unnoticed. When it heals with a fibrosis and some of the endometrial tissue gets damaged and the endometrium becomes thin and the endomyometrial junction becomes irregular. So the culprit here is the plenty of plasma cells present in the endometrial stroma. Yes, some of the bacteria that cause chronic endometritis is written here. The symptoms will be very less. But yes, the patient says, earlier I had a good menses, there was a good flow, regular menses. But recently, there is amenorrhea or oligomenorrhea or hypomenorrhea, that is scanty bleeding. We should not ignore this symptom. Listen carefully to the patient, she will tell the diagnosis. Yeah, diagnosing this situation is very challenging because most of the bacteria are not cultured, cannot be cultured, and when we do endometrial biopsy, we have to search for the presence of plasma cells in the endometrial tissue, and it is not very easy. Usually we do traditionally hematoxylin and leucine staining. The plasma cells, yes, we can stain them, but it is sensitive, not very specific because other mononuclear cells also will take up the stain. So we have to look for the CD138 cells. What is it, CD138? It is a proteoglycan present on the membrane of the plasma cell. So it is more specific. If we identify at least one plasma cell in 10 high power field, then we have to conclude that it is a chronic endometritis. We can as well do culture if possible or RT-PCR and confirm that it is a chronic endometritis. When we see a thin endometrium during the follicular study, that is day 11 and 12 of the induced cycle, if the follicle is developed well and endometrium is thin and the endometrium does not increase in thickness in spite of giving estrogen, ecosprin, sildenafil and all other adjuvants, then we may clinically suspect that it is a chronic endometritis and we have to give a prolonged antibiotic therapy. The first line therapy here is doxycycline for 14 days. We can add metrogyl as well. If doesn't respond, then we can go for second line of antibiotic therapy as it is written here. If it doesn't improve, then we have to think there could be a fibrosis inside the uterine cavity and we have to do hysteroscopy and adhesiolysis. This is an example. She came to us in October and we suspected chronic endometritis. After giving antibiotics, didn't improve much. Then we put a hysteroscope, saw there was adhesions in the lower uterine cavity, released them in the month of December, and January she came for ovulation induction. The endometrium has beautifully improved there and it resulted in pregnancy and she is delivered now. Coming to endometrial tuberculosis, yes, it is one of the form of chronic endometritis. Very, very difficult to handle such situation. Similar to the chronic endometritis, the endometrium will be thin, endomyometrial junction will be irregular, there will be calcification spots, and if there is adhesions in the lower part, there can be secretions in the upper part, and the endometrial lining will be hyper-echogenic, and sometimes a micropolyposis can be seen. In 3D, there will be a vertical orientation of the interstitial portion of the fallopian tube, which is very specific for the tubercular endometritis. As the stage progresses, as the tuberculosis progresses, the endometrial cavity undergoes fibrosis and the cavity becomes
contracted like a T-shaped uterine cavity, doesn't improve with any of the therapies. Coming to endometrial polyp, it is very common scenario. If we look at endometrial cavity very carefully, it is nothing but a localized overgrowth of the endometrial tissue. Most of the time it is solitary and pedunculated. If we look carefully, especially in the infertile couple and those, if there is a recurrent implantation failure, there will be a definitely endometrial polyp seen, which is the best time to see this is a late proliferative phase. I'll show with an example. This is a case when she had come to us for the first time in the late proliferative phase. The endometrium here is a negative contrast and the endometrial polyp is a echogenic mass. There we can see the interface between the hypoechoic endometrium and the echogenic endometrial polyp, that is bright edge sign. That is a hallmark for the diagnosing of endometrial polyp. And the central echogenic line, as I had said, it gets interrupted here. So that is called as interrupted endometrial mucosal sign. In 3D it gets delineated. In saline infusion sonography along with 3D it gets more delineated. The same case, I have just kept the name purposely, the same case when she comes in early proliferative phase, in the lower endometrial cavity 3 lines are appearing with hypoechoic endometrium. As we move upwards, there is a disshapening of the endometrium in this area. There is no hypoechogenicity. So it gives a clue that there is an endometrial polyp. The same patient comes in the menstrual phase. We can see the central line. Here there is something. We may get confused with the blood clots. Then we called her after menses. We put a saline inside, saline infusion sonography. The lesion stands out very clearly. Then we did a hysteroscopy, confirmed it and removed the polyp. She conceived. Another example, whichever day of the menses she comes, our eye should look at that interrupted mucosal sign, single feeding vessel sign. After removing the polyp, the endometrium improved, she is conceived and it is ongoing pregnancy now. Yes, coming to fibroid. As we all know, it is hypoechoic and it stands out better in the secretory phase because the endometrium is hyperechoic and the myoma will be hypoechoic. And when we put a color Doppler, there is circular vascularity, very easy to identify, and remove the lesion, the fertility results. This is another case where there is endometrial synecdoche. They are avascular fibrous strands across the endometrial cavity. We see the endometrium. She has undergone 2 to 3 cycles of IVF. It has not resulted in pregnancy. It is not endometrial polyp. And when we put a hysteroscopy and we saw there was fibrous strands across, after releasing them, we are thinking it is tuberculosis and put her on tuberculosis therapy. This is another case of secondary infertility. She has a child, previous C-section, 1 abortion, and after 1 IVF cycle, she has still embryos frozen. It didn't result in pregnancy after embryos transfer. We could see it was not a good endometrium. After putting estrogen therapy and antibiotics, upper cavity improved but the lower cavity still remains thin. So we did the hysteroscopy and the adhesions were there and we released them, and lower uterine cavity improved 3 line, but it is not as we expect like a thick endometrium. But after ovulation induction, it has resulted in pregnancy. Isthmosil, yes. It is a hypoechoic area in the site of previous C-section. It can also cause infertility. If we approximate the layers, it will result in pregnancy. Endometrial hyperplasia, here the endomyometrial junction remains regular, but there is a hyperechoic endometrium with anechoic cyst because there is a more action of estrogen. How do we differentiate if the endometrial polyp is very big and the endometrium looks hyperechoic? Here we can see the polyp because we can see little endometrium hypoechoic at the corners. Similarly, another endometrial polyp which is not pedunculated, it is sessile after, we understood after putting saline inside. This is hyperechogenic plus heterogeneity is there in this endometrium,
But if we ask her history, she was pregnant and she had a bleeding, so it is incomplete miscarriage. How much ever we are advanced in technology, we should not forget to take the history. This is endometrial hyperplasia because more action of the estrogen and endometrial gland hyperplasia is there. This is a secretory phase of the menstrual cycle, day 27. There is a progestonic effect, that is why there is no hypoechoic glands. She comes with UPT positive after 5 days. All the thin endometrium are not chronic endometritis. Here we can see the ovulation induction cycle. Day 11, follicle is almost 16 millimeter, but the endometrium is thin, just 4.4 millimeter. I usually give adjuvants like estrogen, sildenafil and arginine. Day 14 she comes, the endometrium is beautiful. We can give SCG injection and she may conceive. Whatever I have told till now, it is a revision what I have written here. We have to look at all the components of endometrium. A big thanks for patient listening. Thank you. I thank Tumkur OBG Society and KSOGA for giving me this opportunity.
Thank you, Dr. Sumangala. So you have highlighted about the importance of assessing the endometrium in an infertile couple, and more so we tend to neglect the endometrial factor, and as you said, we put it as infertility of unknown origin. We are not finding a cause. So this cause, I think good sonology plays a vital role in assessing the endometrium. Thank you. So we move on to the last talk, I think.
Thank you, ma'am, for shedding light on this important topic. To conclude the session, we have Dr. Suman Gaddi, madam, who will enlighten us on the topic WHO Labour Care Guide, a modern evidence-based framework that redefines respectful and quality intrapartum care. We kindly request Dr. Ashwini Harish Pai, madam, to introduce our speaker, Dr. Suman Gaddi, madam.
Our next speaker is Dr. Suman Gaddi, madam. She is a consultant obstetrician gynecologist at Dhanama Super Specialty Hospital, Ballari. She was a former professor and HOD of OBG in WIMS, Ballari. She has been a KSOGA treasurer from 2024 to 26, treasurer from 23-25, EC member 21-23, and president of BOGS 2011 to 13. Over to you, madam.
Thank you, madam, for the kind introduction. So the topic, I'll straight away go to the topic. The topic given to me is WHO Labour Care Guide, and it is also known as the next generation partogram. And all of us know what is a partogram, which is a graphical record of the progress of labor, the condition of the mother and the fetus. And it has been extensively tested by the WHO. So the evolution of partogram, so many men actually contributed to the development of the partogram. Of special importance, I would like to mention the Friedman and the Philpotts and Castle. The Friedman created this cervicograph in the year way back in 1954. He plotted the cervical dilatation against time and yielded a sigmoid S-shaped curve and station against time to give a hyperbolic curve. Then Philpotts and Castle partogram in 1972, he introduced the concept of the alert and the action line. As a part of Safe Motherhood initiative, the WHO decided to rigorously evaluate the Philpotts report, and a large trial was conducted in Southeast Asia involving 35,484 women in 1987, and came up with a simplified WHO partogram in the year 1990, which had a latent phase of up to 8 hours and an active labor. Active phase started at 3 centimeters, and the alert and the action line was 4 hours apart. WHO later modified, and the latent phase was removed in the year 2000. Active phase was started at 4 centimeters, and the descent of head, fetal head, was recorded by abdominal examination rather than the pelvic examination. Further, WHO wanted to revise this partogram, And they thought, why this revision? Because of the modified WHO partogram, they thought it was an over-medicalization of childbirth with the alert and the action line, and which led to the increased cesarean section rates. And moreover, there was a debate on what is normal progress of labor, because it, actually it varied from patient to patient. And they also questioned the alert and the action lines, its importance. So therefore, the WHO labor care guide was developed to support the implementation of WHO recommendation on intrapartum care for a positive childbirth experience, which was published in 2018. And this, we came up with, they came up with the WHO labor care guide in the year 2020. It is a tool that aims to support good quality evidence-based respectful care during labor and childbirth, irrespective of the setting and level of health care for the positive childbirth experience. Somehow it didn't gain much, people were not talking much about it in the year 2020 when it came up, because maybe because of the COVID, because all were talking about COVID only and COVID. So what are the guiding principles of the WHO LCG? Labor and childbirth should be individualized and woman-centered, not obstetrician-centered. And no interventions without a clear medical indication should take place. Only interventions that serve an immediate purpose and proven to be beneficial should be promoted. And a clear objective that a positive childbirth experience for woman, newborn and a family should be at the forefront of labor and childbirth care at all the time. So it is a complete package, it is just not the woman or the laboring patient, it includes the newborn and her family. So the aim of this labor care guide is, it guides the health personnel for monitoring and documentation of the well-being of the woman and their babies and the progress of labor. And it offers supportive care throughout the labor. It also supports serves to support the audit and quality improvement of the labor management. It also assists the health personnel to promptly identify, address emerging labor complications by providing refreshed thresholds for labor observation that are intended to trigger reflection and specific actions if an abnormal labor observation is identified. So for whom this WHO labor care guide you can implement, that is for women and the babies during labor and birth, regardless of their risk status, both in high risk as well as low risk, though it initially was designed to be used in the low risk pregnancies only. High risk pregnancy may require additional and specialized care like this. So now, what is progress of first stage of labor? See, now according to the WHO LCG, the active labor starts at 5 centimeters, because they thought labor may not naturally accelerate until the cervical dilatation of 5 centimeters. Therefore, interventions to accelerate labor and childbirth before this threshold is not recommended, provided the fetal and the maternal conditions are reassuring. Cervical dilatation rate slower than 1 centimeter after 5 centimeters alone should not be a routine indication for obstetric intervention. Now regarding the second stage of labor, in primaries you can wait up to 3 hours, in multis up to 2 hours, provided both the condition of the mother and the baby is reassuring. So now with this background, I will come to the WHO labor care guide and how it is different from the modified WHO which we were using earlier. It has got 7 sections, 1 to 7, which includes the identifying information, labor characteristics of the on admission, then 2, supportive care. This is a new introduction to this labor care guide. Then you have the care of the baby here, then care of the mother, then labor progress is there here, the cervical dilatation and descent. Then you have the medication part and the shared decision making. So this is the new this part is the new introduction, the supportive care and the shared decision making. So now I will come section by section. Section 1, the identifying information, and here you should you should enter the information obtained when the active labor of 5 centimeters diagnosis is confirmed. That is the name, parity, labor onset, that is whether it is spontaneous or induced, and that when she has started the active stage of labor, that is the date. Is also important to mention the time. Ruptured membranes, date and time, and risk factors, what risk factors she is having should be entered here. Then from section 2 to 7, it is monitoring to action section. This is for the systematic and consistent application of the labor care guide. The health providers are encouraged to use the following approach. That is, first assess the patient, examine it properly, record the findings, check whether it is within the threshold for labor progress, and then plan the further course of action accordingly. So now, after the identifying information, you have the time axis, which is the horizontal axis here, and the first row is the actual time of each observation, and the second row, it is the number of hours that has lapsed during the course of labor, and then you have the vertical alert for determination of any deviation from normal. So this is the vertical alert which is given here, and the values are written here. So it is very easy for any health assistant to compare this threshold and see whether it is falling within the normal progress of labor. So now coming to the second section of the labor care guide, that is supportive care. How to complete this section? See, in this section you have 4 components. That is the companionship, which is they thought it is important. Then you have the pain relief. Then she should be taking during labor oral fluids, because she's laboring and that is a stress, and she should not get dehydrated, so oral fluids are allowed. And posture, she should be preferably ambulatory, that is mobile. And there are certain abbreviations that has to be entered in this partogram, in this labor care guide. That is, N is for no, S is for yes. So if she had on admission this Mary Jane Williams, this is taken from the WHO labor care guide manual, so therefore the name is as such. She is para 2. Spontaneous onset of labor was there. She was admitted on 6th July 2020, and at 5 a.m. she had a history of stillbirth, and she had anemia as high risk factors. So at 6 a.m. she had no companion and there was no pain relief, and that was actually she wanted both. And oral fluids, yes, she was taking oral fluids and she was ambulatory. After 1 hour, that is 7, she had a companion, pain relief, as well as oral fluids, and she went into supine position. So wherever this alert, this is the alert column, and wherever this is an alert, you have to circle in red so that it is rectified. So next section comes the care of the baby. In the care of the baby, you have the fetal heart rate that has to be entered. It has to be well between 110 and 160. And you have to even mention whether she has decelerations. So N is for normal deceleration, V is for variable deceleration, and the alert here is late deceleration amniotic fluid. If the amniotic fluid is clear, C, meconium, M, and B for blood stain, and 3+ meconium is an alert. Then fetal position, posterior and the transverse position is an alert, so it is circled, P is circled here, and caput and molding, if it is 3+ and more, it is an alert. Then coming to the care of the baby, you have to look for the pulse, blood pressure, temperature, and urine. You have to see all this, and the alerts are given in this column. Her pulse should be between 80 and 120, the systolic blood pressure between 90 and 140, and if it is equal to more than 90, it is an alert, and if the temperature is between the, if it is less than 35, it is an alert, and equal to more than 37.5 is an alert. And in this particular patient, which was I was mentioning, everything was within the threshold, and even after 4 hours of her labor, it is within the threshold. So now, so far from section 1 to 4, we see that everything is going as per, okay, in between, after 4 hours of her laboring, she, again that companion went away, and this is how one should plot. And then pain relief was not there. She again demanded for pain relief, and oral fluid she was taking. She went again into supine position after 2 hours when she was ambulatory. And from posterior position, she has now come to transverse position. That is okay. The progress is okay. Others were within the threshold values. So far everything is going on fine for this patient. So we wait. And then we come to the section 5, which is the labor progress. Here, see, this is a very important section which I must tell. It includes cervical dilatation and descent. See, for cervical dilatation, there's an alert value. It says that the active labor starts at 5. Of course, if she remains for in the active stage of labor, that is 5 centimeters. If she is 5 centimeters for more or equal to 6 hours, this is an alert. At 6 centimeters, if she is equal to more, she remains for more than 5 hours or equal to 5 hours, in this stage only it is an alert. So similarly, up to 9 centimeters, the alert values are given, and this is the descent. This descent column has no alert. So after 4 hours, she becomes 8 centimeters. After say about 8 hours, she is fully dilated, and then P is for pushing, and she starts pushing. So the good thing about the labor care guide is that even the second stage of labor is included here. You have to monitor her throughout the second stage also. So suppose in case after 6 hours, here the alert comes. After 6 hours also she remains at 5 centimeters, this an alert, and you circle it in red, and then you accordingly plan as to what is to be done regarding this patient. The descent, here of course the dilatation is marked as X and the descent is marked as O. Descent is also favorable, and it has come, head is not palpable during the second stage of labor. So the progress is within the threshold. So now coming to the 6th section, it is the medication. Whatever medication you are giving, whether it is oxytocin, other medicines or IV fluids, it has to be mentioned. The name of the medication has to be, the dose has to be mentioned, the route of administration has to be written, and if at all IV fluids are given, you have to mention that also. And for this particular patient, everything is N. That means nothing. She is not on oxytocin, taking no medication, as well as she is not on any IV fluids. So therefore, the progress, you have just allow this patient to go into its normal progress of labor. Now coming to the last section, that is the shared decision making. And this, it has assessment part. This is the record, the overall assessment, and any additional findings not previously documented but important for labor monitoring. So that is written, and then the plan. Planning means, for example, continuation of routine, whether it is going to be continuation of routine monitoring or prescription of any diagnostic test, or whether you want to augment the labor or you want to do some procedure like ARM. And definitely, whatever you are doing, you have to take into consideration that the woman should be involved in the discussions and be allowed to make informed decisions. So here in this particular patient, everything, pain, whatever was the red circle, within the red circle, you have provided all those. That is the assessment, and the plan was that you should allow her for normal progress of labor, and finally she delivers normally, normally, and then a live baby. So this is the overall, the projection of the WHO labor care guide till she gives birth at around 1:45 p.m. and this is how it looks. So to summarize, it is a replacement of old WHO partogram. LCG is evidence-based. It is an A4 size paper tool used to monitor and document labor events, can be used in any setup from third world countries to first world countries, from primary to tertiary care center, either in low risk or high risk woman, in primary or multi, from first stage to third stage of labor. The major change is that the active labor starts here at 5 centimeters. There is no alert and action line. Instead of the alert line, clear alerts, reference threshold have been given for each labor event observation. And the presumption that the cervix dilates at the rate of 1 centimeter per hour in primary and 1.5 in multi is given up,
and a more realistic approach, that is 12 hours for primary and 10 hours for multi, are given after 5 centimeters of dilatation. Second stage is 3 hours in primary, 2 hours multi, provided all, there's no feto-maternal distress. And 2 sections have been added, that is the supportive care and the shared decision making. This is all for a positive and respectful labor childbirth experience by the mother, child and a family, which is the fundamental right of a woman and her baby. Of special mention, I must tell that this WHO labor care guide, we conducted a trial, the WHO conducted a trial, and 4 hospitals in Karnataka state was included, and our center was also included in the study, wherein the effects of WHO labor care guide on cesarean section was studied, which was a pragmatic step-based cluster randomized pilot trial. And what we found is the primary outcome was the cesarean section rate among women in Robson's group 1. And we had a total of 26,331 participants, and we saw that there was a reduction in the primary outcome, which was observed from 45.2% to 39.7% when we implemented this WHO labor care guide. And thank you all for your patient hearing.
Thank you, Dr. Suman Gaddi, for elaborating on the value of WHO recommended labor care guide. So it is now replaced partogram. All of us are basically lazy with respect to data. So I think we need to stress on our faculty in medical colleges to see to it their postgraduates do this, so that all of us follow better protocol. So now we come to the end of not only this session, end of KSOGA 2025, before we all meet at Gulbarga. Thank you.
Thank you, ma'am, for sharing your expertise on the topic. We also thank all our chairpersons for chairing the session. We request all the dignitaries to please collect the token of gratitude at the gratitude desk. With this, we conclude the scientific session of the conference. Thank you, esteemed speakers, for the enlightening series of presentations. Each session today offered a unique perspective, from surgical innovation and diagnostic precision to holistic labor care, reminding us that continuous learning is the cornerstone of better patient outcomes. Thank you.
Now we have a short lucky draw contest organized by Tulsi Corporation. May I now request our organizing secretary, Dr. Jyoti Mahesh ma'am, to please come onto the dais, please, to pick the chits. May I now welcome owner of Tulsi Corporation, Anil Dhariwal sir, to distribute gifts and prizes. First prize, Krupa, SN Medical College, Bagalkot. Dr. Krupa, first prize winner. First lucky dip winner. First prize winner has a bumper prize. 2 nights and 3 days stay at Goa. I request ma'am to pick the next chit, please. Dr. Geeta, Shivamogga. Dr. Geeta, Sushil Kumar.
Dr. Geeta Sushil Kumar. She is left? Okay. Yeah. Sama? Pick them? Yeah. Yes. I request madam to collect on her behalf, please. Ma'am, you can collect, please. They will collect. She's colleague of madam. Dr. Shilpa Patil, BG Bellur. MSOBG. Shilpa Patil. Dr. Shilpa Patil. Dr. Shilpa Patil. Total 10. Total 10. 10. Dr. Suprita Rangaswamy, Cloud9. Dr. Suprita. Next chit, please, ma'am. I call our president to pick up the chit. Please come, sir. Yes, sir, please. Please, sir. Sir, Nagar, sir. Please. Ma'am, Bunny, ma'am. Welcome to the dais, sir.
Dr. Rekha Gurumurthy. I request my most dear sister, Dr. Kasturi, to take up the next.
I'll pick up your name. Please, someone collect it.
Dr. Divya Gupta, HSK Hospital, Bagalkot. Not there.
Hanmukha ma'am, Nagaraj sir, please come, sir. Ma'am, Bunny ma'am. Hanmukha ma'am, please. Next chit, please, ma'am.
Nagar sir, one second.
Sujata Tumkur. Tumkur.
Dr. Sujata Tiptur.
Sunita. Oh, Dancing Queen. Tumkur.
What a coincidence. Durga also picked up Guru Rekha and Madam picked up both Tumkur. Okay, all three of them.
ರಾಕೇಶ್ ಭಕ್ತ ಅಲ್ಲ ಭಕ್ತನ್ನ
ಅಲ್ಲ ರಾಣಿ ಯಾವ್ದು ನೋಡಿದ್ವಿ
ಅಲ್ಲ ರಾಕೇಶ್ ಭಕ್ತನ್ನ
ಬಂಟಿ ಡಾಕ್ಟರ್ ಬಂಟಿ
ಅಲ್ಲ ಬಂಟಿ ಇಲ್ಲ ರವಾ ಸಾಹೇಬ್
ರಮಾ ಸಾಹೇಬ್
ಬಂಟಿ
ರಮಾ ಸಾಹೇಬ್ ಬಂಟಿ
Who?
Sir, phone number है she's there. Oh, okay.
We thank Tulsi Corporation for this session. You want to take? Thank you, Anil Dhariwal, sir. Now over to our colleagues, Dr. Namrata and Dr. Sucheta, for the next valedictory function.
Sir wants to give first. Who is there?
Dr. Shilpa Patil to kindly collect the prize, please. Shilpa Patil. Dr. Shilpa Patil.